आप लोग आ जाओ, इधर चले जाओ। Excuse me, we are nine. Whatever you speak, report. Yes, we are just shortly starting our CMA training.
A very good morning to all the esteemed delegates. We'll be starting our session shortly at around 8:30. Thank you so much.
ये भाई नहीं कुछ नहीं पूजा कर रहे फास्ट हो सकते हो जाना अभी तो 5 बजे का टाइम जाए 4:30 बजे मात्र पहुँच जाया नहीं क्या 1 घंटे में चला que 500 रुपये की कॉम्प्लीट
चर्च कहाँ पे? सुल्तानपुर ग्राम होटल से आगे। No one's there.
Good morning, esteemed delegates, respected chairpersons, and HODs and faculties. A very warm welcome to each one of you. I am Dr. Lokesh Postgraduate, Junior Resident, on behalf of Department of Anatomy, Snmc, Agra. Privileged to serve as your host for today's academic event. As we embark on this enriching journey through insightful discussions, expert lectures, and collaborative learning, I am humbled to stand before this esteemed gathering. With guidance from our respective mentors and the wholehearted support of our department, I look forward to making today's proceedings smooth, engaging, and memorable. Let us together celebrate knowledge, innovation, and the spirit of academic excellence.
A very good morning and heartfelt welcome to all on behalf of Department of Anatomy. I am Dr. Yatika Parekh, postgraduate junior resident from Department of Anatomy, Sarojini Naidu Medical College, Agra. And I am honored to serve as your host for today's CME on imaging anatomy, anatomical and clinical applications of imaging modalities in diagnosing abdominal ailments. As we unite today to explore the convergence of anatomical understanding and radiological precision, I look forward to navigating you through the sessions, discussions, and expert presentations that promise to enrich our clinical perspectives. With the inspiration and support from our mentors, I extend my sincere thanks to the organizing team and all the participants for making this academic event a grand occasion. Let us together make this CME a memorable experience of knowledge and collaboration. Esteemed delegates, respected chairpersons, and honored HODs and faculties, welcome to first session of our CME. We are privileged to commence today's program with an insightful lecture that will set the tone for the rest of the academic proceedings. It is my great pleasure to introduce our eminent speaker for this session, Dr. Kamal Bhardwaj sir, Professor at FS Medical College, Agra, and a renowned expert in field of anatomy. Dr. Kamal Bhardwaj sir's remarkable contribution to anatomical education and imaging practices have earned him a great respect across the medical community and country. Today he will be enlightening us with a lecture titled Introduction to Abdomen, a foundational session that promises to enhance our understanding of clinical applications of imaging modalities in diagnosing abdominal ailments. Before we begin, allow me to introduce chairpersons for the session, Dr. Anita Rawat ma'am and Dr. Anshugupta ma'am, who will guide our discussion with their expertise. Please join me in welcoming Dr. Kamal Bhagwan sir with a big round of applause as I invite him to the podium to deliver his lecture.
Very good morning to all of you, all the offline delegates as well as the online delegates who are assembled here to enrich themselves with this enlightening knowledge of anatomy and especially the abdominal anatomy that we will be taking all throughout the day. The first topic that has been decided upon is the introduction to the abdomen. Now, just to start with the introduction. Now, why have we kept this introduction to abdomen? The simple logical reason is that this session, this CME has been planned for all the learners. Now, for that learning, even I am a learner and let's start the learning session. So, I hope everybody can see this picture. This is quite a different picture from the routine lectures that we take. Just keep on guessing for a few moments, for a few seconds that why have I put this. So, while you are guessing, till that time I'll just try to illustrate this. There is a sea, vast ocean, which is almost fulfilling all the screen. And in the corner of the screen, you can see a young boy just staring at this vast stretch of ocean.
Oh,
So, where can we put ourselves? Inside this boat? Inside the ocean? Or outside the ocean? I hope all the students sitting at the back, they must be thinking themselves to be in the boat. Well, it's not true. You are all, in fact, we all are here. We all are in this role of this boy. We are staring at the ocean, and what's the ocean then? What's the ocean? Any comments from the back? The ocean is the deep sea of knowledge of the abdomen. When I in fact started my journey of anatomy, this was the first presentation that had been, or this was the first topic that had been allotted to me for a seminar. It was a difficult topic for me as a postgraduate, and the same thing was happening with me. I was standing just on the seashore and trying to explore the vastness of this ocean of abdomen. So, but today's CME, I hope I will try to recapitulate those concepts for you. Let's start the topic. Now, whenever we try to understand abdomen, we always try to understand it in different formulations. You know, these are not mathematical formulations, but these are medical or anatomical formulations. These can be said in the forms of planes, divisions, and then the arrangement of structures. Now, as a layman, arrangement of structures can be understood as a layman also, but we need to understand them before understanding the planes and the divisions. Before going to the arrangement of the structures in the abdomen, we need to understand what is the planes and divisions. Why do we always divide the abdomen into planes and divisions? The obvious reason is because I had, in the previous slide only, I had told you that the abdomen is a vast ocean. And whenever you try to explore the ocean, you always divide it into various water bodies in the forms of, continental water bodies and the country-wide water bodies. The same way we need to divide the abdomen also. So it is such a vast sea of knowledge. So we take this in the opportunity for planes and also the divisions. So let's start. So this diagram this has been the favorite diagram of the students. So the abdomen stretches right from the mid-thoracic region. You can see from the mid-thoracic region down into the pelvis. Right, all this red colored sea of anatomy is the abdomen. So where are the stretches from the abdomen? It is in the lower half of the trunk, below the diaphragm, right? And it's divided again into two parts. The upper part, the abdomen proper. This is from the diaphragm to the pelvic rim. Now here is the pelvic rim stretching from the sacral hiatus into the suprapubic region, right? And this is the abdomen proper. Below this, the blue colored region is the pelvic proper or the pelvic inlet, right? So, whenever we talk about the abdomen, we as anatomists or as medical fraternity, we always try to look into the abdomen proper when we talk about the abdomen. In fact, when you will be in the imaging fields, many of you might go into the imaging field, then also the pelvis will be a different entity than the abdomen. But for study purposes, we can take it together also, abdomen proper as well as the lower abdomen. Now, starting with the planes of the anatomical, the abdominal landmarks. So the first planes that we discuss are the horizontal planes. Horizontal planes, as you can see in this backdrop image also, these are the horizontal planes. Now, basically we have two planes, but multiple planes can have been or in fact can be divided upon. So, the concept of dividing the abdomen into horizontal planes is, we take some, the basic landmarks that we take are the bony landmarks. We take some bony landmarks. Now, how many bones, in fact, I have a habit of asking the students many a times, but this is the CME, so we won't go into the asking sessions. We basically take the bony landmarks as the lumbar vertebrae. So you all must be knowing by now that there are 5 lumbar vertebrae, L1 to L5. So based upon those lumbar vertebrae, we take the horizontal planes, right? Always, whenever we take any plane, we try to take it, the reference point should be any bony landmark, whether it's a vertical landmark or it's a horizontal landmark or an oblique landmark, wherever. In radiology also, the landmarks are the bony landmarks initially. Then further on we can extend the landmarks. But basic landmarks, always remember these are the bony landmarks. So the first plane that we discussed, which is the most important one also, the transpyloric plane. This was described by Addison. Again a famous diagram from the books. Now this blue line is the transpyloric plane. This is the most important landmark because it's covering the gross abdomen in itself. This is the most deepest, in fact the most, you can say, elaborate landmark in the abdomen. So the transpyloric plane. Let's see the transpyloric plane details. It's indicated by a line which encircles the body midway between the. Now there are 2 types of nomenclatures for the transpyloric plane. The first one indicates from the suprasternal notch up to the symphysis pubis. From the suprasternal notch, everybody must be knowing the jugular notch or the suprasternal notch, which is just on the top of the mediastinum sternum. From here up to the suprapubic symphysis, here, symphysis pubis. This is a whole vertical line, and if we go into the midway of this line, we can get into the transpyloric plane. Another way or another layman way of approaching the transpyloric plane is the midway between the ciphisternal joint and the umbilicus, right? So there are 2 parts or the 2 nomenclatural ways to describe the transpyloric plane. The first one, the extended one, is the suprasternal notch and the symphysis pubis midline, and another one we will shortly discuss is between the midway of xiphoid process and the umbilicus. Right? So let's go ahead with the transpyloric plane. Now it passes through the pylorus of the stomach. This has been used as a nomenclature for the transpyloric plane. We call it transpyloric because it's going through the pylorus of the stomach. Now which bony landmark? Again, because I have already told you that the bony landmarks are the ones which are needed for the basic understanding or the basic definition of any horizontal plane or vertical plane. So this passes to the L1 at the lower border of L1, right? Now again, when we look further into this, we will understand that it meets the costal margins also at the tips of the 9th costal cartilages. So here we can see the 9th costal cartilages. At the tips of the 9th costal cartilages, this transpyloric plane intersects. Now let's look into the slight details of the transpyloric plane. If we move towards the right from the transpyloric plane in the midline, we will encounter the structures from midline towards the right side, medial right, and then towards the lateral right. So the first structure that we pass through is the first part of the duodenum. The first part of the duodenum can be very easily approached in the transpyloric plane, and this is a very, very important, you can say a favorite viva voce question for the examiners. All of these points that I will be discussing, these are very important for the UGs as well as the PGs. The first part of the duodenum can be approached just medial to the transparent plane in the midline. Then the head of the pancreas comes next. In fact, the head of the pancreas, the upper part of the head of the pancreas, to be more precise. Then we have the ninth costal cartilage moving further lateralwards, and then the fundus of the gallbladder. Now the gallbladder in radiological practice, we see that the gallbladder is not a fixed organ. It's variable, but the extended or the distended gallbladder fundus generally comes to lie in the lateral aspect of the transpyloric plane towards the right side. And lastly, the hilum of the right kidney. These are the very important landmarks towards the right side. Now let's see the landmarks towards the left side from the midline laterally. The first landmark is the neck of the pancreas. The second landmark is the hilum of the left kidney. Now these are the landmarks that you need to understand as the PGs as well as the UGs. Please make it a point that this lecture at least makes you understand this basic. This line that we have discussed just now, the transpyloric plane, is the most important aspect of this lecture. Now let's move ahead. The second plane in the horizontal series of demarcation is the transtubercular plane. This is again a bony landmark which is passing through the lumbar vertebra fifth body, right? Corresponds to a line around the trunk level at the iliac tuberculus. Again, it cuts from the front of the L5 somewhere. It's again a variable thing. Some books say it's in the body of the L5, some books would say it is the upper border of L5. But anyhow, it cuts near the upper border of the L5. The third plane, again, now this plane, the subcostal plane, this is again dividing the abdomen into an upper portion and the lower portion. Subcostal, everybody can understand by the name also. Subcostal means the inferior aspect of the costal cartilage. Now this is very often used in abdominal topography. Whenever we are marking the surface anatomies, especially in the UGs and the PGs, so this plane is used quite often. It corresponds to a line with the lowest limits of the 10th costal cartilages. Now, can I ask you why the 10th costal cartilage is, why not the 11th and 12th? I hope you might be having an answer to this. Because the 11th and the 12th rays are, it cuts to the upper border of L3. Now again see, I had told you, whenever we are trying to demarcate a plane, we need to take any bony landmark. Now here the bony landmark is the upper border of the third lumbar vertebra. The structure or the organs that it passes through is the third part of the duodenum. So the first part of the duodenum has got a landmark and the third part has got a landmark. And the lower border of the, I told you the head of the pancreas, upper border was demarcated by the transpyloric plane, and the lower border of the head of the pancreas is demarcated by a subcostal. Now this often displaces also the transpyloric plane in descriptions of the, I told you, because when we are in clinical practice or in routine practice also in teaching, so we tend to take it as a basic plane because it's a very easily demarkable plane, the subcostal plane. Everybody can see the subcostal. A differently named plane, the supracristal plane, just I thought it was worth mentioning. The supracristal plane passes from the transverse line from the highest points of the iliac crest. Now this is again a very favorite question for the UGs, those who try to give or have some good illustrations towards their viva. Then this question is a favorite question from the examiners. Then where is the supracristal plane? Or you can ask in the other way also, where is the highest point of iliac crest located? So it is located at the fourth lumbar vertebra. Now, all through this talk you might have noticed that I have talked about L1, I have talked about L3, I have talked about L4 finally and the L5. So which is left? The second lumbar vertebra is left, which is having no demarkable plane as such. So whenever we try to approach the second lumbar vertebra, which is again a very favorite approaching point for the spinal needle people holders who are the anesthetists who give spinal anesthesia. L2 vertebra is a favorite landmark, but it's basically deep embedded inside the dimple of the lower back. So we try to take L1 or L3, and in between L1 and L3 we just imagine that there is L2, but there is no such plane to demarcate L2, right? Let's go ahead. Now in this series, now we already discussed the horizontal planes. Now let's quickly go into the vertical planes. Vertical planes, obviously, these are the mid-clavicular or the mammary planes. right and left. Vertical lines passing through the midways from the anterior superior iliac spines and the symphysis pubis, which is the mid-clavicle or the memory line. So these are not very important planes as far as the abdominal description are concerned. But when we go into the quadrant abdomen, the ninth quadrant anatomy, then these planes come into role. Now these two vertical planes and horizontal planes that we have discussed in elaboration, these divide the abdomen into 9 regions. The 3 regions on the right, 3 regions on the left, and 3 in the midline. Now this was a picture that I just loved because it's showing the transtubercular plane structures, and these are the most important structures as far as the ultrasound anatomy is concerned. We basically love these places, the right and the left kidneys, pancreas and the duodenum. Now these are the regions that we will be going into details now. The right hypochondriac, left hypochondriac, epigastrium. Now, as UGs, you need to understand or you need to recapitulate or try to understand that these are the places that we will be asking you more often than frequently, right? Let's go into the details of each region. The first region is the right hypochondriac region. Now these will be geometrical descriptions, very easy. Just if you can basically dissect the abdomen into 9 regions, then these will be very easy to understand. The right hypochondrium is the right upward region. Basically when we do ultrasound or when we go into the radiological anatomy, we don't go into right hypochondria. We will say it's the right upper right region, right? So as layman also you can very easily take your fingers into the right, above the costal subcostal marks, you take your fingers and you reach the right hypochondrium. Why do we say hypochondrium? Because it's just below the costal cartilage of the right. Then the right lumbar region, it's just subcostally. Right lumbar region is just subcostally. Then you can say in Hindi there is a kamar region. जो हमारी कमर होती है वो right lumbar region में. So this is lateral to the right lateral plane and below the transpyloric, above the transtubercular plane. In this region is the right lumbar, and just below this is the right iliac region. Same way we go into the left side, left hypochondriac, left lumbar and the left iliac region. Lastly in the midline, epigastric region, umbilical region and the hypogastric region. Again the same lines which are demarcating the planes, these are used as demarcating the 9 abdominal quadrants. Now let's look into the next part of the lecture, that is the basic elements that we encounter into the abdomen. So first of all, again, whenever we start any topic, we always go into the skeletal parts. So let's look into the skeleton of the abdomen. Now, basically, as academicians, we need to know that the L1 to L5 are the basic vertebrae of the abdomen. But because we are also understanding the right and the left hypochondriac regions, as well as the right and left iliac regions, so we need to consider the other bony landmarks also. So abdomen starts from the T11 and goes up to the S1, right? And in the lateral parts, we have the right iliac bones. In the midline, we have the lumbar vertebrae. So these are the bony landmarks that we always look for whenever we are going into the abdomen. Finally, we go into the arrangement of structures. Now, already we have discussed about the geometrical concepts of the abdomen. Now let's a basic sneak peek into the abdominal arrangement of structures. So let's first go posteriorly to the posterior abdominal wall, because here we will encounter all those structures which are generally overlooked by clinicians. These are academically important. Rarely we find diseases apart from some tumors or some accidental cases. But posterior abdominal wall structures are not frequently used in the routine clinical practice. Let's see them. Let's see the muscles. So the top of the muscle, the top muscle in the abdomen which we will encounter will be the diaphragm. From there the abdomen will start. Psoas major is the next to come. Psoas major, everybody knows. There is a very favorite pathology located at this region of psoas. Whenever we pulmonologists try to see the psoas, we try to see if there is any collection or not, because psoas abscess is a very frequent entity in India, especially tuberculosis. Then quadratus lumborum, the muscle which is in the posterior region, and lastly the iliacus. Then after the muscles, we will now blood vessels are again. The finer details of the blood vessels are not encountered in this lecture. We will go into the major blood vessels. These are the abdominal aorta and its branches. I hope everybody is familiar with the basic branches of the abdominal aorta and as well as the iliac, which is inferior vena. Then the nerves, again, are theoretical importance topic. The first nerve, again from the top, the subcostal nerve. Iliohypogastric and ilioinguinal nerves, the femoral nerve, the natofemoral, and lastly the obturator nerve. Last but not the least, the sympathetic chain of nerves. Now let's come into your favorite topic, that these are the abdominal organs. Now again, looking from the posterior wall onwards towards the front, we will encounter the structures. I'll be asking you a basic question. The kidneys and the ureters are encountered most posteriorly. Wherever I hope you have had a dissection of abdomen very frequently, and in those dissections you will encounter the kidneys most posteriorly. I hope you must have seen them in the dissections also. The ureters again accompanying the kidneys, the suprarenal glands again, the retroperitoneal structures, all of the pancreas except for the tail are retroperitoneal, and lastly the duodenum, second and third parts are retroperitoneal. Now this diagram illustrates all these retroperitoneal organs which are located in the posterior abdominal wall. Now we won't go into the details why they become retroperitoneal and how to define them. But these are the organs that you need to understand in your brains, that looking for pathology in the posterior abdominal wall can also encounter the pathologies in the organs in the posterior abdominal wall, which are the retroperitoneal organs. Now let's go ahead of these organs. Now, disposition of the organs in the abdomen is the next topic. Now, when we look into the disposition, we need to understand now as a layman that if I am percussing or I am palpating the abdomen, which organs I am palpating. Now, these are important for the clinicians. If I am palpating just below the right hypochondrium, which organ can I have access to? If I am palpating just below the left hypochondrium or inside the left hypochondrium, which organ should I access? The clinical topic is next topic to be, Dr. Shikhi ma'am will take the topic. But before going into the clinical topic, let's see the disposition of the abdominal organs as a layman. The first organs which are most important, again are the liver and the gallbladder. Just right subcostal plane, you release the right subcostal plane, insert the insinuator fingers and you release the liver, the inferior border of the liver. Then, just medial to the inferior border, we have the stomach. Now, stomach and the liver, as a layman, are connected to each other by this lesser omentum. The lesser omentum is a sac of peritoneum, everybody must be knowing this, and this is connecting the stomach to the liver. Then, more left side towards we have the spleen. The bigger and lesser omentums are encountered at the top. Whenever we are dissecting the abdomen, the first structures that we need to understand or we see immediately after dissecting the abdominal wall are the greater omentum. As we go deeper inside the predisposition of organs, we will encounter the various other parts of the small intestines. Now, small intestines, the first part that we have discussed already is the duodenum, which was located more geometrically within the planes of the abdomen, that was the transvertebral plane and the subcostal plane. The rest of the small intestines are predisposed more or less cavewards. You can say there are two parts of the small intestine, the jejunum and the ileum. The ileum towards the right iliac region and the jejunum towards the umbilical region and the left hypochondrium. So these are the basic predispositions of the jejunum and ileum. No fixed landmarks can be asserted towards these regions because these are quite vast organs of the abdomen. Next in the predisposition, we see the large intestines. The large intestines again can be discussed in quite a detail, but not for this topic, as we are into the abdominal introduction only. So the large intestines have got the various parts that we can as clinicians or as anatomists, we can just percuss the abdomen or palpate the abdomen and see. The cecum and the appendix towards the right iliac fossa, the ascending transverse and descending colons, and the pelvic colon towards the left iliac fossa. Rectum in the midline, nobody can palpate it, obviously. So this was a small talk for the introduction. Thank you.
What a truly enriching session that was. Dr. Kamal Wadla sir has provided us with an engaging and comprehensive overview of abdominal anatomy, laying the groundwork of good diagnostic mechanism and clinical applications. On behalf of every present, I extend Dr. Kamal Wadla sir for his insightful presentation. It is now my privilege to invite the chairperson of this session, Dr. Vibhuti Ma'am, for a formal felicitation of distinguished speaker. Welcome, Dr. Kamal Wadla sir. I now take the pleasure of inviting Dr. Pune to kindly come forward and
मेरे पीछे से दिखता है
Great pleasure to introduce the speaker for our second session of the day at 2025 CME on imaging anatomy. We are diving deeper into the foundational knowledge that underpins our understanding of abdominal diagnostics. Our speaker for the session is Dr. Shikhi Ma'am, HOD and Professor at ASMS Firozabad, and a renowned expert in anatomical studies. Dr. Garg's extensive contribution to medical education and her expertise in abdominal anatomy have made her a distinguished voice in the field. She has done her MBBS and MD from SC Medical College, Agra. Today, she will share her insights on basics of abdominal anatomy, a concise purview, a topic that will provide us with essential knowledge to enhance our clinical applications of imaging modalities in diagnosing abdominal ailments. Before we begin, allow me to introduce the chairpersons for this session, Dr. Anjali Gupta ma'am and Dr. Chetna Thakur ma'am, who will guide our discussions with their expertise and ensure a productive exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Shikhi ma'am to the podium to deliver her lecture.
Good morning to all my dear students, all the dignitaries present here, and dear faculty of Medical College of Snmc, Agra, outside. Today my topic is basics of abdominal anatomy, a concise purview. You know, abdomen is so vast that you cannot cover this topic in one single topic. So I just try to cover the main points which might help you in clinical diagnosis and main things to handle. Okay? Abdominal anatomy. Basic learning objectives today are understanding basic distance of the abdomen, identify the major abdominal organs and their positions, correlate surface anatomy with internal structures, and appreciate the clinical relevance in abdominal examination. I feel the two first topic has been well covered by Dr. Kamal. So our focus will be on the further topics. Division of abdomen, we have already read the 4 quadrants, we have read about the 9 divisions. And so the clinical significance of the quadrant is that when you know what structure is lying in one quadrant, you can assess कि अगर इस quadrant में pathology है, pain है, इसका मतलब यहाँ पर ये problem होगी. जैसे right upper quadrant है, वहाँ पर आपका liver lie कर रहा है, gallbladder lie कर रहा है, आपका stomach का part lie कर रहा है, तो it can be a problem of hepatitis, it can be cholecystitis, it can be peptic ulcer. अगर हम राइट लोअर क्वाड्रेंट में आते हैं तो वहाँ के स्ट्रक्चर जो है आपके आपका असेंडिंग कोलॉन है, आपका सीगम है, योर गॉट अपेंडिक्स एंड मोस्ट कॉमन लंग अगर राइट लोअर क्वाड्रेंट में प्रॉब्लम आती है दैट इज अपेंडिकुलर लंप और एपेंडिसाइटिस, है ना। फिर हम जाते हैं लेफ्ट लोअर क्वाड्रेंट में, तो वहां पर आपको आपने पढ़ा कि जो स्ट्रक्चर्स हैं वो आपके कोलॉन है, देन यू हैव गॉट योर फेलोपियन ट्यूब, यू हैव गॉट ओवरीज, है ना। उसमें यू हैव गॉट प्रॉब्लम जो आ सकती है, अगर यहाँ प्रॉब्लम है, इट कैन बी कोलाइटिस, कैपिलाइटिस, इट कैन बी यूरिट्रिक कोलिक ऑल्सो। अगर ट्यूमर है तो हो सकती है, बेनिक इन्फ्लेमेटरी डिजीज भी हो सकती है ना। और लेफ्ट अपर क्वाड्रेंट में यू नो इट इज स्प्लीन है, एंड यू हैव गॉट spleen या what major part of stomach या what the pancreas, so problem related to these structures will be there, right? Now the key features of the abdomen are like wall. Abdominal wall, you know, it consists of 7 layers, starting from your outer level. Skin, fine. Then below skin we have got 2 layers of superficial fascia, a fatty layer that's the camper fascia, and deep to that is the scarpa fascia or the deep membrane. And then you have got 3 muscles, external oblique, internal oblique, and you have got the transverse abdominis. Below the transverse abdominis, as you penetrate deeper, you have got the fascia transversalis. And below fascia transversalis, you have got the extraperitoneal tissue, the root segregated tissue, and finally you have got the peritoneum that is covering the inner aspect of the abdominal cavity. Fine? And if you see here in this diagram, the external oblique muscle that is turning itself, rolling itself on its lower border, forming the inguinal ligament, and this is forming the floor of the inguinal canal. So in the lower part of your abdominal region, you have got the inguinal canal that crosses the spermatic cord in the case of males and cowlicks in the case of females. If you see this diagram, this is basically a section. See, here it is the external oblique muscle, the fibers are directed downwards and forwards. This is internal oblique, the fibers are directed upwards and forwards. Then this is the transverse abdominis, the fibers are straight. And then you can see on both sides you have got a vertical strap muscle, that is the rectus abdominis. And this rectus abdominis is basically covered by the joining of the athletic fibers of 3 muscles, external oblique, internal oblique, and the transverse abdominis. And if you see, these rectus abdominis are having tendinous intersections which is dividing this strap-like muscle into 5 vertical sections. And if you have heard 6 packs, देखो अगर 6 packs लोग अपना जो बॉडी दिखाते हैं 6 पैक्स बहुत शो करते हैं, तो बेसिकली दीज आर द सेम मसल्स। उसमें 3 पैक बहुत परमानेंट हो जाते हैं, नीचे के लोअर पैक से ज्यादा परमानेंट नहीं, राइट। और लोअर रीजन में यू हैव गॉट हियर, यू हैव गॉट एंडियोस्टिबियल स्पाइन, एंड स्ट्रेचिंग फ्रॉम द एंडियोस्टिबियल स्पाइन इज द inguinal ligament, the forward ligament that is going to the pubic ligament. Fine, here you see this is the external oblique muscle that appears which is turned. The lower end is turned inward to form the inguinal ligament stretching from the anterior spine to the pubic tubercle, and this is forming the floor of the inguinal canal. See, this is the pubic tubercle. It is a very important point when you are concerning the abdomen, because this point, अगर आप patient hernia का सफर कर रहा है, you see this portion is the gap in the external oblique muscle aponeurosis. If a person is having a hernia and you have to make out whether it is an inguinal hernia coming through this inguinal canal, or if you see here, this is the femoral region in the upper part of thigh. This is the femoral artery, femoral vein, and this is the femoral vein. So if you have to decide whether it is the femoral hernia or the inguinal hernia, you have to see this tubercle, and if the hernia is lying superior medial to the tubercle, it is inguinal hernia. And if it is lying inferior lateral to it, this is the femoral hernia. So this inguinal region is very important. It is region in the groin. Here you see this canal, femoral ring is basically not transmitting anything, it is basically a part of thigh, but it's important. But here in the lower part of the abdomen, this inguinal canal is basically giving passage to the spermatic cord. Because you know that testis has to descend from the abdomen to the scrotum in order to survive, right? So this is giving passage to spermatic cord in the case of and the case of female it is a round ligament of uterus. Fine. So the hernia that is occurring through this is the inguinal hernia, and the indirect inguinal hernia अगर इसके medial होता है तो wall के through आता है, that's the direct inguinal hernia. So the haploid pattern. Fine. Then we come to the another key feature after the wall, that's the peritoneum. Peritoneum basically it is a serous membrane that is covering the abdominal organs. It has got two layers. It has got a parietal layer and it has got a visceral layer. Parietal layer, you see this, the red one is the parietal layer. Parietal layer, it is, and this visceral layer, it is basically investing all the organs of the abdominal cavity. So the space between the parietal layer and the visceral layer is known as the peritoneal cavity. And the potential space मतलब कि ये space वैसे नहीं होती है, पर अगर कोई fluid भर जाए, कोई pus भर जाए, तब वो it becomes prominent. So this parietal layer, you see this lining, above it lying the under surface of diaphragm. ठीक है? Under surface of diaphragm है और इसकी जो nerve supply होती है, it is same nerve supply as the diaphragm. So it is pain sensitive. क्योंकि visceral वाली जो है, इसकी autonomic nerve supply होती है, it is not pain sensitive. Fine? अब ये parietal peritoneum जब cover करती है, anterior aspect of abdomen, it is the inner aspect of the anti-abdominal wall, this is the parietal peritoneum. And lower down it is covering the superficial aspect of the pelvic diaphragm. Then posterior aspect पे it is on the anterior aspect of the posterior wall of the abdomen. If you see this lining, parietal, यहाँ जो parietal peritoneum है, it is supplied by the same nerves as the abdominal muscle. That means lower 6 intercostal muscles, subcostal muscle, plus your lumbar nerve. So what is happening? अगर कोई पैथोलॉजी होती है पेरिटोनियम के अंदर, तो ये parietal peritoneum इरिटेट होगी और इसकी जो नर्व सप्लाई है सेम है एब्डोमिनल मसल की, जो वॉल की मसल का उसकी सेम सप्लाई है. तो व्हाट विल हैपन? पेरिटोनिटिस के केसेस में देयर विल बी अ टेंडरनेस, देयर विल बी मसल स्पाज्म हो जाएगा, क्योंकि बिकॉज ऑफ द इन्वॉल्वमेंट ऑफ द parietal peritoneum गेटिंग इन्वॉल्व, क्योंकि वही सेम नर्व सप्लाई है, तो देयर विल बी टेंडरनेस ओवर दिस रीजन, एंटी एब्डोमिनल वॉल पे टेंडरनेस मिलेगी. और आपके parietal peritoneum अब कोई भी फ्लूइड या कुछ भी इकट्ठा होता है ऊपर के लेवल पे, जो डायफ्राम को स्टिमुलेट कर सकता है. आई मीन दैट मींस दिस इज parietal peritoneum is covering the under surface of diaphragm. नर्व सप्लाई क्या है? पेनिक नर्व है, जो भी डायफ्राम की है. तो अगर कोई पस या फ्लूइड यहाँ पर इकट्ठा होगा, दैट विल कॉज द पेन इन द शोल्डर रीजन. We'll explain the revert pain होता है, basically just explain it. Before that we come to complete the peritoneum. अब structures formed by the peritoneum, it is forming the peritoneal folds. Fine. If you see the peritoneal folds, जो fold cover करते हैं stomach को, उनको बोलते हैं omentum. उनकी यहाँ पर lesser omentum, यानी यहाँ पर the greater omentum. Fine. जो fold cover करते हैं colon को, वो कहलाते हैं mesocolon. इसमें transverse mesocolon है, sigmoid mesocolon है, and mesoappendix. Fine. जो fold mesenteric, जो fold one dimension cover करता है, that is known as the mesentery. Fine. And it is also forming the peritoneal ligament, falciform ligament, right and left triangular ligament, and it is forming the correlate and other ligaments also. अब यहाँ देखिए greater omentum है, that is starting from the stomach, greater curvature, and then it will fold on itself and it will go back and it will attach the transverse ligament. और इसके attachment की वजह से what happens कि इस parietal cavity divided into two compartments, suprapubic compartment and infrapubic compartment. With this infrapubic compartment again is further divided by the root of the mesentery into a left compartment, left infrapubic and right infrapubic compartment. और साइड में दोनों के साइड में you have the parapubic vessels. Now what is the relation between viscera and the peritoneum? कुछ हिस्सा है जो टोटली पेरिटोनियम से कवर्ड होती है, दैट इज कंप्लीटली सराउंडेड बाय द पेरिटोनियम. इसमें आपकी स्टमक आती है, फर्स्ट पार्ट ऑफ पेरिटोनियम आता है, ड्यूडेनम, इलियम, सीकम, वर्मिफॉर्म, अपेंडिक्स, ट्रांसवर्स, सिग्मॉइड कोलन, स्प्लीन है, ओवरी है, यूट्राइन. फाइन. सो दिस इज बेसिकली इंट्रापेरिटोनियल स्ट्रक्चर जो टोटली कवर्ड है बाय पेरिटोनियम. अब कुछ स्ट्रक्चर होते हैं जो दैट इज लाइंग बिहाइंड द पेरिटोनियम. ये आपकी सेक्शन है, इसमें आपकी रेक्टस एब्डोमिनस है, ये आपकी मसल्स हैं, ये आपकी एब्डोमिनल कैविटी है, जिसको parietal peritoneum पूरी कवर कर रही है. और जो भी ऑर्गन्स है उसमें दैट इज कवर्ड बाय द वेस्टिबुलर। इसके पीछे क्या सी दिस इज द रेट्रोपेरिटोनियल स्ट्रक्चर। अब इसमें रेट्रोपेरिटोनियल स्ट्रक्चर आर दो स्ट्रक्चर दैट आर लाइंग बिहाइंड द पेरिटोनियम। उसमें दो तरह के स्ट्रक्चर होते हैं, प्राइमरी जो पहले से ही जब स्टार्टिंग से ही पेरिटोनियम के पीछे है, और कुछ जो सेकेंडरी पेरिटोनियल होते हैं जो बाय द प्रोसेस ऑफ जाइगोसिस पहले तो इंट्रापेरिटोनियल थे बट बाय द प्रोसेस ऑफ जाइगोसिस दे बिकम सेकेंडरी दे बिकम रेट्रोपेरिटोनियल। तो आपके प्राइमरी रेट्रोपेरिटोनियल में क्या है, किडनी है, सुप्रापीनियल ग्लैंड है, या वो द यूरिटर या वो इंट्रावेना केवा, यू हैव गॉट द एओर्टा एंड रेक्टम का लोअर वन थर्ड पार्ट। फिर आपकी सेकेंडरी रेट्रोपेरिटोनियल स्ट्रक्चर्स कौन से होते हैं, ये आपकी इंटरपेरिटोनियल था, बिकॉज ऑफ द प्रोसेस ऑफ रोटेशन this falls down the posterior column wall, this fusion of visceral and the parietal layer, and so it becomes retroperitoneal. This is the process of zygosis. इसमें क्या है, duodenum का second third part, pancreas except tail, ascending colon, descending colon, and the upper part of the leg. These are the secondary retroperitoneal structures. Now the major abdominal organs that are lying in the abdominal cavity concerning the GIT. You have got the foregut, you have got the midgut and the height. कैसे आपने डिवाइड किया कि जो आपका बाइल डक्ट की ओपनिंग जहाँ पर थी दैट पोर्शन, उससे पहले का पोर्शन दैट द फोरगट, उसके बाद का पोर्शन टिल द proximal 2/3 of transverse colon and distal 1/3 of the transverse colon, वहाँ का आपका midgut, और फिर बाकी का distal 1/3 of transverse colon, descending colon, then sigmoid colon here and the rectum and upper part of anal। ये आपके आ गया हाइट के। अब इसमें बेसिकली क्या है, ये इंपॉर्टेंट क्यों है, क्योंकि नर्व सप्लाई जो है वो डिफर करती है, और नर्व सप्लाई डिफर करती है देन इट द आर्टियल सप्लाई भी डिफर करती है। एंड यू मस्ट हैव रेड अबाउट द रोटेशन ऑफ द गट, यू मस्ट हैव रेड कि आपका जो आपका फोरगट इज सप्लाइड बाय द सिलिक ट्रंक, मिडगट सप्लाइड बाय द स्मूथ and highlighted by the inflammatory। इसी तरह आपकी नर्व सप्लाई भी जो है वो डिफर कर रही है। अब इसका कॉन्सेप्ट क्या है, सर्वाइकल रिफर्ड पेन का। व्हाट इज हैपनिंग, यू नो विस्कस स्ट्रक्चर जो है वो अगर आप कट करोगे तो वो पेन नहीं फील होगा, पर अगर डिस्टेंड होंगे, स्पाज्म होगा या इसीलिया होगा तो देन द पर्सन फील्स द सेंसेशन ऑफ पेन। वो कहाँ होगी, क्योंकि आपको सिंपली नर्व सप्लाई तो नहीं आ रही है। व्हाट हैपेंस, जो फाइबर्स जहाँ से इसको सिंपलिक सप्लाई मिली है किस डिस्टर्ब हो, वो फाइबर्स जहाँ पर जिस स्पाइनल सेगमेंट से ये स्पाइनल एरिया से स्टार्ट होते हैं, वहीं से जो फाइबर्स पर्टिकुलर स्किन या एब्डोमिनल वॉल पे जा रहे हैं वहाँ पर इनका पेन फील। तो जो फोरगट का जो पेन है दैट इज स्प्रेड इन द एपिगैस्ट्रिक, मिडगट का अम्लाइकल रीजन में, और आपका जो हाइंडगट का इज द प्यूबिक रीजन। इसी तरह एग्जांपल हम देखते हैं, अपेंडिक्स का एग्जांपल लीजिए। अपेंडिक्स इज अ पार्ट ऑफ मिडगट एंड इट इज लाइंग इन द राइट लेग होता, बट स्टार्टिंग में जो पेन होता है दैट इज स्प्रेड एट द लेवल ऑफ टी10, क्योंकि अम्लाइकस का जो लेवल है वो L3 L4 है, बट जो नर्व सप्लाई है उसकी वो टी10 स्पाइनल सेगमेंट से है, और टी10 स्पाइनल सेगमेंट से ही सिंपलिक फाइबर्स आपके अपेंडिक्स जा रहे हैं। तो अपेंडिकुलर लंग हुआ या अपेंडिसाइटिस हुई तो दैट पेन विल बी फेल्ट एट योर अम्लाइकस, राइट। फिर आपका रेट्रोपेरिटोनियल ऑर्गन जैसे है, किडनी है, पेंक्रियास है, दैट पेन इज रेफर्ड टू द बैक पेन। आपने पढ़ा होगा ना, कोई आपने सुना होगा कि पेंक्रियाटाइटिस है, पर्सन बताता है कि मुझे पेन पीछे की तरफ जा रहा है, क्यों, बिकॉज इट इज रेट्रोपेरिटोनियल एंड द जो आप इट इज कंसर्न विद द स्पाइन एंड द पोस्टेड डॉन वॉल स्ट्रक्चर, इसलिए पेन पीछे की तरफ फील होगा। इरिटेशन ऑफ डायफ्राम पेरिटोनियम, इरिटेशन डायफ्राम होगी तो राइट पेरिटोनियम इरिटेट हुई, अगर राइट साइड का डायफ्राम राइट साइड में हो रहा है तो पेन कहाँ फील होगा, दैट विल बी ऑन द राइट शोल्डर। क्यों, व्हाट हैपेंस, ये नर्व सप्लाई है, फ्रेनिक नर्व की जो रूट वैल्यू है दैट इज योर C3 C4 है ना, C2 C3 C4, और आपकी सुप्राक्लेविकल नर्व की क्या रूट वैल्यू है दैट इज सप्लाइंग योर शोल्डर, इज अगेन C2 3 and 4, राइट, मेनली C4 बेसिकली। So, अगर इरिटेशन हुई डायफ्राम की, the pain will be perceived at the level of the shoulder। अगर राइट डायफ्राम इरिटेट हो रहा है that भी राइट शोल्डर पे, और लेफ्ट डायफ्राम इरिटेट हो रहा है तो it will be on the left shoulder, right? this is a diagram to show you the rubber paint, the very important concept. अगर आप यहाँ देखिए, ये आपका this is yellow से show किया, this is the peptic ulcer. Basically perforate करता है, तो what happens? It gives the pain to the right shoulder, right? And the pain also passes. जब perforation हो गया, कंटेंट बाहर निकल से आते हैं, so they passes to the paracolic gutter to the right leg fossa. तो बाद में आपको पेन नीचे की तरफ leg fossa में फील होगा, तो स्टार्टिंग में जो पेन फील होगा, that will be होगा right shoulder. सेम में गॉल ब्लैडर का पेन है, गॉल ब्लैडर में अगर कोई there is inflammation of the gall bladder, the sensation will transfer through the phrenic nerve to and to be felt at the level of right shoulder. और साथ में इसकी जो सप्लाई है, एट फ्रॉम द गवर्नमेंट सप्लाई कहाँ से? T7 के लेवल से. So the pain will radiate to the back and this will be felt at the inferior angle of scapula. क्योंकि T7 के लेवल पे inferior angle of scapula लाई करता है और नर्व सप्लाई है गॉलब्लैडर की, इट इज T7. राइट? इसी तरह से आप यहाँ देखिए, अपेंडिसाइटिस हुई, अपेंडिकल लंप हुआ. अपेंडिसाइटिस का फेज सबसे पहले फील होता है, दैट इज एट द लेवल ऑफ tonsillitis, दैट इज स्पाइनल सेगमेंट T10, और जो सप्लाई होती है उसकी सप्लाई होती है आपकी अपेंडिक्स की T10 होती है. बाद में जब इट बिकम्स वेरी मच इन्फ्लेम्ड एंड इट ऑल की कंटेंट्स बाहर निकल जाते हैं, तब आपको द पेन इज फेल्ट एट द बैक बर्निंग पॉइंट, फाइन, और यू कैन से इन द राइट लाइक, फाइन. देन आपकी किडनी है, किडनी का जो पेन है इट इज एट द बैक सर्जन, तो आपको लॉइन, आपकी लॉइन में पहले फील होगा बैक से, एंड इट विल कम फॉरवर्ड and be felt on the middle aspect of thigh, on the testicles and the hypogastria. Spleen है, spleen very important structure. अगर spleen का किसी भी point of view से splenomegaly हुई, rupture हुआ, तो जो blood निकलेगा that will irritate the left dome of diaphragm. And so when it irritates the left dome of diaphragm, you will have the pain sensation on the left shoulder blade, and that is known as a hair attack. Fine? So अब ये आपका बेसिकली these are the points for the, अगर आपको यहाँ पर पेन फील हो रहा है hypogastria bilaterally, it can be because of the saprophylaxis or the peritoneum, right? So inflamed parietal peritoneum, pericarditis is basically inflammation of the peritoneum, and the inflamed parietal peritoneum is extremely sensitive to stretching, and when you apply the pressure on the abdominal wall with one finger and then you leave it, there is rebound tenderness. क्यों? क्योंकि आपने जैसी वॉल को टच किया और छोड़ा, तो जो आपका ऑर्गन है इन्फ्लेम है, दैट विल गेट इरिटेटेड एंड द पेन विल स्टार्ट. देन पेरिटोनियल एडेशंस हो जाते हैं एसोसिएटेड विद पेरिटोनाइटिस, एंड पोस्ट सर्जिकल इट्स वेरी कॉमन, गायनेकोलॉजिकल और जनरल सर्जरी में दोनों में ही है. 90% पेशेंट्स के अंदर मेजर एब्डोमिनल सर्जरी में एडेशंस बनते हैं, और पेल्विक सर्जरी जो फीमेल अंडरगो करती है उनमें 100% के अंदर होते हैं. इसके स्मॉल बाउल ऑब्स्ट्रक्शन होता है, इनफर्टिलिटी भी होती है, क्रॉनिक एब्डोमिनल एंड पेल्विक पेन रहता है, एंड डिफिकल्ट रीऑपरेटिव सर्जरी आर द मोस्ट कॉमन कॉन्सिक्वेंसेस ऑफ दिस पेरिटोनियल एडेशन. नाउ another aspect is the vascular supply of the abdomen. Vascular supply, abdominal aorta and its branches, मेरी 3 ब्रांचेस हैं इसकी, सेलेक्ट ट्रंक है, सुपरवेंट्रिक है एंड इंफीरियर वेंट्रिकल. जब हम ब्लड की सप्लाई की बात करते हैं तो पोर्टल वेन को हम नहीं छोड़ सकते हैं, पोर्टल वेन है सिस्टमिक कनेक्शन. Or portal vein and systemic connections, you know the portal vein is basically supplying the 80% of the blood to the liver, and it is having the nutrients in it because it is taking the blood from the GIT and it giving it to the liver, and it has got at many sites it has got the portal cable communication, that is the portal blood is communicating with the vehicle blood, intercable blood, and those sites are, you know, a very important site is the lower end of esophagus. Then it has got basically it is beneath the peritoneal posterior abdominal wall. Then at the lower part of anal canal. Then at the umbilicus, and there are certain there are many places where the portal system is communicating with the cable system or the systemic circulation. And if the blood pressure is raised of the portal venous circulation, what happens, these sites जहाँ भी आपका कम्युनिकेशन हो रहा है, वो साइट्स जो हैं they become enlarged, और इसकी वजह से what happens, एक बहुत कॉमन प्रॉब्लम है esophageal varices, क्योंकि आपके लोअर पार्ट ऑफ esophagus में आपका
लेफ्ट गैस्ट्रिक वेन यानी डायग्नोज वेन से कम्युनिकेट कर रही है, तो जब पोर्टल वीनस हाइपरटेंशन होगा तो these varices or the veins will become dilated and clotted and known as posterior varices, or then the person at times what happens, these dilated veins rupture and the person have the bleeding from the mouth or hematosis. and अगर किसी को hematosis हो रही है, it shows कि person की लाइफ का एंड स्टार्ट हो चुका है, ठीक है। तो कॉन्सिक्वेंसेस क्या है, एसाइटिस होती है पोर्टल हाइपरटेंशन से, एटलीस्ट पूरा एब्डोमेन जो है आपका फ्लूइड से फिल हो गया, उसकी जो वेरिसेस होगी, गैस्ट्रोइंटेस्टाइनल ब्लीडिंग होगी, स्प्लीनोमेगाली होगी, कैपिट मेडिसन वेरी इंपॉर्टेंट थिंग। अगर आप देखिए यहाँ पर आपकी एम्ब्लाइकल में पहला एम्ब्लाइकल वेन और पार्ट ऑफ द पोर्टल वेन, और ऊपर से जो आपकी आ रही है ये एपिगैस्ट्रिक वेन आ रही है और लैटरल थोरैसिक वेन आ रही है, साइड से लंबर वेन एंड देन एम्ब्लाइकल वेन आ रही है, नीचे से सुपरफिशियल एपिगैस्ट्रिक वेन आ रही है, राइट। तो यहाँ पर क्या हुआ, जिसका पोर्टल हाइपरटेंशन हुआ तो यूजुअली जो ब्लड है वो लिवर को जा रहा था, पर क्योंकि अब पोर्टल हाइपरटेंशन हो गया तो वो लिवर उसको एक्सेप्ट नहीं करेगा, इट विल सेंड इट इनटू द ऑल द सिस्टमिक वेन, सो दे विल ऑल फिल अप एंड दिस अपीयरेंस नोन एज द कैपिट मेडिसन, क्योंकि इट लाइक द स्पोक ऑफ व्हील, ये सारी जितनी वेन्स है वो सब डायल्यूट हो जाएंगे, क्योंकि जो ब्लड इस तरह लाइक वेन्स की वजह से लिवर में जा रहा था, centrifuges are the blood flow becomes centrifugal, but it is with the blood all the way. So all the way from the umbilicus will get dilated and known as the caput medicine. Right? इसके अलावा anatomical varices and thrombocytopenia is also the effect of direct increase of portal blood pressure. Now we come to the cervix, landmark of the abdomen, very important ones we have covered. ये आपका zigzag joint है. Then from the zigzag joint to the pubic symphysis, you have got a fibrous raphe produced by the deconstruction of the epidermic fibers of the external oblique, and the transverse appearance is linea alba, right? Then इसके just पास आप देख सकते हैं ये rectus abdominis muscle है और ये transverse, आप can see the intersection. इसके just lateral there is a semilunar line that is showing the lateral border of the rectus abdominis. Then you have got, this is the umbilicus, very important point. तो adults में इतना काम नहीं है, but it is very important from the anatomical point of view, logical point of view, as well as from your clinical point of view. Just see to that. Then you have got the external oblique muscle fibers. Here in the lower part you have got the inguinal canal that is having the somatic cord in the case of males, and the rounding inflection in the case of females. McBurney point, we draw a line from the umbilicus to the endoscopic spine, and few lateral 1/3 and 2/3 के junction पे this is the McBurney point. This is the point that is utilized for giving the incision, redirect incision when you have to cut upon the on the dissection. Umbilicus basically is a very important as from the aspect of the anatomy, clinical and logical point. Umbilical, it has no functions in the human, adult human, but the important for understanding the abdominal anatomy and certain medical constitution. Umbilicus is acting as a watershed line. It is lying at the level of L3, L4 vertebrae, but the spinal segment that is supplying is the T10. Fine. So umbilical watershed lines का मतलब ये है कि जो वीनस सप्लाई है, वीनस ब्लड है और लिम्फेटिक ड्रेनेज है, अम्बिलिकस के ऊपर वो ऊपर की तरफ ड्रेन करेगा, दैट मींस इट इज, और जो नीचे है दैट विल गो टुवर्ड्स द ग्रोथ. तो जैसे लिम्फेटिक्स है अबव द अम्बिलिकस दे गो टू द एंटीएक्सिलरी लिम्फ नोड, और नीचे की तरफ दे गो टू द सुपरफिशियल इन्हाइलर लिम्फ नोड. ठीक है, इसी तरह से आपकी जो वेन्स है अबव द अम्बिलिकस दे गो थ्रू द लैटरल थोरैसिक वेन टू द एक्सिलरी वेन, और नीचे की तरफ सुपरफिशियल एपिगैस्ट्रिक वेन से दे गो टू द ग्रेट सर्कुलेशन वेन. इंपॉर्टेंट इसकी इसलिए भी है कि आजकल बहुत नया फैशन चला है ना, यू गर्ल्स को क्या है, दे आर हैविंग द अम्बिलिकस के अराउंड, वो छोटे छोटे दे आर वेयरिंग दैट ज्वेलरी पहनने का शौक चढ़ा है, और वो अगर वो किसी ऐसे पर्सन से जाके अपनी ज्वेलरी पहनती है जिसने प्रिकॉशंस नहीं ली, स्टेराइड कंडीशंस में नहीं किया, तो व्हाट हैपेंस, द फीमेल गोज एंड आफ्टर अ मंथ शी कम्स विद अ swollen lymph nodes in the axilla
as well as the social inguinal lymph nodes, and the pain and inflammation is there. So if you know this, आपको ये कॉन्सेप्ट मालूम है तो आपको मालूम होगा कि अम्लाइकस को पियर्स करने की वजह से उसकी ये एक्सोरियल lymph nodes और आपकी social inguinal lymph nodes enlarge हो गए, right? Then the umbilicus is basically the meeting point of cardiovascular system, genitourinary system, and the gastrointestinal system. If you see the hotbed of immunology, and surgical incisions should never cross this umbilicus. ये आपकी gut है और ये आपका vitreointestinal duct जो कनेक्ट कर रहा है आपको umbilicus, इससे umbilicus से कनेक्ट कर रहा है आपका vitreointestinal duct, ठीक है? ये आपका ब्लैडर है और ब्लैडर का जो टिप है दैट इज यूरेकस, व्हिच इज एलेंडॉइड, बेसिकली यूरेकस बनाता है और यूरेकस बेसिकली ऑब्लिटरेट हो जाता है, ठीक है? तो दिस इज यूरेकस दैट गेट ऑब्लिटरेटेड और उसके अलावा यू हैव गॉट द अम्बिलिकल वेव एंड अम्बिलिकल आर्ट. सो इट्स द मीटिंग पॉइंट ऑफ द ऑल द थ्री सिस्टम. अब क्या हुआ कि आपका जो विट्रोइंटेस्टाइनल डक्ट था वो पूरा खत्म नहीं हुआ. अगर का प्रॉक्सिमल पार्ट रह जाता है that shows it is known as the Michel's diagram. It's a very common problem. और अगर ये पूरा duct रह जाता है तो what happens? You have fecal matter at your umbilicus because the patent vitreointestinal duct is communicating with your intestine. So there is fecal matter at your umbilicus because of this persistence of the vitreointestinal duct. और फिर आपका जो यूरिनरी ब्लैडर है वो यूरेकस ऑब्लिटरेट हो जाएगा. एलेंडॉइड यूरेकस बनाता है और यूरेकस ऑब्लिटरेट हो जाता है, मीडियम अम्बिलिकल लिक्विड बनाता है. पर अगर ये यूरेकस ऑब्लिटरेट नहीं हुआ तो व्हाट हैपेंस कि आपका यूरिनरी ब्लैडर से यूरिन आके अम्बिलिकस कर जाएगा. सो यू माइट हैव यूरिन प्रेजेंटेशन आल्सो एट द ब्लैडर. इफ यू नो द एम्ब्रियोलॉजी यू नो कि इसका मतलब उसका ब्लैडर का यूरेकस अभी ऑब्लिटरेट नहीं हुआ था, इसलिए यूरिन आपको अम्बिलिकस करेगा, राइट? Then clinical relevance, palpation of the abdomen, we'll go for that. Abdominal, just keep on. Palpation of the abdomen अगर करना है एक normal person के अंदर, usually soft and pliable, and आप inward और हर respiration के साथ it is moving inward and outward. और आप जब palpate करेंगे, आप right inguinal region से जाएंगे to left hypoglossal region में, और contour of the abdominal wall depends on the tone and the fat of the person. Findings आपको क्या मिल सकती है? Lungs and large organs such as liver, spleen, dilated veins, thin respiration. Dilated veins ये किससे मिलेगी? ये आपको कॉमन मिलती है साइटिस के अंदर, राइट? Abdominal obesity is a very leading cause जो प्रॉब्लम क्रिएट कर रही है. इससे बेसिकली द कंडीशन जिसमें abdominal fat और visceral fat रहा है excessively, it is gathering between the abdominal organs. And it is a significant health concern in India with prevalence rate of 40% in women and 12% in men. And the condition is known as pot belly, and this is also linked to increased risk of serious health problems like diabetes, type 2, heart disease, stroke and cancer. So it is, as you are becoming the budding doctor, आपको बहुत केयर करनी है अपने साथ वालों की, अपने पेरेंट्स की, कि आप और आपके साथ वाले मोटे नहीं हो, राइट? बिकॉज इट इज शोइंग दैट इज हैविंग अ ग्रेट प्रॉब्लम, सीरियस प्रॉब्लम. यूजुअली जो आपका एब्डोमेन होता है इट इज बेसिकली इट इज बाहर निकला हुआ होता है, बट एट टाइम इफ द पर्सन इज यूनिट इज हैविंग अ कंजाइटल डायफ्रेटिक इन्फ्लेटेड हर्निया, देन द एब्डोमेन बिकम्स स्केफॉइड विद द बोर्ड शेप. तो अगर एक बच्चे के अंदर स्केफॉइड या बोर्ड शेप एब्डोमेन है तो इट गोज टू डायग्नोज द कंजाइटल डायफ्रेटिक हर्निया. और अगर बड़े में है तो इट इज केस ऑफ मालन्यूट्रिशन, राइट? इवन बच्चों में भी मालन्यूट्रिशन होता है जब आपका पेट अंदर चलता है. Laboratory we have already talked about. It's just to show you since spleen rupture हुआ, spleen rupture से diaphragm irritate हुआ and it goes to your left shoulder. The left, and this sign, care sign, is very important even today when your all the modalities of the imaging have come, but still the clinician considers it's an important sign. आप हम पढ़ेंगे सारी modalities में देखेंगे. Then the abdominal surgical incisions, आपको basically आप जितने incisions देते हैं, the basic knowledge is that you give the incision according to Langer's line of cleavage. ये Langer's line जो आपकी छोटी लाइन होती है बॉडी के अंदर एब्डोमेन के ऊपर और हर जगह, जो क्लीवेज लाइन होती है इसमें जो कोलेजन होता है वो पैरेलल होता है डर्मिस के अंदर, इसलिए अगर आप इंसिजन दोगे तो वो इट विल जस्ट सेपरेट द फाइबर्स, है ना। तो मसल शुड बी स्प्लिट एंड शुड नॉट बी कट, क्योंकि अगर आपने कट करी तो नर्व डैमेज हो सकती है, तो मसल की पैरालिसिस हो सकती है। एंड इंसिजन शुड बी ऑलवेज गिवन अवे फ्रॉम द मसल। जो मेन इंसिजन जो हमारे आते हैं वो एक कॉकस इंसिजन होता है, सबकॉकल इंसिजन होता है जो हम देते हैं फर्स्ट स्टेप के अंदर। अपर और लोअर मिडलाइन इंसिजन होता है, ये बहुत अच्छा इंसिजन है फ्रॉम द पॉइंट ऑफ व्यू, क्योंकि ये ब्लडलेस होता है, क्योंकि लीनियर एल्वा को आप इंसिजन दे रहे हो। लीनियर एल्वा क्या है, एप्रोटिक फाइबर से बनी है। तो इंसिजन जो आप दोगे आप आराम से ऑपरेट कर सकते हो, पर हीलिंग इसमें अच्छी नहीं होती है। तो पैरामीडियल इंसिजन जो होते हैं जस्ट मिडलाइन के पास होते हैं, एंड दिस इज बेसिकली कटिंग द रेक्टस, राइट। ये बहुत अच्छे इंसिजन मेनली यही फॉलो होते थे पहले, पर अब गायनेकोलॉजी के अंदर दे आर टेकिंग द फेनेस्ट्रील और द ट्रांसवर्स इंसिजन। दिस इज कॉस्मेटिक पॉइंट ऑफ व्यू से अच्छे, क्योंकि जो फाइबर की डायरेक्शन होती है इट इज हॉरिजॉन्टल ओवर हियर, सो फेनेस्ट्रील इंसिजन इज गिवन below the umbilicus along the lateral line and the uterus and other parts जो भी आपको करना है देख लीजिएगा। और एक इंसिजन होता है दैट इज पैरारेक्टल। पैरारेक्टल इंसिजन इज वेरी बैड, क्योंकि इट इज अलोंग द लैटरल बॉर्डर ऑफ रेक्टस एब्डोमिनल, और जितनी भी नर्व हो रही है वो एंटर कर रही है आपकी लैटरल बॉर्डर से। जब आप लैटरल बॉर्डर ऑफ रेक्टस एब्डोमिनल में पैरारेक्टल इंसिजन दोगे दैट विल कॉज डैमेज टू नर्व, सो पैरारेक्टल इंसिजन इज नॉट गिवन। फिर आपका एक हमने पढ़ा था ग्रिड एंगल, like only point I told you, it is basically draw a line from the anterior cervical spine to the umbilicus. इसके middle tutor और lateral one-third के junction पे यहाँ पर there is a, अगर आप incision लेते हो perpendicular axis का grid iron incision given for like Burney point मिलाता है, like Burney incision और grid iron incision मिलाता है, ये this is for the appendix के removal, right? Then if you are observing the abdomen, तो आपको hernia को देखना ही है, you have to see, आप linear elbow पे देखोगे, अगर यहाँ पर कोई hernia हो रहा है जिसकी epigastric hernia है, इसमें usually fat होता है, umbilicus के region के ऊपर it can be hernia, it can be physiological hernia जो reduce भी होता है, right? और it can be तो या बट umbilical hernia जिसमें आप inguinal canal के थ्रू से जो निकल के आ रहा है inguinal hernia, और आपको याद करना है वही चीज, tubercle को देखना है, अगर उसके लैटरल है तो femoral है, और मिडिल है तो इट इज inguinal, राइट। इसके अलावा इंसिजन hernia भी होते हैं कि जो आपने इंसिजन दिया है अगर उसका स्कार प्रॉपर्ली नहीं बनता है उसके थ्रू जो hernia होता है दैट्स इंसिजन, राइट। देन परकशन एंड ऑस्कल्टेशन। नॉर्मल एब्डोमिनल परकशन में आपको क्या मिलेगा, आपको टिम्पैनी हॉलो ड्रम लाइक साउंड मिलेगी एयर फिल्ड स्ट्रक्चर में, जैसे स्टमक इंटेस्टाइन के अंदर है, और अगर लिवर स्टीम है तो आपको मफल्ड साउंड मिलेगी। ऑस्कल्टेशन में आपको नॉर्मल फाइंडिंग क्या है, आपको इंटरमिटेंट लो पिच गर्गलिंग साउंड मिलेगी आफ्टर एवरी 5 to 35 seconds. These sounds indicate a normal movement of food and liquid through the intestine. Additionally, no vascular bruise, rolling sound should be heard. अगर सुनाई पड़ रही है तो it indicates pathology. Summary is that कि abdominal anatomy को आपने segments में, regions में, quadrants में divide करने से easy हो गई है, and it is clinically vital. And understanding regions and organ positions aid diagnosis and integration with radiology, surgery and internal medicine over new dimension जो हम आज करने वाले हैं। And very thank you for patient learning, and I hope आप लोगों को कुछ मिला होगा। Thank you.
What a remarkable session we have just heard. Dr. Shiki Garg has truly enriched our understanding with this lecture on basic of abdominal anatomy. Success project. On behalf of every president, I extend heartfelt gratitude to Dr. Shiki Garg ma'am for her insightful presentation. We are deeply grateful for her contribution. This is now my privilege to invite the chairperson of this session, Dr. Chitra Thakur ma'am and Dr. Sanjeev Gupta ma'am, for a formal presentation of distinguished.
भाई पीछे आओ।
I now invite Dr. Veena ma'am and Dr. Bhavana ma'am kindly come forward and felicitate our respective chairpersons. Chairpersons Dr. Anjali and Dr. Chidna ma'am.
Thank you so much, ma'am. I request everyone to kindly proceed for the breakfast. We'll be having breakfast for next 20 minutes. Kindly proceed for the breakfast. Thank you. delighted to welcome the third session of the day. Following the enriching discussions in our previous sessions, we now turn our focus to a critical aspect of anatomical study that directly impacts the diagnostic accuracy. It is my great pleasure to introduce our speaker for this session, Dr. Anamika ma'am, professor at RML Lucknow and a distinguished expert in anatomical research. Dr. Anamika's extensive work in the field of anatomy, particularly her contributions to understanding development anomalies, has earned her widespread recognition in medical community. Today she will share her insights on developmental and anomalies of abdomen, a topic that promises to deepen our understanding of congenital variations. Before we begin, allow me to introduce the chairpersons for this session, Dr. Anshu Gupta ma'am and Dr. Virendra Kumar Nim sir, who will guide our discussion with their expertise and ensure a productive exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Anamika ma'am to deliver her lecture.
Good morning, all of you. Good morning, ma'am. Am I audible? Yes, ma'am. If I'm not going to use the mic, is it okay? Yes, ma'am. The mic is
So, good morning all of you. My dear sweet students, so well Parishi of this SA Medical College Agra. So, clapping to Corona. And all senior members, my dear friends, all sitting here. Topic of today's talk is the development and anomalies of abdomen. So you are first year students who must have been thorough with this embryology of abdomen. But this is a topic which will in future it will be of great help in your surgery department. So now moving forward, now this is a very vast topic. We will cover this topic under these following headings. That is the development and anomalies of abdomen. We will cover it under anterior abdominal wall development and anomalies related to it. Then gastrointestinal tract development and anomalies related to it, and so on. So moving forward, first of all, we will see anterior abdominal wall development. Now in a very short span of time, we have to move very quick. So as you all know, this developing embryo, the two types of folding occurs in the embryo. Fine. The embryonic disc, it undergoes folding, and these so we have got two types of folding. It occurs in two planes. First is this cephalocaudal folding, and then we have this lateral plane folding, which is known as lateral folding. Now, as you can see in this diagram, you can see this is XY axis, and if the folding when it takes place on this axis, then this is called cephalocaudal folding. So this is the cephalic end, this is the caudal end. Actually, my pointer is not working on this view. So this X is the cephalic end, this Y is the caudal end. Now you can see this is the embryonic disc, and it has got folded in this diagram. As a result, you can see the androgenic tissue which will lie on the this cephalic end, it will come to the ventral aspect. So now, please pay attention on this diagram. This is the embryonic disc. Now this is undergoing in this figure B, cephalocaudal folding. As a result, you can see this is the amniotic cavity, this is the yolk sac. Now in this section C, you can see this androgenic tissue, which in future is going to form the heart as well as the pericardial cavity. This is coming on the ventral or the anterior aspect of the growing embryo. Fine. And this endodermal tube is getting narrower and narrower, and this will form your future gut tube. And this is connected to this yolk finally through very narrow duct, that is the vitiligo. Fine. So now another folding is this lateral folding. Initial was cephalopodal folding and next is this lateral folding. You can see here in this lateral folding, on either side there will be the embryonic body cavity and then this will form your peritoneal cavity. Now we have anomalies related to it. So if you pay attention to this diagram, there are 3 points we can see anomalies. But try to understand, this part will form your anterior body wall. This will form your anterior thoracic wall. This will be anterior abdominal wall. So we have defects at 3 levels. First defect will be at this level, then another at this level, and third one is this level. So if we say that point A, B and C, then at the level of A, when there is defect in the development of anterior thoracic wall, this condition is known as ectopia cordis, as you can see in this red. That is the anterior thoracic wall developmental defect. Fine. And second is gastrocytosis, where there is defect in the development of this anterior abdominal wall. And third is your bladder or quadrant extrophy, where the defect is at still lower level. As you can see in this way. So these are the 3 anterior abdominal wall as well as anterior thoracic wall defects. Now coming to the gastrointestinal tract development as well as anomalies related to it. So first of all, to begin with, we should be very thorough with the derivatives of this gut tube. So this gut tube, as you can see, this yellow colored gut tube, this is divided into 3 parts. This is divided into 3 parts. That is the foregut, midgut and hindgut. So we can see the derivatives of gut tube. Now foregut. Foregut means the part of, this is the future outcome of this gut tube. Okay? Then foregut in future will form the floor of the mouth, tongue, pharynx, septal pouches, esophagus, stomach, proximal part of the duodenum up to duodenum is divided into 4 parts. Second part of duodenum, we have opening of major hepatohepatic duct. That is, there is the side of major duodenal papilla and below bladder is present. Before that, we have everything derived from foregut. And after that, and this, of course, this liver, pancreas, gallbladder, they all develop from your foregut. Then we have, these are the derivatives of midgut. So remaining part of the duodenum, after that we have jejunum, ileum, cecum, appendix, ascending colon, until right 2/3 of transverse colon. All this develop from the midgut. And then we have hindgut, that is the left 1/3 transverse colon, descending colon, sigmoid colon, rectum, and bladder urethra. They all develop from your hindgut. So now, the anterior most point of this, our tube, there we have buccopharyngeal membrane. This separates the stomatium from your foregut. Similarly, we have cloacal membrane at the posterior end, which separates this posterior from the cloaca. So now this diagram is very informative. Please pay attention, especially the UG parts. So this complete gut tube. And as a rule, कहीं पर भी develop होकर जाएगा, it will maintain its chief artery. That is, wherever the derivatives of foregut will go, they will always get their arterial supply from celiac trunk or its branches. Wherever the derivatives of midgut will go, again they will follow the same rule that they will get their arterial supply from superior mesenteric. Similarly, all the derivatives of hindgut, they all will receive their arterial supply from inferior mesenteric. Fine. So by this we can know the rule of this arterial supply is fixed. So you can see behind this foregut we have this abdominal aorta. They are giving the branches, three unpaired branch. This is the unpaired or ventral branch, celiac trunk, superior mesenteric and inferior mesenteric. Fine. So you can see all the derivatives. There are three branches of celiac trunk, that is the splenic, common hepatic and gastric. इस साइड में gastric, इस साइड में splenic and बीच में centrally कौन सी? इधर hepatic हो गई, इधर splenic. Centrally we have no. I'm asking about the branches of celiac trunk. Hepatic, splenic, बीच में gastric. So that is the thing in तीनों side में. We have three branches of celiac trunk and supplying all the derivatives of foregut. And similarly, superior mesenteric will get the derivatives here. So now, coming to development of foregut. सबसे पहले देखते हैं the first derivative in the abdomen, because my topic is to cover the development and anomalies of foregut. So first derivative is stomach. So you can see it is a fusiform dilatation of the foregut which will form your future stomach. Fine. Then first part of duodenum, second part of duodenum, clear presence of ampulla of Vater. So all will get its arterial supply from the branches of celiac trunk. Okay? So this is the development of stomach. And you can see you must have gone through this. Initially, when the stomach develops, it has dorsal border and ventral border. That is, it is like this. But development के बाद, because of the overgrowth of the dorsal border का overgrowth हो जाएगा and ventral border grows slowly. So it will move like this. So your ventral border will become right side. It will come to right side. That will be the form future will be the lesser curvature. And your dorsal border, it will come to lie on the left side and it will form the greater curvature. So you can see in this diagram, your this anterior border or ventral border will come to lie on the right side, whereas dorsal or posterior border will come to lie on the left hand side. And now coming to the development, and what will the arterial supply of stomach? Branch from the celiac trunk because it is a derivative of foregut. Now coming to the development of duodenum. Now this duodenum develops both from the foregut and midgut. So a part which develops from the foregut will get its arterial supply from branches of celiac trunk. That is superior pancreatic or duodenal artery. And there is a part which develops from midgut will get its arterial supply from branches of superior mesenteric. That will be inferior pancreatico-duodenal artery. Okay? And then you will see it. We are very quickly and covering each and every vista in very short. So now we will see development of liver. Development of liver. Again, I am repeating it again and again. It is derivative of foregut. So somehow it has to take its origin from the foregut. So, abhi I will show you my next diagram. You can see here from the foregut there is one hepatic bud is taking origin. Now this hepatic bud is moving towards septal transversal. because this our liver get developed from following sources. First is your endodermal liver bud, which is taking origin from foregut. Then we have septal translucidum, that will, what it will form will be your fibrous capsule, puffer cells and blood vessels of liver. And then we have decline of glycoproteins and ventral cells. So with these combined, they will form the liver. So you can see here, this is a liver bed moving towards septal translucidum to form the complete liver. And you can see very well in this diagram, this hepatic bud on the right side, it is giving one more bud, and that bud will future which will form the gallbladder, and this bud is known as cystic bud. So again, gallbladder develops from foregut, liver develops from foregut. So all these are derivatives of foregut. So you can see in all these diagrams. Now coming to so at the end, if you want to compile everything, so liver developed by this foregut se develop hoga, and then we have the cystic bud which will form your cystic gut and gallbladder. So these are the various anomalies of the gallbladder. Now suppose this is fundus of gallbladder, body, and this is neck, and then cystic gut. So if the fundus means there is one indentation, then this forms the pharyngeal capsule of gallbladder. These are the various anomalies, the structural defects. And sometimes at the neck we have the dilatation which is known as Hartmann's pouch. And sometimes we have this sessile gallbladder, means the duct is not developed. And at the end we have septic gallbladder. You can see this is the cut section. Inside we can see the septa they are present in the body of gallbladder. So now these are the various other anomalies of the extrahepatic biliary ducts. Sometimes there can be biliary atresia, sometimes accessory ducts may be present. Now coming to the development of pancreas. So we have covered liver, we have covered gallbladder development, start. Now coming to the development of pancreas. Now point to be noted here is pancreas develop from two buds. That is, we have endodermal ventral bud and dorsal. Here you can see in this diagram. Now, this is future stomach. This is your foregut tube. On dorsal side, we have the dorsal pancreatic bud shown in brown color, and ventral pancreatic bud shown in blue color. Now, this dorsal pancreatic bud, this will form your major portion of the this pancreas, and this ventral pancreatic bud will again come to this side, and so incomplete we have the pancreas lying in the sea of urine. Fine. So this brown color is the portion which has developed from the dorsal pancreatic bud, and blue colored portion is that portion which has developed from your ventral pancreatic bud, which is developed on the ventral aspect of foregut. So now both of them, they have came to one side, and as a result this future pancreas will be done. Your ventral pancreatic bud, this will form the lower portion of the pancreas, which is known as uncinate process. And both the buds, they will have separate duct system. Okay? And so we have the openings of the two sort of ducts, that is a major duodenal opening and minor duodenal opening. How this major one is formed? Or the major openings, major pancreatic duct is formed by the pancreatic duct which opens at ampulla of Vater. So everything above this is a derivative of foregut, and everything below this ampulla is a derivative of midgut. So all these UG students, please remember this. This is very frequently asked in your MCQs or in your Viva exams. How this main pancreatic duct is formed and how this accessory pancreatic duct is formed. So your main pancreatic duct is formed by the duct of the ventral pancreatic part plus distal part of the dorsal pancreatic. This is also known as duct of Wilson. And accessory is also known as duct of Sanders. Now there are various anomalies related to the development of pancreas. So first of all we have annular pancreas. Okay? You can see ventral part, it has to come to this side, and if it is not able to come to this side, this is somehow you can see this is blocking the uterus. So this condition is known as annular pancreas. So this ring of pancreatic tissue will be present on this second part of uterus. What will be the result? The result will be the continuity of the uterus will get affected. There will be some sort of uterine obstruction. And in radiograph we get the double bubble appearance of the uterus. So sometimes we have divided pancreas if there is failure in the fusion of the two buds of pancreas, dorsal and ventral. Alag-alag jagah hui hai, and if you are unable to fuse, then we get the condition of divided pancreas. Sometimes we have accessory pancreatic tissue, that is the pancreatic tissues will be present somewhere else. For example, there is a congenital anomaly which is known as medial scleroticulum. Sometimes this pancreatic tissue is present there. So this is known as accessory pancreatic tissue, and sometimes we have the inversion of pancreatic duct formation. Now coming to development of spleen, as you all can see, this diagram is quite informative. We have stomach in the central. This is ventral mesogastrium, and dorsally we have dorsal mesogastrium. In the ventral mesogastrium, liver develops, and they divide this ventral mesogastrium into two parts. Part lying between this liver and interior abdominal wall will be falciform ligament. Part lying between this liver and stomach will be lesser omentum. Lesser omentum is attached to which part of the liver? Porta hepatis. And another part is attached to the lesser curvature of the stomach. And posteriorly we have dorsal mesogastrium. And this dorsal mesogastrium develops spleen. So anomalies related. What is the arterial supply of spleen? Again, it is a derivative of foregut. So arterial supply will be from the celiac trunk, and the artery will be spherical. And the anomalies sometimes there can be accessory spleen, or because sometimes there can be lobulated spleen. Now development of midgut. So after opening of this ampulla of Vater, our midgut starts, and it receives all its arterial branches from the branches of superior mesenteric artery. So we have second part of uterus, third part of uterus, fourth part of uterus, jejunum, ileum, cecum, appendix, and ascending colon, right to a third of transverse colon. It all develops from the midgut. So blood supply will be superior mesenteric. Now you can see here, after this, that is the opening right here for liver banja. After this, everything is your midgut. Now due to presence of the superior mesenteric artery, our midgut root is divided into two portions, that is the prearterial and post-arterial segment. So now, these are the derivatives as I have enumerated earlier. So now, there is physiological umbilical hernia. ये अच्छे से समझ लेना. This is normal phenomena, so we are using the word physiological umbilical hernia. The midgut, which is in the form of a U shape, this herniates out through the primitive umbilical ridge. It will herniate out. अंदर जगह नहीं है abdominal cavity की, so it is outside. ठीक है? So this is physiological umbilical hernia and duration is 6 weeks to 10 weeks. Right? During this time, abhi loops are outside. Fine. Now, as a result of rapid growth expansion of liver, your abdominal cavity space becomes less. So midgut is not able to adjust, so it moves outside. But after 10th week, your abdominal cavity size increases and this midgut has to come inside. And if it is not able to come inside, it will remain outside, and this condition is known as omphalocele. Okay? So you can see reduction of physiological hernia occurs due to midgut rotation and increase in the abdominal size. Once abdominal size is increased after 10th week, this midgut root, which was lying outside, it will rotate, come back inside the abdominal cavity, again it will rotate, and then it will adjust itself in the abdominal cavity. So there occurs rotation of gut. Now, per point to be remembered is initial 90 degrees rotation will be outside the abdominal cavity, remaining 180 degrees that will be inside the abdominal cavity. So first 90 degrees rotation, this is along this superior mesenteric artery and this will be outside the abdominal cavity. As a result, prearterial segment, this will come on right side, and further 90 degrees and again 90 degrees rotation, incomplete 270 degrees anti-clockwise rotation will result on the cecum and appendix coming on the right iliac fossa. Because in such a short span of time, we can't explain all this rotation. Right? So here you can see this green colored portion is the prearterial segment of this midgut loop. Centrally we have superior mesenteric artery. Part behind that is the post-arterial segment. This prearterial, the initial 90 degrees rotation, prearterial will come to the right side and post-arterial, जो अभी cranial model है वो right and left हो जाए. Then it will again rotate by 180 degrees. So now coming to congenital anomalies of this midgut. So first of all we can see if there is no rotation, there can be incomplete rotation or there can be reverse rotation. So these are the anomalies related to rotational difference. Fine. And then we have the anomalies related to your anomalies of midgut. First is the Michael's diverticulum. This is a patent persistent. We have two feet. Try to remember patent persistent part of vitreointestinal duct. If that remains patent in your upper side, then this condition is known as Michael's diverticulum. Then we have ametocystoma, that is the benign cyst. You can see here there are three diagrams. If proximal part is patent, this becomes Michael's diverticulum. If in the center it is present, the cyst is present, this is known as Michelin cyst. And if it is communicating both exteriorly and interiorly, then this leads to the condition of Michelin fistula. Now, if, as I told you, if there is a persistent
then that clinical condition will be Mekiel's diverticulitis. And if there is persistent distal part of the intestinal duct defect, then this will lead to raspberry tube. Fine. Now what is this omphalocele or exomphalus? That is if suppose I have told you normal hernia is physiological hernia during the 6th to 10th week of your embryonic period. If that loop is unable to come inside, then this leads to a condition which is known as omphalocele. You can see here, this is a condition of omphalocele. This is due to failure of reduction of physiological hernia. And this is characteristically point here is this is always covered by the peritoneal line. And if this omphalocele, if it brings with it, along with it, there is some solid organ is present, then this is known as omphalocele major. And if no solid organs are present, then this is known as omphalocele minor. Now this is the difference between gastroschisis and this omphalocele. Gastroschisis is the developmental defect of the anterior abdominal wall. Now, these contents will be present outside the abdominal wall, but they will never be covered by the peritoneal line. But omphalocele is the result of non-correction of the physiological hernia which took place in the 6th to 10th week of life. It has to come inside, but it was not able to come inside. Then this leads to a condition called omphalocele. So you can see the difference between the two. We are never covered with this gastroschisis never covered with the peritoneal line. You can see here, again this is omphalocele. You can see the anterior abdominal wall, loop is lying outside, and this loop is covered by blue colored peritoneal lining. This is the major difference between gastroschisis and omphalocele. So now coming to development of hindwall. So these are the few structures which develop from your hindwall. That is the left one colon of the transverse colon, descending colon, sigmoid colon, rectum, and upper part of the anal cavity. So now coming to cloaca, how this urodactyl membrane is formed. Urodactyl membrane is formed, and this divides your cloaca into this thing. That is anteriorly we have groove. So this is the urodactyl membrane. It is going towards this cloacal membrane, and as a result, this divides this cavity into anteriorly lying urogenital sinus, and posteriorly we have primitive rectum. And when this urodactyl membrane joins this cloacal membrane, as a result, this complete cloacal membrane is again divided into two parts. Anterior part will be your urogenital membrane, and posterior part will be this anal membrane. And the anterior part, which is your urogenital sinus, in future it will form urinary bladder and urethra. So now the congenital anomalies related to this hindwall will be Hirschsprung's disease, which is also known as congenital megacolon. There is some defect in the parasympathetic ganglion in the wall of the gut. Then this leads to this Hirschsprung disease. Then if there is some defect in the anal membrane, this leads to imperforate anus, ectopic anus, rectal fistula. Fistula is a communication between the two organs, and so first of all we have rectovesical fistula. If there is a communication between rectum and urinary bladder, then this leads to rectovesical fistula, or there can be rectourethral, or there can be rectovaginal fistula. Now, so switching on to our next part, which is development of urinary system. Now, our urinary system, some portion will develop from your
intermediate mesoderm. Now this intermediate mesoderm, we have urogenital bit, one is genital bit and one is nephrogenic cord. Now this nephrogenic cord, we have three parts, pro, meso, meta nephros. So you can see this is the unsegmented mesoderm, that is a mesonephric system. And then from this part develops a mesonephric. This is a urethric part. Urethric part will move towards this metanephros and this will form metanephric blastema that will form future kidney. So you can see here, this is the urethric part taking origin from this mesonephric duct and this will move towards this metanephric blastema to form your complete kidney. And this is again the portion of the hind gut. You can see here, this was the hind gut, this is the anteriorly cloaca, posteriorly primitive rectum, rectal membrane, and this anterior portion and this urorectal membrane moves and touches this membrane, and as a result, anterior part will be your urogenital membrane and posterior part will be your anal membrane. And if we come to this anterior portion, that is urogenital, so this is your vesico-urethral and urogenital sinus. Vesico-urethral, future will be vesico means bladder and urethra. Will develop from this portion, and after the junction of mesonephric duct, this portion will form urogenital sinus. Now urogenital again will be divided into this pelvic part and phallic part of urogenital sinus. So cloaca is dividing into primitive urogenital sinus, anteriorly and posteriorly we have rectum. The primitive urogenital sinus is again divided into ऊपर है vesico-urethral and नीचे है definitive urogenital sinus. देखो definitive means होता है कि वो सिर्फ urogenital ही बनाएगा नीचे वाला, and vesico में bladder and urethra बनता है, primitive में दोनों है. Now development of kidney, we see the pronephros becomes non-functional and appears in the cervical region, then it degenerates by fifth. And mesonephric that appears in the thoracolumbar region, it will form mesonephric duct or Wolffian duct. And metanephros appears in the lumbosacral region and form the excretory part of the permanent adult kidney. So the development of kidney initiates during the 5th week of intrauterine life, and we have the two components in the development of kidney. First of all, we have the secretory part and the collecting part. Secretory part is the main part which develops from the nephrogenic cord, metanephric blastem. So this is our secretory part, nephrons jaise karne. And then we have collecting part which develops from the urethric part, as I have shown you in the previous slides. So kidney we have collecting excretory. Excretory is the nephrogenic part. So you can see this is this brown color portion. Brown color is the main excretory part, main neuron, and this pink color part is the collecting part. You can see development of urethric part. This is dividing and forming this renal pelvis and calyx. So that means in this diagram we can see kidney is formed by the two parts, that is the excretory part and the collecting part. The collecting part कहाँ से बन रहा है? Mesonephric duct gives one outgrowth which is known as urethric part. Urethric part ureter बनाएगा, ये ureter renal pelvis बनाएगा, and then major and minor tracts. And excretory part जो है हमारा, which is forming nephron, it develops from the intermediate mesoderm, metanephric blastem. So now there is one thing, that is ascent of kidney. This is derived from, this is present in the sacral region, so it has to ascend upward. And if ascending there is some sort of tissue unable to ascend, then this leads to various anomalies like pelvic kidney, your kidneys at some lower level. Ideally, it has to ascend up, but sometimes it remains at the lower level. So these are the various anomalies of kidney, renal agenesis, duplication, anomalies of the position of kidney. Now there is abnormal rotation, non-rotation, congenital polycystic. And then we have aberrant renal arteries, anomalies of shape. So you can see this is duplication of kidney, because it is developing from metanephroblastoma, so there can be duplication, horseshoe-shaped kidney. With the lower end of the two kidney, they are in contact with each other, and this shape we get, and this is known as horseshoe kidney. Then we have pancake kidney. Both the kidneys are fused together and giving this irregular single mass. This is known as pancake kidney. And then we can see this is the lobulated kidney. Because kidney initially it has developed in lobules only, and if they are unable to fuse, then this leads to a condition called lobulated kidney, or congenital polycystic kidney. What this appears is, as you all know, kidney has developed from two sources, that is the excretory and collective. Both have to communicate. If they will not be able to communicate, urine formation will occur in excretory part, but it will not be able to move to collective part. So this leads to the formation of small cysts on the surface of this kidney, and this is known as congenital poly, means many cysts are present on the kidney. Now development of urinary bladder. So this portion, as I told you, the cytourethral canal, this will in future it will form the bladder. Again, this is a repetition of the slide. So vesico-urethral, ऊपर वाला part जो vesico है वो आगे बनाएगा, and urethra will form the urethra. Again, this is a repetition of the diagram. You can see this is vesico-urethral canal. ऊपर का part vesico बनाएगा, नीचे का part is not urethra. And what are the anomalies related to this urethra? We have congenital rectovesical fistula. Rectovesical fistula means communication between rectum and vesicle, or we have vesico-vaginal fistula, then cyst, sinus, or there may be hourglass, that is a developmental defect in the shape of the bladder. Now coming to development of reproductive system. Now this reproductive system, now remember two things. We have the genital system, that is the gonads plus ducts. Fine. The gonads they develop from the genital ridge in cooperation with the primordial germ cells. And then we have genital ducts. बस यहाँ पर you remember this one thing कि under 7th week gonads are similar in both the sexes. Gonads are derived from three sources, that is mesothelium, underlying mesenchyma, and primordial germ cells. So now development of testes. These are the various sources from which the testes develop. That is seminiferous tubules, interstitial cells, and and this fibrous septa and tubule. They all develop from your genital ridge. To be particular, try to remember this is the main part of the testis, that is the seminiferous tubules, vegetative scales, interstitial cells of lytic, fibrous septa and covering of testis. They all develop from this genital ridge. Whereas the connecting part, that is the even tubules, canals of epididymis, vas deferens, appendix, and this appendix of epididymis, they all develop from the mesonephric duct. So in broad classification, we can see the main part of the testis, tubules, everything develops from the genital ridge, and this connecting part. Now, but asli spermatogenesis organ, all develop from the genital ridge. And the part which is carrying this, that is tubules, and this is
canals and everything.
They all take origin from the mesonephric duct. So now, as we have read in our previous slides, there was ascent of kidney. And you all are very well aware, we have to know that this body temperature does not take place, so kidney has to descend. So there occurs descent of kidney. So these are the various points. I'll show it in the diagram. So these are the various stages of descent of kidney. Third month, developing testes in period fossa. By 6 months, it will be present at deep inguinal ring of the deep inguinal ring of your inguinal canal. By 8th month, it will be at the level of the superficial inguinal ring, and by the 9th month, a baby is born. At that time, it will be present in the stomach. So this is the normal descent of kidney. Sometimes undescended, the abnormal presence, then these are the various positions at the testis will be found. Anomalies of testis, we have pictuorganism, anortism, monoortism, or ectopic. There can be ectopic position of the testis. It can be present in the superficial because ये बनता कहीं और है, इसको जाना कहीं और. ऐसी सिचुएशन में there are chances of the ectopic positions of the kidney as of its testis. जैसे कि kidney has to ascend, testes have to descend. So whatever various ectopic position, if it is present as superficial perineal pouch, it can be present in the front of the symphysis, femoral canal, skin of penis, and in the skin in the front of thigh. These are the various ectopic position of the testes. Similarly, development of ovary. So again, these oocytes, follicular cells, germinal epithelium, all will develop from your primordial cells and cortical sex cords. That is a genital bridge. And these are the anomalies. Now coming to the two types of duct. That is mesonephric duct and paramesonephric duct. In males, we have seen all the system develop from the mesonephric duct or the Wolffian duct. And in females, paramesonephric duct or Mullerian duct. So mesonephric ducts form genital duct system in males, paramesonephric duct form genital duct system in females. This is most important point in development of this reproductive system in males and females. So now coming to mesonephric tubes and duct in males, क्या क्या बनाएगा? After testes, whatever everything is, that is the effect ductus of the testes. Then we have this canal of epididymis, ductus efferents, ejaculatory duct, seminal string. Everything will be derived from the mesonephric duct in males. But in females, this part will form just the vestigial remnants in the nape of this epifront, paraophron. All these structures, they are present in females and they are present in the broad ligaments of uterus. So mesonephric duct form the duct system in males. उसी के counterpart में females में of this complete paramesonephric duct system in females form the complete duct system, which is the cephalic part, which is unfused. Two paramesonephric ducts. They are forming the uterine tube and the cranial ends, the distal part, the distal opening. There we have the pelvic ostium, the opening of the fallopian tube. And then these two paramesonephric ducts, they join in the center and form the uterus. So here we can see these are the two paramesonephric ducts. Their distal part is unfused and so they are forming fallopian tube. And coming in the midline, they fuse and they will form a future uterus and upper part of vagina. So here you can see there are two paramesonephric ducts. They are totally unfused. Still they are unfused, but in the midline they fuse to form uterovaginal canal. With this unfused portion, they are forming fallopian tubes. The distal end is forming the femoral end of fallopian tube, and in the midline they are trying to form the uterus, and lower part will form the vagina. So this is known as uterovaginal canal. Now, some developmental defects of the uterus. You have biconvex uterus, uniconvex, septate uterus. There can be abscess of uterus, double uterus. So you can see here, there is biconvex uterus. Both the tubes are separate. There are two contours present in the uterus. Here you can see only one contour is present. So this is uniconvex uterus. Sometimes septa may be present. That is called septate uterus, or there can be uterus diathesis when they are having two separate cervix. Then this is known as uterus diathesis. So, in very short, this is just a brief description of the development of this abdomen as well as various congenital anomalies related to the development of various parts of it. So in very short, this development of abdomen can be covered under four major headings. That is the anterior abdominal wall developmental defect, gastrointestinal duct and its defect, urinary system, and then last, beyond reproductive system, development and so I think in this very short span of time, I was able to put some important points in your mind. If I am right, please say yes. Yes, ma'am. Some other things in your mind? I can open one question of your prof that will be the derivative of meso nephrecta or parameso nephrecta. Either in your MCQs, in your Bible exam, some or the others will not be able to avoid these questions. So if we say embryology पढ़ लो, that is going to help you a lot. PGs have to study more. UGs के लिए small points will help them. ठीक है? And gut system में never thought that all the derivatives of foregut will get their arterial supply from ciliate trunk and the branches. All the derivatives of midgut will get their arterial supply from ciliate trunk and its branches. And all the derivatives of hindgut will get the arterial supply from. That's it. Thank you. इतनी देर से क्लैपिंग करो मेरे आवेदन तक जाएंगे.
आज भी कर रहा हूँ.
Hello. Thanks a lot, Dr. Anshu. She is one of my favorite colleagues from Kanpur Medical College. We both were great friends out there. We have given me the opportunity to come here. अब लोग क्या सुन लो आगे. ऐसे ही फ्रेंडशिप बनाना आगे तक बुराई रहेंगे एक दूसरी जगह. नहीं तो कौन ठीक है? ओके?
Thank you, Dr. Anamika. Your session was not only insightful, but also highly relevant to our theme. Your contribution has added immense academic value to this PhD. As a token of gratitude and appreciation, we request Dr. Anshu Gupta ma'am and Dr. Rajendra Kumar Nim sir to kindly present a memento to Dr. Anamika ma'am. Please welcome. Thank you ma'am and Dr. Rajendra Kumar Nim sir. Dr. Anamika ma'am, please.
क्या यार कहते नहीं है ना.
Photo please.
ऐसे मैम वेट कर लो बस 1-2 सेकंड हो ले रहा है बस ये 2 सेकंड जो हाँ
I now invite Dr. Manjula ma'am and Dr. Rachna Agarwal ma'am to kindly come forward and felicitate our respected chairpersons, Dr. Anshu Gupta ma'am and Dr. Bin Kumar sir, for their support of this session. Please welcome Dr. Anshu. I now invite Dr. Rachna ma'am and Dr. Manjula ma'am to come forward and facilitate our respected chairpersons. Dr. Anshu Gupta ma'am and Dr. Bin Kumar sir.
wonderful progress in our exploration on 2025 CMES making anatomy. And I'm thrilled to welcome you to the fourth session of the day. Building on the insightful discussions from our previous sessions, we now shift our focus to the practical application of imaging techniques in understanding abdominal anatomy. It is my great pleasure to introduce our speaker for this session, Dr. Pradeep Singh, Associate Professor at Snmc, Agra, a distinguished expert in the field of anatomy. Dr. Pradeep Sir's expertise in the field of anatomy, particularly his contribution to the anatomical research, has made him a respectable figure in medical education and clinical practice. Today, he'll share his knowledge on radiographic overview of abdominal anatomy, a topic that enhances our ability to leverage radiographic techniques. Before we begin, allow me to introduce the chairperson for this session, Dr. R.K. Ashoka Sir, who will guide our discussion with his expertise and ensure a meaningful exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Pradeep Singh Sir to deliver.
Thank you, all of you. I welcome CNE. Today, my topic is radiographic overview of abdomen. Now, the three sessions you already have, and now I hope that the theory part is now you have been very thorough with. Okay. So, the important role now is of diagnostic. The patient is there. Now you will be dealing from this session the patient. So patients are there. How you will diagnose? How you will diagnose? So there are different ways in the radiology to diagnose the abnormalities in the abdomen. So first thing, you are having an X-ray. Second, you are having a CT, and then you are having an MRI. As my view, it is very important in the Indian life. The people are having not so much. We should keep it very simple. They are very poor. And if a doctor is having a clinical expertise in his field, he can reveal the diagnosis from an X-ray also. This is my main focus today. That X-ray you are having, you are going for an X-ray and you are not telling the patient straight away to go for CT and MRI, which are very costly. The things you can derive or diagnose from the X-ray if you are expert in that field. So this we will learn today in our session, that you are having an X-ray, how you will diagnose a patient from that X-ray. Few points I will tell you, tips will be there, and it will be very helpful in your later life as a student, as a patient. Okay. So my first slide is very important. That X-ray, abdominal X-ray, it is a relic or a reliable. Now, relic means outdated. As most of the doctors today they are practicing, they think that the X-ray is a relic tool, outdated, but it's not. It is still a reliable, and this I will prove in my session. When we will be completing our session, you will be definitely be an expert of an X-ray abdomen. So, remember this line, relic or reliable tool. And when I will finish my session, you can just relate this line and we will discuss this line after finishing my session. So, the second slide, what we have discussed is that that the physicians they rely on the abdominal radiography as a primary diagnostic tool. And it's very important before going for any CT and MRI. So what are the advantages of the abdominal X-ray? firstly, it should be, very important word, it should be a primary screening modality. कोई भी जो है पेशेंट आया है, should go for an X-ray. Don't tell to go for an MRI or CT. Secondly, it's widely available. Patient इधर-उधर भटकेगा नहीं. He will definitely go for an X-ray. Cheap and simple. That's what we are discussing. And it is excellent in diagnosing free air in the abdomen. तो ये बहुत ही important part है कि patient perforation के साथ आया है and is very much agony, not having much time. So this is a simple diagnosis. Yes, I will tell you. You must be having. I am giving an example of an actor, Amitabh Bachchan, in the movie of Police. Yes, the villain just एक घूसा मारा था उसके पेट में, है ना, जोर से मारा था, उसकी क्या है, आंतें फट रही थी, ठीक है, and he went to his family doctor. He was not able to diagnose. Then later on, the perforation was there, and then the treatment started. You know, so this is important that it is excellent in free diagnosis, free air in the peritoneum. If the rupture is of the intestine is there, there will be free air in the peritoneum, and that will be corrected at the diaphragm, dome of the diaphragm. And there you can, and the sign is there, as we discussed later on, the set sign. Secondly, it is very good diagnosis. All of stones, calcification, kidney stones, urinary stones, ureteric stones, and the bladder stones. Very good. Bowel obstruction, you can see. All this, in the end of the session, you will be the expert of that test. Now, what are the disadvantages? Only the radiation exposure is here. And you should be, I think you must know that the exposure of the X-ray is about 0.7 millisievert. 1 millisievert, if you compare with the cigarettes, that 20,000 cigarettes per year, that comes to 2 packs of cigarette per year. One radiation, one X-ray is costing such much radiation. But when we are going for a CT, it is 30 to 14 times. So, you can see it is 8 to 10 millisievert. But X-ray is 0.7 millisievert. This is a difference. Secondly, why I am comparing the cigarette with the radiation? The cigarette is also having a radiation. You know, yes, it is having a radioactive isotope, polonium 210. Polonium 210 radioisotope है. Then it is a tobacco. It is a silent killer, and it is there. That's why I am comparing the radiation with the cigarette. Secondly, it is a poor soft tissue case. This is the laguna of an X-ray. It is a poor soft tissue details are there. For that, you have to go for a CT and the MRI. What are the indications? Firstly, I have told you an example of infection, rupture of the intestine. That is, for that, we are going for a straight limb. Now, what is a straight limb? Straight means straight. The patient is suffering, no preparation needed. Go to the X-ray lab, go for the X-ray, and that too in an erect position. So, air is setting on the outside, but the fluid side is down. So, go for an erect X-ray. Secondly, perforation, here, that's the same thing. Bowel obstruction is there, and for that we are seeing the dilatation. Now, this also we will confirm in the coming slides that how we will judge for the bowel obstruction. Then for the cavity, stones is extract for the cavity. Foreign body location. बच्चा है, bowling हो गया, and we can just by the X-ray where it is. पास हुआ नहीं हुआ 100 दिन बुलाएंगे, सीरीज ऑफ एक्सरे कराएंगे, आप अदरवाइज go for an intervention. Toxic megacolon, it is a condition where the size of the colon is increased. Aortic aneurysm, it is a silent killer. Aortic aneurysm, generally 2.5 to 3 centimeter of the aorta is normal in diameter, but if it is more than 3 centimeter, that is aneurysm, means dilatation of the aorta is called as aneurysm. What it can do? It can burst. So it is a silent killer is there. कभी भी बॉडी में पड़ा रहता है एनेरिज्म, सर्कुलर ऑफ विलेज में एनेरिज्म होता है और एकदम अचानक ही जो है हेमरेज क्या होता है साइलेंट किलर. Then there is a contrast studies. Different contrast studies are there for that we can also in the case of poisoning we put the gastric tube for the patient who are not able to feed to see the position whether it is going in the correct place or not. For that we have the X-ray or uterine tube design indication. But first thing, this is very important and you should see that the lab technicians are working proper or not. उन्होंने देखा नहीं, पेशेंट आया, लाइट लगाई, 10-15 पेशेंट्स हैं, उल्टी रेटिंग कर दी, पेशेंट का नाम था, शाम वाले ने कर दिया. तो डायग्नोसिस तुमने अच्छी बनाई, तो डायग्नोसिस रात की जगह शाम की बन गई. So there are no prizes for making a brilliant diagnosis with a wrong patient. Patient wrong था, diagnosis सही है, nothing, you will not get prize for that. So very cautiously you have to mention the basic details, the name, age, UID number, if any, type of investigation and date. ये अच्छे से लिखना होगा. Then proceed. Now, one was the acute case of acute abdomen, where a straight frame you can go for, no preparation needed. But if you want a good result, you want that the intestine should be clear, because the gas, the fecal matter, will obstruct your view, your diagnosis. So for that, first the enzyme preparation you will give any digestion, if any content is there, it will be digested. Secondly, there is 2 tablets of Snmc is given at the night. What it does, it is clear the fecal matter. Then 2 tablets of charcoal, what it will do, it will absorb the air. So all the gaseous absorption will be there. So these 2 things, charcoal for the gas and the Dulcolex for the clearing of the fecal. And also the overnight fasting for the patient. The third thing is, if fecal matter is there in the large intestine, become sigmoid colon or the rectum, then you can use the any one. So the patient is prepared. Exposure type, it is very important, the penetration of the X-ray. So for that, in our National Medical College, we are having a machine which is having 1000 milliampere. And we should have a short exposure. Why it is given short exposure? Because we know that the peristalsis are there when the movement of the bowel is there. But what we should do at the time of an X-ray, we should freezing the voluntary and the involuntary movement. क्या मतलब हुआ voluntary movement का? आप पे ना आ रहा है, उसको कहना है पेशेंट को शांति से लेट जाए. Supine position, जो भी supine position जो है हमने कहा है, make the patient comfortable so that to clear off the voluntary movement. Involuntary movements को कैसे कहेंगे? उसमें सांस पेशेंट जो है वो एक्सपायर कर देगा. सांस आप छोड़ के लेट जाए, 2 मिनट होल्ड कर लें सांस को. 2 मिनट होल्ड कर 2 सेकंड होल्ड करने से क्या होगा? वो जो बाउल मूवमेंट है वो सेटल होने लगेगा. एंड देन गो फॉर एन एक्सरे, कोई एक्सरे. सो दैट बहुत ही शॉर्ट एक्सपोजर, ज़्यादा एक्सपोजर हो जाएगा तो मूवमेंट आ जाएगा. तो दिस इज द टेक्निक. So we are having a better view. There is a difference between the chest X-ray and the abdominal X-ray. क्या फर्क है? Chest X-ray में we are saying the patient सांस अंदर लेके रोक लो. एब्डोमिनल एक्सरे में क्या कहेंगे? सांस हाथ छोड़ के रोक लो. क्या इसका एडवांटेज? यस, बाहर लेके सांस छोड़ेगा तो उसका डायफ्राम ऊपर आ जाएगा एंड वी विल गेट अ बेटर व्यू ऑफ द एब्डोमेन. डायफ्राम ऊपर रहेगा एंड बेटर व्यू ऑफ द एब्डोमेन. व्हेन द एक्सरे वी आर टेकिंग, इट इज फ्रॉम the rib cage, lower part of the rib cage to the pubic symphysis. This is the area we have to study. तो डायफ्राम ऊपर रहेगा एक्सप्रेशन करके and much better. You will be having, So, secondly, immobilization. Radiation protection should be there. Gonades, the sheet should be there. Secondly, 10-day rule. Pregnancy cases में after menstrual, usually 40 days are safe. But here we go safe. 10 days we are taking. 10-day rule we should go. Otherwise, the cases are there in which trauma hysterectomy is complete. Now, before going for further session, know that the radiographic projection should be there. Two types are there. For chest X-ray, we know we are going for PAD. For the abdomen, we are going for APQ. क्या फर्क होता है? APQ अगर लेते हैं तो ये डायरेक्शन बता रहा है एक्सरे का. AP का मतलब है डायरेक्शन है एक्सरे का एंटीरियर टू पोस्टीरियर. ये जो है वो पोस्टीरियर से एंटीरियर आ रहा है. तो डायरेक्शन पेशेंट जो है वो अगर ये व्यू है देन इट इज एंटीरियर. अगर AP व्यू है देन द पेशेंट इज पोस्टीरियर. So generally for the abdomen we are having an AP view. जनरली AP view किसके लिए कराते हैं? AOB रीजन के लिए. AOB जिसमें किडनी, यूरेटर एंड ब्लैडर, ये तीनों जो है इन्वॉल्व हो जाएंगे, इसके लिए कराते हैं. एंड तीनों पोस्टीरियर व्यू. सो द क्वेश्चन इज कैन वी डू द एक्सरे फॉर A view आल्सो? यस, कर सकते हैं. इसमें जो है हमें किडनी, यूरेटर, ब्लैडर नहीं है, उसके लिए हम AOB भी करा सकते हैं. उसमें क्या फायदा है? उसमें जो है वो स्ट्रक्चर्स हैं पीछे वाले और बेटर व्यू आ जाएगी. पोस्टीरियर एज डॉक्टर कमल हैव सेड, स्ट्रक्चर ऑन द पोस्टीरियर वॉल. ये विल बी मच बेटर व्यू और गोनाड्स भी सेव हो जाएंगे. तो लेसर डोज विल बी इन द व्यू. ओनली द कंडीशन इज व्हेन यू डोंट नीड AOB इंजेक्शन. सेकेंड इज AP इरेक्ट. AP इरेक्ट मैंने बताया था परफोरेशन के केसेस में उसमें है AP इरेक्ट करेंगे, एयर विल राइज अप टू परफोरेशन के लिए. कुछ पेशेंट्स हैं जिसमें जो है AP व्यू है और वो वहाँ से आया कि वो करा नहीं रहा है, खड़ा नहीं हो पा रहा है. ये आ सकता है कंडीशन AP व्यू है, कराना है, परफोरेशन लग रहा है, लेकिन बट करा नहीं पा रहा है. उसके लिए एक सेकेंड चीज है, सेकेंड टाइप का एक्सरे है पोजीशन दैट लेटर टेकिंग. तो साइड से लेटना है, लेटरल एब्डोमिनल वॉल से जो है लेटना है. टेबल शुड ऑन द टेबल द लेटरल एब्डोमिनल वॉल शुड बी देयर. लेफ्ट लेटरल एब्डोमिनल वॉल बी देयर. आई एम ऑन द टेबल. करवट से लेटना है, दैट इज द लेफ्ट लेटरल टेक्यूटर. इसमें भी जो है एयर आ जाएगी ऑन दी अदर साइड, अपर साइड ऑफ दी लेटरल. एयर आ जाएगी, एयर बट द डिफरेंस इज दैट इन AP इरेक्ट में इवन 1 ml ऑफ एयर विल बी अवेलेबल. लेफ्ट लेटरल डेक्यूबिटस में 3 एयर पेरिटोनियम में होगी, 5 to 6 should be there ml. इसमें दैट sensitivity is more for the but the condition is there that you should see. This is the position that already I have told you that AP supine. Supine is patient लेटा हुआ है, eyes on upwards and the back is toward the table and the patient you can see in the lower side. So the direction as the AP is, the direction of AP is as the direction of the X-ray. What you should see that the mid sagittal line should be at the right angle of mid sagittal line. Mid sagittal line should be at right angle to the table. Secondly, there should be a pubic spine equidistant from the edges of the table, so that the pelvis can be in the center. Okay. Thirdly, very important, when you are having an X-ray, a correct X-ray, good X-ray, will have lower 3 or 4 ribs. Lower 3 or 4 ribs and lower part the pubic symphysis. So lower 3 or 4 ribs should be there and the pubic symphysis should be there. And the arms and not obstruct should be on this side of it. Here you the later patient. So what will be the direction of the X-ray? So you can see the plate is on the anterior aspect of the body. And the same thing is there, mid side of the plate is 90 degree, mid side of the plate should be 90 degree, so that the patient is straightly close position. And the arms should not obstruct. AP erect, you can see here, this the patient is standing with the back at vertical bucky. Now, what is this vertical bucky? Bucky is a plate-like thing which is having the lead around it. Bucky is a plate in which we put the casing, and it is having a lead around it. Body, so that the X-rays which are going do not scatter. Lead से absorb हो जाएगा, X-ray scatter नहीं होगा. So that is called the bucky which is having a lead. So you can see bucky is there, vertical bucky is there, in which the cassette is there, and the patient is standing, and the mid sagittal plane, you can see the mid sagittal plane should be at the right angle as for the table. 90 degree with the bucky, and the equidistance of the ESI, so that the pelvis should be in the center. Left-sided decubitus is a condition when patient is not able to stand. AP erect नहीं हो पाएगा, then we can go for the recommended position. Recommended for decubitus are same thing. Okay. Decubitus is a general term. The recommended is a position in which the patient is relaxing. So after this all preparation, now what should be the quality of the quality? As we are giving the points, I am giving the points, I am correcting them all. That we should look for the diaphragm. And what should be there? The 3 or 4 lower ribs should be there. To the pubic symphysis. Both the lobes of the diaphragm you should see any brief here. Secondly, the ball gas pattern. This I will do, and I will show you the slide. Lateral abdominal wall and the pre-peritoneal fat. Pre-peritoneal fat is around the kidney, and this is the important thing. From that you can diagnose or just able to see the kidney. Fast major shadow is there. See in the lumbar vertebrae the transverse process. The origin is there, L1, L2, L3, and ultimately it is having insertion in the lesser pocket. Straight border we can see on the swan fluid. Lumbar vertebrae and the spine should clearly be visible. And the side identification, the marker should be there. Now, a good doctor is what a good doctor should be. He should be able to orient quickly and see from right to left, left to right. Second thing is eye wall of the limb. Eye wall of the limb, nothing related with the eye wall. It is the alertness of the mind. We are seeing all the corners. The quadrants as been said to you previously, the 9 quadrants. We are eyeballing, rotating the eye all around, right? This is called as eyeballing. Eyeballing of the eye to see the flame. And also, what the things we should very clear that what we are having in the mind, I see that only. अगर mind में नहीं है पहले से, we can't see the things. So firstly, here I have made a mnemonic ABC. A stands for the ear. Ear means any perforation. That perforation, the ear can be there. The bowel. See the pattern of the bowel, dilated or not, perforated or not. Bone. See the bones, whether the bones are normal, fractured or not. Bones are important. Calcification. कुछ bone है kidney में, urinary bladder में. Density. Density is very important. Density अगर बोन का देखें तो वाइट दिखाई देगा, एयर का देखेंगे तो ब्लैक और एक स्केल है. I made a scale that is known as density scale. So all the shades are then between. One is the darkest for the hair, one is the whitest for the bone, and then the scale is there. So what this scale is here? This is the scale. This is the scale known as density scale. Now here you can say here that the bone is there. Is white. Gas is black. Gas is black. Bone is white. Soft tissue light gray color. Soft tissue light gray. Fat is dark gray. These are the shades you should keep in your mind to diagnose the case. Otherwise, and it comes with the practice. It comes with the practice. Metal, bullet or foreign body, a coin is there. A coin and a bone. If you see, when you see the practically the X-ray, coin and a bone, the coin will be intense white, while the bone is white. So this is the things they will be able to see when we see the X-ray which I come. So what will be the systemic interpretation? एक X-ray आया, ऐसा नहीं X-ray आया और हमने ऐसे देखी, ये उसका एक ऑर्डर है, चेकलिस्ट है, and checklist we should have. अगर चेकलिस्ट नहीं बनाया है तो we can't diagnose an X-ray. चेकलिस्ट क्या है? मैंने शुरू बताया. First name and the age. Then bowel preparation हुआ है नहीं हुआ है. Position of the flip मैंने बताया कि ASIS से जो है वो मेड सेंटर है नहीं. Adequate ये covered है या नहीं पूरा है तो सांस लेके जो बताया है. Bowel gas pattern very important. ये मैं अभी बताऊंगा किस तरह. Bowel dilatation obstruction के cases में use किया जाता है bowel dilatation. Pre-peritoneal fat lines की kidney को देखने के लिए is very important. Visualized organs are normal or not. ये भी मैं बताऊंगा कि जो organs हैं उसको normal size में है या नहीं. This also you will see from the slides. Bones and joints are normal. Whether you are able to see the soft tissue shadows, any calcification, any opacity, any artifact. The 12 points you should learn by heart and then you should be able to diagnose an X-ray. Here, just an idea. I have made a rough sketch and X-ray itself. So here, for the SWAS shadow, you can see here, here, and here you can see the transverse lumbar vertebrae and up to the lesser protector, the SWAS shadow. The arrow is showing the SWAS shadow. Can you see? This is the SWAS shadow. Secondly, the gas in the colon. Here, the transverse colon was here, and you can see the gas in the colon. The gas here is there in the fundus. So this is giving an idea. You are seeing a normal X-ray. You will see abnormal X-ray also. And all the lumbar vertebrae, starting from here, this is the L5, L4, L3, L2, L1. And this is ultimately there is 12 here. All these things are there. So mainly, roughly you have seen an X-ray. Now, what are the things you will see? Here, yes, ABCD. So formula we know. First we have to see the air and the bowel, bone, density, calcification, all the things. In the abnormal cases, 3 B's are there. In the abnormal cases, the 3 B's are there, and they are, one is the bowel dilatation, very important. Second is the bowel perforation, very important, and the bowel obstruction. And then, one by one, we will see these all. So, air gas pattern, you see in the normal case, stomach is having air in the fundus. Generally, a small bowel is having 2 to 3 tubes. In the large bowel, there is the air always in the rectum. अगर rectum में air नहीं है, means there is some obstruction above to it. And the case is there. Sigmoid colon air, air only. 2 to 3 tubes, it's okay with the small bowel and the air is the small. It's a normal case. Otherwise, some fecal matter can be there, which is with the air and any obstruction. Look at here. Very good. On the slide. Fourth shadow. We have already done the lower 4 ribs, lumbar vertebrae, spine, ribs, sacrum. Now the organs. How the organs will look like? Firstly, the liver. You know, where the liver, if you see, I am making a pointer like this. This is liver. And this is the 12th rib. So liver is particular when it is beyond that rib cage. जब rib cage के नीचे आएगी, then only it is called the hepatomegaly. So in this case, it is normal, lying within the rib cage. So other thing is liver span. We can go for a liver span. So what for that we have to do that mid-level line is lying there. We are making 2 points of the liver span. A line is there, mid-level line. We are making 2 points only. One is the diaphragm is there, the right diaphragm, which is with the upper border of the coinciding with the upper border of the liver, and the lower border, which is again coinciding with the mid-level line. So this is the liver span. In the age according as wide the age grows, the liver span the child, it is of the, up to 5 years, it is 4.5 to 5 centimeter, while in the adults it is 6. Other details we should go for the ultrasound. Kidney, what is kidney? It should be in shape. Now if I just pointing my pointer, you can see this is kidney. Can you able to see the kidney? Are you able to see the kidney? This one and this one. Can you able to see the Swas shadow? This is here. Okay. Can you able to see the bowel gas in the transverse colon? Yes, it is. Okay. Now, what is the size of the kidney? The size of the kidney is generally 3 lumbar vertebrae. The size of the kidney is generally L1 to L3. You know, from L1 to L3, this is the size of the kidney. Now, roughly, if you see that the lumbar vertebrae का size क्या होता है? It is 2.5 generally, 2.5 to 3. 3 lumbar vertebrae. 3 lumbar vertebrae का कितना होता है? 7.5 to 8. फिर उसमें intervertebral disc है, वो भी height लेना पड़ेगा. It is around 0.7 to 0.8. दोनों को मिलाकर में 2 lumbar vertebrae को 1.5. 7.5 plus 1.5. Nearly the size of the kidney is 10 to 12 centimeter. And if it is more than 12 centimeter, you can go for enlarged kidney. If it is less than 10 centimeter, you can go for a contracted kidney. So lumbar vertebrae size, you are comparing for the L1 and L3. Which kidney is lower? Definitely the right kidney because of the liver. Here you can see the right kidney is lower, while the left kidney is slightly upper. And the urinary bladder, when it is empty, can't see. A full bladder is globular, and you can see radiolucent shadow. Globular in have already done. And it's very important, if the spark shadow you are not able to see, basically some pathology is there. Spark shadow should be very clear. The three conditions that we have seen for the bowel, what was there? Bowel में क्या क्या देखना है? First dilatation, second में perforation, third में obstruction. ये तीन चीज देखने के लिए bowel will be clear. You are an expert of the seeing the bowel, any abnormality in the bowel. Firstly the dilatation, secondly the perforation, thirdly the obstruction. So bowel. How bowel की बात आई है तो how to identify the small bowel, how to identify the large bowel. Simple formula है, small bowel will always be located centrally. Ileum, duodenum, they are central. For the large bowel, you have to look for periphery, transverse colon, ascending colon, transverse colon, and the descending colon. Very clear. Secondly, there is a mucosal folds. The permanent folds are there, mucosal folds, and they are known as valvulae polyventous, valvulae polyventous, curving is for there, and they are the folds, permanent mucosal folds. The thing is, they are through and through. From this is the bowel. It is extending from this part of the ball to this. So whole of the extent of the ball is there. So I think you should compare it with a spring. एक spring देखा है, पूरा point वाला spring देखा है, वो ball मान लो, and it is such that वो spring जो है ऐसे roll कर रहा है, and it is like that. So you can think of a spring for the small ball. And very important thing to note that the normal diameter of the bowel, small bowel is 3 cm. More than that, it is dilated. So you see here, valve-like polyventous, overall the thickness of the bowel, and large bowel. How you see for the large bowel? The only thing is there, obstructions are there, separations are there. We know that the tinea coli, there are 3 tinea coli, and the wall is there, but as the movement is there, the sacs are formed because of the tinea coli, they are not extending, but the wall is there, which makes us sensation for the absorption of the more of the water. Separations are there, obstructions are there, and they are different from the valve-like polyventous because they are not extending to whole of the length of the bowel, whole of the diameter of the bowel. So here you can see the circulation, and they are more interspaced, more wider spaced in the comparison to the small bowel. And what is the diameter? There it was 3 cm, it is more than 3 cm small bowel, it is dilated. Here 6 cm. The normal diameter of the bowel, large bowel is 6 cm. So it is more than that, it is dilated. So when a X-ray is there to you, अगर वो bowel में देख रहे हो, अगर वो 3 cm से ज़्यादा है और central में dilatation of the small bowel, it is more than 6 cm in the transverse, and it is the dilatation of the large bowel. Conditions would be there. So I have made basic difference small bowel, valve-like polyventous, in which the mucosal fold, there are permanent folds, and they extend across the lip. Here obstructions are there, they are not extending. Secondly, they are moved. Small bowel is central, while it is peripheral. Diameter, it should be normally up to 3 cm, while the large bowel it should be 6 cm. But cecum, it should be 9 cm. So, second is the thing that we have discussed. This is 9. This is 9 for issue. diagnostic that they have done is for the adults. But for the neonates, it is difficult to differentiate between small bowel and the large bowel. You can see there is a mosaic pattern. You are not able to differentiate between the large bowel and the small bowel. Third thing was the perforation. Now, this is called as lymphoperitoneum. Now, the gas pattern was the first step for reading an X-ray. Second is the perforation. It is the second step in reading an X-ray. So, perforation can be, in any case, usually seen in clinically. एक अल्सर है, वो परफोरेट कर गया है. Generally, we have seen that duodenal ulcer is most commonly perforated. Peptic ulcer cases, typhoid ulcer cases, ये perforated. There are the usual cases, ये आते हैं हर एक cases. Bowel obstruction, this can also lead to the pneumonia, diverticulum. They can also perforate penetrating trauma. The condition in the neonates or the premature babies is the necrotizing enterocolitis. Premature babies में ये condition होती है necrotizing enterocolitis. उसमें inflammation और infection हो जाता है wall और उसकी वजह से उसकी wall में air आ जाता है and this air in the wall of the premature baby is called as pneumatosis intestinalis. Pneumatosis intestinalis. Then there is a post-surgical cases of complication हो गया उससे जो है वो ear recovery फिर हो. Now what are the signs of the ear in the peritoneum? The first thing is very clear. You can see the diagram here. See the domes of the diaphragm. Can you see the ear within that underneath that dome? Yes. The right dome, the left dome. I can see the ear. And the shape of the ear you can see it is crescent type. So this is crescent sign for the pneumoperitoneum. First diagnostic tool, crescent sign. ये straight film में भी है, direct film में है. But if the patient is not able to go for a direct, then go for left lateral diagnosis. The only difference is उसमें 1 ml आ जाएगा diagnostic. It needs 5 to 6 ml. Clinical signs कि pneumoperitoneum में एयर आ गया है और एयर एक जो है वो बाउल में भी है, बाउल में एयर है और पेरिटोनियम में भी है. Both the air are black in color, but the wall is generally light grey in color or whitish in color. So can you see the air which is outside and air which is inside and giving a shadow of a wall? This is only in the case of pneumoperitoneum where air is on both sides of the wall and you can clearly demarcate the wall of the intestine. And this is known as regular sign. So duodenal air, extraduodenal air, both are putting a shadow and clearly demarcate the wall. This is known as regular sign. Second is the football sign. Football sign generally we see in the children's. Children's का जो weight है, that is protuberant. तो muscular mass नहीं होता. तो generally जो है शिकायत है बच्चा आया है पेट बड़ा हुआ है. Normal. So there is no muscular mass. Protuberant abdomen होता है. And that was because अगर वो pneumoperitoneum हुआ है और बच्चे को हमने supine position में किया है, then what the air will be do? Air will go to the anterior wall. लेटाएंगे तो anterior wall के नीचे आ जाएगी. And because it is protuberant, the abdomen will spread around that anterior wall. When we are having an X-ray, it will look like football sign. Football sign. Falciform ligament sign. We know that the falciform ligament is the liver is attached to the anterior wall with the falciform ligament. When the air is there on either side of that falciform ligament, the ligament as for the regular sign will be seen. You can see here. This is These are signs for the pneumoperitoneum. So pneumoperitoneum इसमें क्या करना है? डायरेक्ट एक्सरे लेना है. इसमें 1 ml आ जाएगा. एक प्रेशर टेक्नीमीटर भी ले सकते हैं जिसमें हम डायरेक्ट ले सकते हैं. और you can detect 5 to 10 ml of pressure. Sensitivity differences of degree of sensitivity. Now for the perforation we have done, dilatation of the bowel we have done. Now the obstruction. Obstruction, it can be two types. It can be functional or mechanical. अगर obstruction हुआ है, तो it can be functional or functional means bowel is not moving. पड़ा हुआ है bowel, no peristalsis. ये केस हो रहा है इलियस में. फर्स्ट डिजीज उसमें भी जो है एक एनाटॉमिक स्टेटमेंट होता है, उसमें भी बाउल पड़ा रहता है, मूव नहीं कर रहा है, there is no peristalsis. उसमें इलियस की कंडीशन जो है कॉमनली सर्जरी के बाद क्या होता है, जैसे सर्जरी हुई है उसमें 2 दिन वो मूव नहीं करती है इलियस बाउल, दैट इज इलियस. आफ्टर सर्जरी तो उसमें कहा है, डॉक्टर पूछता है गैस पास हुई है नहीं हुई है. आफ्टर 2-3 days द मूवमेंट ऑफ द bowel is there. So this is functional. Bowel is not moving. Ileus. Second is mechanical. Any adhesion, post surgical जो है कोई adhesion हो गया है, any node is there, so that is blocking the movement of the. It can be luminal or external. Now functional ileus, as I have told you, bowel is not moving. Whether it is ganglionic segment disease or it is the post-surgical or appendicitis. Cases can be in the appendicitis. This can be localized or mechanical. I have already read, but there are two types of obstruction we should know: small bowel obstruction and the large bowel, SPO and LPO. Now here, obstruction, one thing is very clear. Always when there is obstruction, this X-ray you will get. Perforation, there is an air, the obstruction, you will get this type of air. Suppose a ball is there and you fill that ball up with the liquid. The liquid will be there and above to it will be air. So, think of a ball. I am half filled with the liquid, and above to it is the air, and below is the fluid. So, what I will call it as air fluid level. Air fluid level. Air ऊपर है, fluid नीचे. Air fluid level. So, this case will be seen only in the obstructions. Generally, 2 levels are normal, but if it is more than 2 levels, then it is abnormal. So here you can see multiple fluid levels. So this is a clear case of obstruction. Clear case of obstruction which is having multiple fluid levels. And what is the pattern? It is step ladder pattern. Step ladder. Video में करें. 1 step, 2 step, 3 step, 4 step, 5 step, 6 step. This step ladder pattern. Now this is a case in the radiology department where a 4-year child was there of bowel obstruction. So can you see here the multiple fluid levels here? 1, 2, 3, 4, 5, 6. Can you see? Because what is this? This is the gas under diaphragm. Gas in the fundus. What is this? This is the large bowel which is dilated. And as it is 4 years, you can see amplifies. It is not fused. So the details you can confirm. Now you are in the process to be expert of X-ray. Perforation you can see now. you can see the obstruction, how you will judge these things, and where you will locate for the large valve, where you will locate for the small valve. These things now you are knowing. And this is a sign where there is a uterine atresia, and proximate to it, as an atresia is there, proximate to it there will be a dilatation. So one dilatation is here, one in the stomach, that will lead to double bowel sign. The second thing is triple bowel sign. If the atresia is in the jejunum, then proximate to the jejunum there will be a dilatation. There will be a dilatation in the jejunum. There will be dilatation in the stomach. So all the three things you will get the air bowels. That is the triple bowel sign. So jejunal atresia, what you will get? Double bowel. Jejunal atresia, what you will get? Triple bowel. So these are mechanical causes. Volvulus hernia, hernia के केसेस आ गए हैं. सर्जिकल hernia हो गया है, ठीक है. एक है inguinal hernia हो गया है. ये सब स्पेकुलेशन भी कर रहा है. और large bowel, due to the suction, very telescopic. There is a telescoping of the bowel within another bowel. It's a telescoping of the bowel. Articulates are there. What is volvulus? The loop is rotating around it. That is the volvulus. Now, large bowel, generally what happens is the curve known as resultant elongated colon. Colon is transverse colon, if you see, it is straight. It is going like this. It is known as resultant colon. Colon is dilated. This is the case. Sigmoid colon is massive dilated colon. Sigmoid colon. Some treating where the dilatation is there, obstructions are there, and obstructions are such that it has become more thick, and the gap is also increased. So it is somewhat like completely fine gap. All these cases, if we join together, bowel obstruction, bowel perforation, dilatation, all these cases, then you will lead to ectoplasm. तो जितना भी केसेस पढ़े हैं उसका सारा सार जो है एक ही है. तो पेडिसाइटिस परफोरेट हो जाती है, ऑपरेशन का केस हो गया. अल्सर जैसे उसको पढ़ा है वो अगर हो गया then it is perforated ulcer. Peritonitis very painful. Peritonitis, cholecystitis, hepatitis, small bowel, volvulus is something here. So X-ray accordingly yes. Calcification, we should know, and the kidney में अगर है कैसे दिख रहा है, अगर ureter में है तो कैसे दिख रहा है. Here, what you will tell that where is the calcification, where is the stone? Generally we see the ureter, the transverse process of the lumbar vertebrae. वहीं से उधर होता है, तक आता है. You can see the transverse process of the lumbar vertebrae. This is the ureteric calculi. This is the case of ureteric calculi. Here is the case of staghorn. See this ear, it is having an horn, and it is like the staghorn. And this is the calcification in the pelvis with the calyx. This is the shape of the calyx is taking, and this is the pelvis. So both of the pelvis and the calyx are taking shape in the form of the staghorn. So it becomes staghorn like this. The bones are like this. Staghorn calculi. Secondly, the bladder calculi you can see here, lying here. These are examples of calcification. This all is what you can see by eyeballing of the eye. Eyeballing of an X-ray. Eyeballing of an X-ray. This is a word you should be very close. Eyeballing. Eyeballing means now we are making all the quadrants, looking for all the quadrants. Barium studies, again the X-ray you need But here, multiple series X-rays are needed. As I have told you, one X-ray is giving a radiation of 0.7 to 8 millisievert. तो अगर 3-4 हो गया तो 3 से 4 millisievert तो हो गया. 1 millisievert is giving an exposure of 2000 cigarettes per year. So single contrast of barium is there. Why barium is taken? It is a radio barium. It is having a high atomic number. It is inert, not absorbed. Also, it outlines the glucose. Patient is asked to swallow the barium 1.5 glass of water, 450 to 550 ml, and X-rays are taken. Double contrast में क्या है? Patient is there, barium is there, and patient is asked to take the effervescence powder also, so that create a clear. In the bowl, where the two things are there, one is air in the center, and the barium will decide to the mucosal lining. So you can delineate the mucosal lining. Any defect, any polyp, any cancer, you will easily see. There is a different types. Barium swallow is from pharynx to the fundus of the stomach. You swallow. Barium meal the esophagus to the proximal duodenum. Barium follow through it is entire small intestine. Enterolysis is somewhere like this, but here what happens, it is more specific. Here the tube is put into the duodenum, and then the small intestine is seen, because here we can make the intestine more dilate. Then there is the enema for the large one. So there are things where we can go for the swallow, meal, follow through, enterolysis, and the enema. Why it is now also in the trend, because it is really available, and the excellent in clinical view. The radiation is more because many series of X-rays are taken. Preparation is same. Within defect you can see ulceration, diabetic lung you can see, but in pregnancy we should avoid, and bowel obstruction is perforation. Perforation के cases में it will go into the peritoneum and will lead to peritonitis. So this is a normal barium solid in this whole of the esophagus you can see here. Specific conditions are there in which the esophageal gap. Here there is a narrowing in the upper part of the esophageal gap. Charts is showing the difference. Here it is in the lower part of the esophagus. You can see the ring, and it is because narrowing into the mucosal or muscular thickness, causing a constriction. Charts is esophageal gap is on the upper side. Here, if you esophageal spasm here, you can see what type of narrowing and dilatation. So here the muscles are dilated and is giving appearance of corkscrew. Ecclesia cardia is nothing but there is a third week, there is narrowing at the lower part, and this is the third week appearance of the lower part of the esophagus, and as it is the narrowing is there in the lower part, the dilatation is on the upper side. So it is like a bird wing type of appearance. Hiatus hernia. What is hiatus hernia? Nothing but a part, upper part of the stomach passes through the diaphragm, the crus of the diaphragm. There is a defect. A crus in the crus of the diaphragm which holds the lower part of the esophagus, and the lower part of upper part of the stomach comes into the esophagus. So there is a dilatation as the upper part of the stomach is coming here, and this is the esophagus. So there is the dilatation, and this is known as hiatus hernia. Now, Ranker's diverticulum, if you know, epitide falls and the true diverticulum. What is false? Is when the mucosa is there. What is true diverticulum? When the muscular involvement is also there. And it's Ranker's diverticulum, it is true or false? It is true. Ranker's diverticulum, it is false or true? It is false. It is here, only the mucosa and the submucosa is. So, the muscle is there, the pharynx, known as cricopharynx. It is having two parts. Between them and the posterior wall, there is a weakness is created, and it will lead to false diverticulum. Functional hypopharyngeal false diverticulum. Because of that, a patient is coming, diverticulum is there. पेशेंट प्रेजेंट कैसे करेगा? फाउल स्पेलिंग आ रही है, कई दिनों से आया है, एंड फाउल स्पेलिंग फ्रॉम द माउथ, एंड ऑल्सो ही इज नॉट एबल टू स्वॉलो, इन्फेक्शन हो गया है पेशेंट। सो वी आर गोइंग फॉर इट, थिंक ऑफ ए रैंकर्स डायबिटीज, वो पाउच बन गया, वहाँ इकट्ठा हो जाता है, फूड वहाँ से निकल नहीं पा रहा है, इन्फेक्शन हो गया है, फाउल स्पेलिंग आ रही है, एंड ऑल्सो फीवर इज देयर। I am showing you a very good diagram. This is a fluoroscopy where you can just diagnose the Ranker's diabetes. Just see. The posterior wall. Can you see the Ranker's diabetes very clearly? This the variant is set at the posterior, the pouch diabetes. You can easily diagnose the Ranker's diabetes. Okay. But sometimes there is a complication. Patient ने लिया, लेकिन गलती से जो है वो लंग्स में नहीं गया। इसके लिए एस्पिरेशन within the various of. So this we should be. We follow through. Generally, we are taking a series. So we are both structural and the motility abnormal, physiological and anatomical. Both we can teach because we are taking in a series. What are the specific conditions? You can see the meat. The meat you can see the stomach. This triangle which is having a duodenal cavity. So this is the part that you can see in the duodenum. You can see the first part of the duodenum where the duodenal cavity is there. And the lower part of the duodenum is pancreatic. Pancreatic of the duodenum you can see because of the folds. Which folds? Mucosal folds. Well, like almond. Here also the duodenum, the lower part of the duodenum also we can see the propeller fibrils. Barium enema, here the enema is pushed to the anus, our meters are pushed to the abdominal part, and postration skin duodenum is pushed from here and going to here, and we are seeing that clear तक आ गया है, then it is we are complete with the procedure, we can go for next. Double contrast effervescence we have given because of the effervescence, the gas is there, and what gas is doing, it is pushing the barium to the wall, and we can see the double contrast, and it is much better to delineate any polyp, any cancer. So, commonly these are the conditions that become intussusception, inflammatory bowel, these are the conditions, and you can see what this is showing. Condition with a large bowel, epic pole appearance, and this occurs in cancer, malignancy. Pyelography is nothing but two types of pyelography that we are having, descending in which the dye is given, and we can delineate the pelvis, the ureter, and the bladder. While in ascending, we are putting a dye, and the urologist take help because we are going through a cystoscopy, and we are seeing the orifice, ureteric orifice, and then putting the dye. And we can see the ureter as well as the ball means a healthy mind. Healthy mind means you can solve any puzzle. The mind is working very sharp. So you can deal with some of the puzzles or some of the cases of AXR. So here you can see a case where the large tumor is massively dilated. So this is toxic megaphone. Second, here you can see a case of obstruction. The small bowel. You can see. What is this? Whole of the human, the wall is there, spring-like pattern is there, like convectus is there. This is the small bowel. Here, what is this stone? At the ureter, there is ureteric stone. What is the diagnosis? It is actually the ulcerative colitis, where ulcerative colitis is a mild constriction diameter. Generally, we are having colon constriction, but here they disappear, and it is a plain wall of the colon, and it is red by appearance. When you see the red by appearance, then there is a case of ulcerative colitis. It is that we have seen double bowel sign, the case of urinary atresia. It is again the sign of human peritoneum. See the regular sign. Regular sign is here. Again, there is a case of large bowel obstruction. And you can see the large bowel is obstructed. Here, this is cross-table view. Cross-table view, where the child is in the supine position, and the air it rise on the anterior, below the anterior abdominal wall. उसमें है कि अगर हम एक्सरे जो है वो इसका इरेक्ट नहीं करा पा रहे हैं तो किस पोजीशन में कराएंगे? क्रॉस टेबल व्यू कहते हैं. And here you can see the ear. This is a case of pneumoperitoneum. What is the diagnosis here? एक बच्चा है, लेकिन ये क्या है? This is the intestine. The intestine is collected like this point. If you see a tub में दे दिया है कि बैलून डाल दिए, तो बैलून कहाँ हो जाएंगे? इकट्ठे हो जाएंगे. तो ये एसाइटिस का केस है. This is a case of ascites. Ascites है पानी भरा हुआ है पेट में और bowels they are sphincteric हो जाता है. You see, this is a case of ascites. Now, what is this case? इसमें क्या किया? एक बच्चा है, उसने क्या किया कि निमोनियम पैदा हुआ, निमोनियम ले गया. लेकिन निमोनियम जो है वो जो इंटेस्टाइन थी वो परफरेट हो गई. परफरेट हो गया उसकी इंटेस्टाइन से जो है वो निमोनियम पेरिटोनियम में आ गया. एंड दैट इज कॉल्ड निमोनियम पेरिटोनाइटिस. कैन सी हियर निमोनियम पेरिटोनाइटिस. हियर वी हैव सीन द gastric bubble. We have seen the here is a case of sexual where the aerobic segment is there and there is a dilatation of the sigmoid bone. This is a case where something is abnormal. This is a case where liver is on the case of citrus syndrome. This is neurosis intestinalis, and it is case of hepatitis and encephalitis, where the walls are having hair. So this is the case of intestinalis. So my point was that X-ray is not a relic, but it is still. We are going for the MRI, we are going for the CT, but still X-ray is still a reliable. It is cost effective, it is easily available, and it depends on the radiologist, the expertise that we can just take the diagnosis from that X-ray.
Thank you so much, sir, for that enlightening session. We'll be proceeding towards the inauguration ceremony. Om Ekdantaya Vidmahe Vakratundaya Dhimahi Tano Danti Prachodaya. We pray to Ganesha as he is omnipresent. We meditate upon him and pray for greater intellect. We bow down asking him to illuminate our minds with wisdom. Good morning, everyone. Respected principals, sir, esteemed delegates, respected chairpersons, distinguished speaker, and honored HODs and faculties. A heartfelt welcome to the grand inauguration of 2025 CME on Imaging Anatomy. We are delighted to commence this transformative event with a cherished left lighting ceremony, a tradition that symbolizes the illumination of knowledge, unity, and as we gather here both in person and virtually, this ritual sets the stage for our journey into the world of anatomical and clinical applications of imaging modalities in diagnosing abdominal ailments. The lighting of the lamp represents the dispelling of darkness with the light of wisdom, mirroring our collective mission to advance medical science and improve patient care. Today, this flame ignites our discussion on cutting-edge imaging techniques, fostering collaborations among experts and learners alike. It is my privilege to invite the distinguished dignitaries to kindly step forward and light the lamp. Please join me in welcoming respected Principal Sir of SM Medical College, Dr. Prashant Gupta Sir, our esteemed chairpersons, head of the anatomy department, and the honored HODs and the faculties of the department. The deity of knowledge, intellect, and creativity. Let us immerse ourselves in this divine invocation as we seek blessings for the success of the CME and the enlightenment of all participants.
Right, sir.
मैम सर की साइड
सर
सही जा
प्रभृति देवै सदा वन्दिता सा मा पातु सरस्वती भगवती निःशेष जायापहा।
छुप जाएंगे लेकिन
कौन मारना है
सर एक ग्रुप फोटो
ऊपर यहीं खड़े हो जाते हैं
सर यहाँ पर
आ जाएगा बिल्कुल है आइए सर इधर आते हैं सर प्लीज कम ये हटा दिए ट्री हटा दिए
आ जाएंगे मैम इस साइड
वेट करना
As the lamp is lit, let us take a moment of silence to reflect on our shared commitment to knowledge and excellence. May this light guide us through the insightful sessions ahead over this day. Having inaugurated the 2025 CME on Imaging Anatomy with the auspicious lamp lighting ceremony and the divine rendition of Saraswati Vandana, we are now ready to proceed with the formal proceedings of the day. At this juncture, I would like to respectfully invite our esteemed dignitaries to take their seats on the dais, from where they'll guide and grace this conference with their presence. The respected principal of SN Medical College, Dr. Prashant Gupta sir, whose visionary leadership has been cornerstone of this event. Dr. Anshu Gupta ma'am, head of the Department of Anatomy and organizing chairperson of the CME. Dr. Pradeep Singh sir, associate professor in the Department of Anatomy. Dr. Ashok Sahai sir, a prominent personality in the field of anatomy. Dr. Ashok Gupta sir, a pioneer visionary in the field of anatomy. I would request Dr. Racha Gupta ma'am to Dr. R.C. ma'am to kindly welcome Dr. Pradeep Singh sir. Dr.
देखिए सर
ma'am to kindly
सर इधर
welcome Dr. Ashok Sahai. Dr. Neetu ma'am to kindly welcome Dr. Ashok Gupta sir.
मैम इस साइड देखो मैम
अरे यार आप
मैम मेरी साइड
मोबाइल है बीच में
It is my privilege to now invite the dynamic and a dedicated leader, Dr. Anshu Gupta ma'am, professor and head of Department of Anatomy, Sarojini Naidu Medical College, Agra. Dr. Anshu Gupta ma'am's unwavering commitment to academic innovation, research excellence, and departmental leadership has been instrumental in bringing this CME to life. Our vision and mentorship continue to inspire faculty and residents and students alike. Ma'am, we are truly honored by your presence and guidance. May I now invite you to the podium to share your enlightening thoughts and formally welcome the gathering. Please applaud.
Respected Principal Sir, Dr. Prashant Gupta, distinguished speaker, esteemed chairperson, valued delegates from various medical colleges of UP and nearby state, and honored guests, all HOD, faculty members, PG and UG students. A very warm afternoon to you all. It is my great honor as the head of Department of Anatomy and organized chairperson of this CME, I, Dr. Anshu Gupta, to extend a heartfelt welcome to each of you at this CME, Imaging Anatomy. Whether you are joining us here at our esteemed institute or virtually from around the country, your presence enriches the gathering of knowledge and innovation. First and foremost, I express my deepest gratitude to our principal, Dr. Prashant Gupta sir, for your unwavering support, visionary leadership. Your guidance has been instrumental in making this CME a reality, and we are privileged to have you with us today. To our distinguished speaker, your expertise and groundbreaking insight are the foundation of this event. We eagerly anticipated the wisdom you will share to inspire and challenge our thinking. To our esteemed chairperson, your leadership in guiding our session ensure that our discussion will be insightful and inclusive and impactful. And to our delegate, your diverse perspective, enthusiasm, and dedication to the CME make this platform a vibrant hub for collaboration and discovery. This CME is a platform of knowledge and space where we come together to explore various domains of radiology, integrated with anatomy, and forge pathway for progress. Over the next few hours, let us engage in the meaningful dialogue, share bold ideas, and build connections that will shape future of our field. I extend my sincere appreciation to the organizing committee and staff whose tireless efforts have brought this event to life. Together, let us make this CME a transformative experience, one that sparks inspiration and drive action. Once again, welcome to Imaging Anatomy. I wish you all the enriching, productive, and memorable time ahead. Let us embark on this journey of knowledge and collaboration with enthusiasm. Thank you.
On behalf of entire organizing committee and Department of Anatomy, I extend my heartfelt gratitude to Dr. Anshu Gupta ma'am, Professor and Head of the Department, for an inspiring and insightful address. Ma'am, your words have beautifully reflected the academic spirit and vision that have guided the planning and execution of the CME. Your encouragement, leadership, and unwavering support have been backbone of today's success. Thank you for setting the tone for the enriching day of learning and collaboration. We are truly privileged to have your guidance and presence among us. As we gather here for this academic celebration, the CME on Imaging Anatomy, it is my proud privilege to invite a visionary leader and the pillar of this institution, our respected Principal Sir Dr. Prashant Gupta Sir, to deliver his inaugural address. Dr. Prashant Gupta Sir's unwavering commitment to academic advancement and institutional excellence have been a constant source of inspiration for faculty and students. His support has been instrumental in organizing the CME, which bring together experts from across the country to share and shape the future of anatomical imaging and clinical practice. So we are honored by your presence today. Now, may I now respectfully invite you to the podium to enlighten us with your words of wisdom.
Ashok sir, Dr. Ashok Gupta sir, Dr. R.K. Shokandi, senior guest faculty members who are here from different medical colleges. हमारे रेडियोलॉजी के हेड ऑफ द डिपार्टमेंट डॉक्टर हरी सिंह, बाकी हमारे अन्य डिपार्टमेंट्स के हेड एंड फैकल्टी मेंबर्स डॉक्टर शिखी मैम फ्रॉम फिरोजाबाद. Department of Anatomy is organizing today CME. The topic is focusing on anatomical and clinical applications of various imaging modalities. I think this is a very novel and innovative idea by the Department of Anatomy. It is a department जहाँ सबसे पहले medical students का एक कैटेगरी से आमना सामना होता है. दो चार दिन भी जाते हैं उस समय, आवाज भी आती है. और हमारे यहाँ तो एनाटॉमी डिपार्टमेंट से सबसे खतरनाक इसलिए माना जाता है क्योंकि ये सबसे ऊपर की फ्लोर पर है. अब डायसेक्शन हॉल इज ऑन दी ग्राउंड फ्लोर और रैगिंग का भी सबसे बड़ा खतरा एनाटॉमी में जाने में ही होता था. इसीलिए सर एनाटॉमी में जो भी रहता है जैसा भी है वो सब तो हम चाहते हैं, बट मेरा पर्सनल मानना है एंड आई कैन से देयर इज वन फैकल्टी हु इज सिटिंग हियर. एक्चुअली ही इज अ रियल एनाटॉमी सिटिंग विद अस. ही इज डॉक्टर हरी सिंह. ही इज ऑल बेस्ट एनाटॉमिस्ट. इन्होंने किस तरह से पढ़ी थी तो यही जाने, लेकिन हम इनसे पढ़ते थे और इमेजिंग की कोई जरूरत नहीं थी, किसी एटलस की जरूरत नहीं थी. यू आस्क फॉर एनी नर्व, यू आस्क फॉर एनी आर्टरी, यू आस्क फॉर एनीथिंग इन दी कैटेगरी. ही इज द पर्सन, ही वाज द पर्सन जो इतना फैंटास्टिक डायसेक्शन करता था. इट इज द रियलिटी. एनाटॉमी इज द थिंग जो जीवन पर एक क्लिनिशियन के साथ हमेशा रहती है. और फॉरेंसिक में बैठने के बाद उनके पास भी जरूरत होती है. इट्स अ फैक्ट. अगर आप गौर से देखें तो रेडियो डायग्नोसिस डिपार्टमेंट के अंदर रेडियोलॉजिस्ट नीड टू नो द परफेक्ट एनाटॉमी ऑफ द बॉडी. देन ओनली वी कैन गिव एनी काइंड ऑफ एडवाइस टू एनी इन्वेस्टिगेशन लाइक एक्सरे और एनीथिंग जो भी है. जैसे डॉक्टर प्रदीप सिंह जी बता रहे थे कि एक्सरे इज अ वेरी रिलायबल टूल. यस, इट्स अ ट्रू, बट द प्रॉब्लम विद एक्सरे इज नाउअडेज माहौल नहीं बनता है, मरीज को समझ नहीं आता है. मुझे लगता है कि एक सीटी नहीं हुआ डॉक्टर साहब, एक सीटी करा लेते तो और अच्छा पता लग जाता. नाउ दिस इज द प्रॉब्लम विद ऑल ऑफ अस. दे rely more on the investigative part, not the clinical judgment of the clinician. This is a big problem with all of us. And this is a thing. भाई हमारे समय में सीटी नहीं था. हम सर्जरी में रेजिडेंट थे तो सीटी नहीं था. हमसे पीछे चल रहे हैं तब सीटी नहीं था. तभी वो रोड बनाया जाता था इसी कॉलेज के अंदर ऑन द बेसिस ऑफ क्लिनिकल जजमेंट ऑनली. जितने भी लेबोरेटरी हम लोगों ने किए इट इज ऑन द बेसिस ऑफ राइट एक्सरे एब्डोमेन ऑनली. ये सब बात तो है ही और इट इज अ गुड थिंग. डॉक्टर मोदी मेरे ख्याल से, और मैं रेडियोलॉजी में भी बोलना चाहूँगा, रेडियो डायग्नोस डिपार्टमेंट में और बाकी सारे डिपार्टमेंट जो क्लिनिकल हैं और एनाटॉमी पर से इट्स अ गुड थिंग कि हमें अपने बेसिक मोडालिटी ऑफ इन्वेस्टिगेशन पर विश्वास करना चाहिए और उस पर एम्फेसाइज करना चाहिए. दे गिव लेसर डोज ऑफ रेडिएशन टू द पेशेंट एज वेल एज टू द एनवायरमेंट. If I am not wrong, I think one whole body CT scan emits radiation equals to 700 chest X-ray. Gross में अगर बात करें, how much radiation is emitted? ये सारी चीजें रहती हैं. तो कोशिश हमें ये करनी चाहिए. And I wish all the best to the anatomy department. You are doing great. Anatomy department वास्तव में बहुत अच्छा कर रहा है. 200 बच्चों का बेंच हुआ. Suddenly we have an extra strength of 72 students. They have done very good to accommodate the additional 72 students. बाकी भी आपके द्वारा जो किया जा रहा है वो बहुत सा किया जा रहा है. हमारा एक साथी कमल भारद्वाज, somehow he is not, or rather we could say he has left us. मजार में छोड़ के गए को ध्यान रखना इस बात का. अच्छी चीज नहीं है. नहीं, तैयार करने का प्रयास कर रहे हैं लेकिन ये गलत है. इट्स योर डिपार्टमेंट, आप हैं, अंशु है, प्रदीप है, तो ये अच्छी बात नहीं है। ठीक है, आप लोगों ने मिलकर कुछ इनिशिएट किया था जिसको हम लोग कर रहे हैं, याद है ना? ये नया जो मॉर्चरी बना है पीछे उसी में बना है, क्यों अंशु? तो थोड़ा ध्यान रखिए इस बात का। अपने इंस्टीट्यूट में जहाँ से आप पढ़े वाले हैं, जहाँ से आप निकले हैं, वहाँ थोड़ा दिल भी दो यार, ठीक है? पैसा तो आएगा ही चीजें जीवन में, आज है कल नहीं। आजकल ऑनलाइन हैकिंग सिस्टम इतना हो गया, पता ही लगेगा आपके अकाउंट से 22 लाख 50 लाख निकल जाएंगे, फिर क्या करेंगे? कुछ नहीं पता लगता है। My anesthetiist, to whom I know, he has lost 24 lakhs. This online hacking system, digital arrest. हाँ, एक चीज मैं आपको बता दूं, which recently I had, this is a good thing to tell you everything. ये अभी recently 3 दिन पहले हुआ है। I think you all know Ketan, Kumar Ketan in famous as well. Most of us will know. His mother received a call 3 days back, and through the AI, the voice was of Ketan. केतन की आवाज में उसने AI के थ्रू आर्टिफिशियल इंटेलिजेंस को उसकी आवाज क्रिएट की और माँ को बोला पैसा देने के लिए, citing something in emergency. His mother, who was not properly able to walk, she went to the bank and transferred the money. So be aware of this thing. बाकी सारी चीजें ठीक है, but now this AI is also being used for this digital kind of fraud. So, on the point, Dr. Anshu, Dr. Pradeep, बाकी डिपार्टमेंट्स के फैकल्टी मेंबर्स, आप सभी को ढेर सारी बधाइयाँ। सबसे अच्छी बात मेरे को लगी कि हमारे 2 सीनियर फैकल्टी मेंबर्स, डॉक्टर अशोक सर एंड डॉक्टर अशोक सर, who are here with us from such a far part. Dr. Sri Gupta, he is still alive. And he must be around 97 years old. He 98, 97 I think. I think 2 years back he was with us in this institute only. We loved his like enthusiasm. मतलब उनका ये था कि मैं चलकर जाऊंगा, 1 मंजिल ऊपर ऑडिटोरियम में वो चलकर गए, हमारे साथ पूरे टाइम रहे। अच्छा लगता है सर, जो कि एनाटमी हमारे साथ ना दिल से जुड़ा सब्जेक्ट है। सब्जेक्ट इसलिए सबसे पहले हम यहीं आते हैं और यहीं से हमारा जीवन शुरू होता है एज अ डॉक्टर, और वहीं से सारी बात चलती है। और जब आप आते हैं MBBS में तो आपके घर वाले भी कहते हैं, पूछते हैं हाँ भाई क्या रहा, आज कुछ देखा, किसी मुद्दे से सबाखा हुआ, पाला पड़ा कि नहीं पड़ा। इट इज द डिपार्टमेंट। तो अच्छा लगता है सर, यहाँ से सब कुछ शुरू होता है। डॉक्टर समरेन, क्या हाल है सर? ठीक है, कैसे मैडम आप? ठीक है। डॉक्टर समरेन के साथ में कुछ समय के लिए सफाई में था और डॉक्टर समरेन ने सफाई में ऐसा शाकुत किया, उसके बाद कोई दूसरा रेडियोलॉजिस्ट और आया ही नहीं। पता नहीं वहां क्या कुछ करके गए हैं। Nobody could have joined over there since then. Am I right or? But he did fantastic job in SFI. He established the radiology department in SFI. He started CT. I think हमारा भी तब आ गया था everything. And after that, he is doing fantastic job in RML. Thank you so much for coming. And I hope बाकी के आपके सेशंस रहेंगे, सब कुछ अच्छा रहेगा। और एवरी स्माइलिंग शिकी मैडम इज हियर। हम मैडम से नंबर से आपको स्माइल देता है। Actually, Dr. Harishing and me, both are batchmates. So, Ola the deeper first level. He is so cute, बहुत cute. Well, your batch, senior batch, was very good. हम लोगों के दिल से लगा हुआ बैच था और सुबह मजा भी बहुत आता था। खैर एनीवे ये सब तरीके की बातें हैं, अच्छा लगता है अपने लोगों के सामने कुछ बात करना, ठीक भी बात हो जाती है। बाकी एकेडमिक्स है, इट्स अ गुड एकेडमिक फीस। आई थिंक संख्या बढ़नी चाहिए, एनाटॉमी के और बच्चे आते तो बेहतर रहता। और कॉलेजेस को कोशिश हमें करनी चाहिए इस तरह के सेशंस के लिए हम बाकी कॉलेजेस के टीचर्स से बात करके नंबर ऑफ रेजिडेंट वहाँ से जितने ज़्यादा संभव हो बुलाने का प्रयास करें, क्योंकि एनाटॉमी डिपार्टमेंट पर से अगर इस तरह का प्रयास करो ये बहुत बड़ी बात, बहुत बड़ी। थैंक यू सो मच।
What an inspiring address we have just heard from our esteemed principal, Dr. Prashant Gupta sir. His visionary words have set a profound tone for the 2025 CME on Imaging Anatomy. To express our gratitude and honor his valuable contribution, it is now my privilege to invite the esteemed dignitaries on dais to stage for special felicitation of Principal Sir. Please join me in welcoming Dr. Anshu Gupta ma'am, Dr. Pradeep Singh sir, Dr. Ashok Sahai sir, and Dr. Ashok Gupta sir to present a token of appreciation to our respected principal sir. We request Principal Sir to kindly felicitate Dr. Ashok Sahai Sir and Dr. Ashok Gupta Sir.
नहीं भाई वो भी नहीं भाई
Please join me in welcoming Dr. Anshu Gupta ma'am and Dr. Pradeep Singh sir to present a token of appreciation to our respected principal sir. CME, a mentor, a guide, an excellent educator to kindly share a word of thanks. Thank you, Dr. Yekika. Respected Principal Sir, distinguished guests, esteemed Head of Departments, faculty members, delegates, and students. Being the organizing secretary of CME, I, Dr. Anjali Gupta, deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. Let me first of all start by thanking the Almighty God for giving us an opportunity to make today's program a resounding success. As William Arthur Ward rightly said, feeling gratitude and not expressing it is like wrapping a present and not giving it. Kritanyata yah karta sayogi viniyojay, which translates to one who performs with gratitude is a yogi. Today, I take the opportunity to express my deepest gratitude and appreciation to all those who are making the event successful. To begin, on behalf of Organizing Committee and Department of Anatomy, I would like to express my sincere gratitude to our Chief Patron, respected Principal Dr. Prashant Gupta Sir, for their steadfast dedication and leadership. With his dynamic personality, his guidance has been invaluable in fostering a positive learning environment. Thank you, sir, for your continued support and guidance. Next, I extend our deepest sense of gratitude to our renowned anatomist, Dr. Ashok Sahay sir, Dr. Ashok Gupta sir, who is spared time from their busy schedule to grace this occasion and share the session. Thank you so much, sir. We are deeply indebted to our distinguished chairpersons and speakers whose scholarly expertise and insightful presentations have significantly enriched our understanding and elevated the academic rigor of the program. Our heartfelt appreciation goes to our delegates, that is, faculty members, senior and junior residents from other medical colleges, whose support have been instrumental in bringing this event to fruition. Without you, today would not have been a magical one. My heartfelt thanks to heads and faculty of various departments of Snmc for their presence and encouragement in all our efforts. Now, this is the time to extend my sincere gratitude and hearty appreciation to Head of Anatomy Department and Organizing Chairperson, Dr. Anshu Gupta ma'am, for her meticulous planning and steadfast commitment. I thank Organizing Chairperson, Dr. Pradeep Singh sir, Organizing Secretary, Dr. Vibhuti, Registration in charge, Dr. Anita Rawat, and Finance in charge, Dr. Kamal Bharadwaj, for their exemplary diligence and dedication. Your efforts in orchestrating this seamless and impactful program deserve the highest commendation. We also acknowledge the invaluable contributions of our junior residents, Dr. Yagika, Dr. Shruti, Dr. Shalini, Dr. Lokesh, Dr. Krishna Kumar, Dr. Shweta, Dr. Sandeep, and Mrs. Jyoti, whose tireless efforts answered the smooth execution of this program. A big thank to the technical staff, Mr. Winning, and support staff of Department of Anatomy for their relentless efforts. Last but not the least, our heartfelt thanks to our volunteer students of MBBS batch 2022, 23 and especially 24, whose active engagement and enthusiasm have made this program a resounding success. To conclude, we all love you people. To conclude, let us carry forward the knowledge and inspiration
again today to further our collective mission of excellence in healthcare. On behalf of Department of Anatomy, Snmc, Agra, I once again express my deepest gratitude to all who have contributed to this enriching experience. We look forward to your continued support and participation in our future endeavors. Thank you and a fruitful day ahead. Thank you.
Thank you so much, ma'am, for your words. I humbly request all our valuable guests on behalf of Department of Anatomy to proceed for lunch. Kindly proceed for lunch. Delegates may collect the certificates from the registration counter. Thank you. We'll be starting our next session at 1:30 sharp. Thank you.
ये पीछे आके खींचो यार, नहीं खींच रहे हैं।
Thank you very much, Dr. Pradeep sir, for your insightful and enriching session. Now I take the honor of inviting our esteemed chairperson, Dr. R.K. Shoga sir, to come forward and felicitate Dr. Pradeep sir as a token of our appreciation and respect. Please welcome Dr. Pradeep sir and R.K. Shoga sir.
सर को बैठा
I now invite Dr. Ashok Gupta sir to kindly come forward and felicitate our respected chairperson, Dr. R.K. Ashoka sir.
Esteemed delegates, respected chairpersons and honored guests, we are continuing to gain invaluable insights at the 2025 CME on Imaging Anatomy, and I am delighted to welcome you to the 5th session of the day. After the enriching discussions in our previous sessions, we now turn our attention to a vital imaging modality that plays an important role in clinical diagnostics. It is my great pleasure to introduce our speaker for this session, Dr. Nikhil Sharma sir. Dr. Sharma is Director for Anuram Healthcare Agra. He has multiple prominent and impactful research publications in his name. Dr. Sharma is a distinguished expert in radiodiagnostics. He has extensive experience in ultrasonography and his contribution to abdominal diagnostics have made him a respected authority in our field. Today we will share his expertise on clinicians' window to abdomen ultrasonography, a topic that will enhance our understanding of how ultrasonography can be effectively utilized in diagnosing abdominal ailments, offering a non-invasive window into clinical practice. Before we begin, allow me to introduce the chairpersons for this section, Dr. Ashok Sahai sir and Dr. Ashok Gupta sir, who will guide our discussion with their expertise and ensure a productive exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Nikhil Sharma sir to the podium.
Respected faculty members, seniors, my colleagues and dear students, a very good afternoon to all of you. I am Dr. Nikhil Sharma. I am also working as an associate professor in our college, SS Medical College. We will be discussing on the clinician's window to abdomen in the form of a very handy modality, that is ultrasound. And to start with, I want to say that radiodiagnosis is basically delineating the normal anatomy through which we have read in books into a patient through various modalities. Whatever modality we can use, we just have to first delineate what the normal anatomy we have read, is it visible in the patient or not. And when we see any difference between the normal anatomy which we know and what we can see on any modality, that drives us to the diagnosis. So anatomy is very much related to each and every branch of medicine, especially for the diagnosis. And as I was told that this CME is basically for the major orientation of major radiological orientation of our MBBS student. So I have tried to keep the things to very simple in understanding what ultrasound as a modality is and how it can help us in imaging of the abdomen. So I will be just discussing a bit about how ultrasound works, what is its physics, what are the probes and modes on which we perform the ultrasound, before going into some of the diagnostic features of ultrasound in abdominal imaging. So ultrasonic waves, as we all know from basic physics of 12th class, any sound waves which have higher frequency from the audible waves of human ears are called as ultrasonic waves. So this modality ultrasound is using those ultrasonic sound waves to create an image. Like we all have also read this technology is naturally used by many of the animals like bats and dolphins. They produce ultrasonic waves which reflects from some object and they create an imaginary vision of that object in their mind, from how far it is being reflected. It is the same principle which our engineers use to image our body. The machine used to create some ultrasonic waves. We used to pass those waves into our body. The various organs of our body, they reflect the ultrasound waves at a very different rate or different number. So what is the reflectivity of any organ for the ultrasound wave? This is the thing which the engineers use to create an image. The basic question is, how can we create a two-dimensional image or an image on a screen from a sound wave which is coming back to us? How can we? So there is a very basic physical effect which is called as a piezoelectric effect, because all these works are being done by the computers and computers know only the electrical signals. So there are some substances like quartz and which are called as piezoelectric materials. Whenever an electricity is passed through them, they will tend to produce an ultrasonic wave or ultrasound. And when an ultrasonic wave hits those substances back, then they will produce an electrical signal in reverse. So this basic effect was the principle of creating the ultrasound and used by our engineers, but this is not for much of use for us to understand, because it is for the engineers to understand. What ultrasound physics do we actually need to know is very important. That ultrasonic waves, high frequency sound waves, they can have various frequencies starting from 1 megahertz to 20 megahertz, which we can use in the ultrasound. Higher the frequency of a sound wave, lesser is the penetration into the body. This is the basic thing. But higher is the resolution. जितनी फ्रीक्वेंसी ज़्यादा है साउंड वेव्स की, हम जो यूज कर रहे हैं अपने अल्ट्रासाउंड में, जितनी ज़्यादा फ्रीक्वेंसी का हम साउंड वेव यूज कर रहे हैं, इट विल पेनेट्रेट लेसर इन द बॉडी. बट जितनी भी डेप्थ तक वो पेनेट्रेट करेंगे, इट विल क्रिएट अ हाई रेजोल्यूशन. The lesser is the frequency of the sound wave used, higher is the penetration, but lesser is the resolution. So this is the basic thing which we need to understand to know what kind of probe, or we call them as transducers, which we need to use for different things. So it is very important by doing an ultrasound to choose for the right transducer. And in our ultrasound, we have various kinds of transducers, like a curvilinear one, which is generally a low frequency transducer. You can see on your screen that the frequency of a curvilinear transducer is 2 to 5 megahertz. That means it has a lesser frequency, so it can penetrate into a greater depth. So we can generally scan all the abdominal organs through this curvilinear probe. There is a high frequency probe which is generally a linear probe or an endocavitatory probe like a transvaginal or transrectal probe. These probes have a higher frequency as compared to the curvilinear probe, and higher frequency makes them less penetrative but with a high resolution. So whenever we want to scan some organs which are lying very superficial, like the cutaneous, subcutaneous or superficial tissue, but with a high resolution, then we need to have a high frequency probe. Also the shape of the probes have been designed as such. So the curvilinear low frequency probe is a curvilinear broad probe which can cover more distance, like we have to scan the complete organ, complete abdomen, so we need a larger scanning area at once. The linear probe generally focuses on the superficial parts of a very small area. It is lesser in its length. Then there are some phased array probes, or we call them as an echo probe. The surface area you can see in the phased array probe is very small. So it is used when we have a very small window, like in cases of echocardiogram. So when we do a echo, 2D echo, the window we have is intercostal space, and we need to peep through that intercostal space. So we need to have a probe which is very small in surface area and can generate the sound waves through that area only. And then we have an endocavitatory probe like a transvaginal or transrectal probe, in which we tend to reach to the organ of interest, either uterus or prostate. We need to reach to the nearest to the organ through the vagina or through the rectum, and these probes are generally high frequency probes. They do not need a very high penetration, but they need a very high resolution. So depending upon our requirement, we can easily now think which probe we need to use. Like in an abdominal imaging, if I want to, I am doing an ultrasound of a very fatty patient. So the abdominal girth is very high. Obviously, the linear probe is not going to help me. We have to do it on with a curvilinear probe. But if I have a child, 2 years, 3 years old child with a very less abdominal girth, I can even scan his abdomen with a linear probe with a very high resolution. So we can choose our probes as per our requirement. And the very good thing with our ultrasound modality is that it is a dynamic thing. Dynamic thing is that it does not have any fixed particular scanning planes. You can rotate your probe in any manner over the surface of the body as per the requirement, as per the alignment of the organ, and you can generally we do a sliding motion. We can slide it up and down. We can tilt it to see a oblique plane. We can rotate the thing. You can see while rotating, initially the vessel was in an axial plane looking round over here, and then we rotated the probe, and we can see the whole length of the vessel. So every kind of motion is possible. It's a dynamic scan. It's a real-time modality. Other modalities are generally not real-time. They generally capture the picture, and then we have to review those pictures only in some planes. Compression, and we can put compression on the tissue. We can see its mobility also. So ultrasound is a very good in this manner that it's a very dynamic and real-time thing. So ultrasound generally has a B mode, which is practically we are doing the imaging, which is called as a brightness mode. So B mode generally, for a very simple understanding, it creates a two-dimensional image of the organ which you are scanning. The other mode is M mode. M mode is generally a motion mode. Motion mode means it generally shows the motion of the surface of organ in a linear manner. So it is generally used when there are various membranes which are moving at a different rate, and like in an echocardiography, the various walls and septums of the heart, they are moving at a different rate, and we want to see how much they are moving, how much is the motion. So we generally tend to use it there in the M mode in an echocardiography. So ultrasound has some enemies also, which limits its use. What are the enemies of the ultrasound? To be very basic. First enemy is the bone. Our sound waves does not penetrate through bone. So जहाँ भी there is a bone, we cannot use ultrasound. Our skull is a bony skull, we cannot peek through it into our brain. So we cannot use ultrasound for brain except when we are imaging a newborn. The newborns have some window between the bones, that is spontaneous, anterior and posterior spontaneous, which are not used. Yes, we have a window. हमारा enemy वहाँ नहीं है, हमारी bone वहाँ नहीं है. We can do an ultrasound of a brain until our spontaneous are not fused. Once they are fused, we are helpless. We cannot image a brain, adult brain through ultrasound. The other enemy is air. Air generally is very a light medium. Sound waves needs to travel from a medium of similar density. That is why we are using jelly while doing an ultrasound. What is the rule of that jelly which most of the patients hates while doing the ultrasound? The rule of jelly is the transducer is producing a sound wave. The sound wave passes through the jelly. The jelly fills all the air gaps between the transducer and the skin and the cutaneous surface, and the sound wave is easily penetrated into the body. But whenever the sound wave meets the interface where the air is, it reflects that. It does not penetrate through that organ wherever the air is. So air is a very lighter medium. So there is we had read physics. So there was a concept of internal reflection, mirage formation. The same thing happens. Wherever the sound wave meets an interface where air is present, it generally reflects back from there only. It does not penetrate into that organ. So any organ which has air inside will be our enemy. Like we cannot image a lung pathology. Lung pathology, which is deep into the lung, which is surrounded by air, we cannot image it on ultrasound. We cannot image an intraluminal pathology of bowel very confidently on ultrasound. Why? Because there is surrounding air around it. So wherever there is air, it will try to make difficulties for us during ultrasound. So another requirement for preparing a patient for abdomen is कि खाली पेट आना. खाली पेट आने का दो कारण है. There are two basic reasons. One is that whenever you eat food, the food tends to create more air in your bowel. And whenever there is more air in the bowel, the epigastrium is distended with air, we cannot pee through it. Our diagnosis will become difficult. The other reason is the gallbladder, which I will be telling you later. Gallbladder, we want to look gallbladder very well on ultrasound, and gallbladder is generally not contracted when we are empty stomach, when we are fasting. And as soon as we eat food, the gallbladder tends to contract and release bile. A contracted gallbladder is, we can miss findings in it. So we need a well-distended gallbladder, and we don't need air in our stomach, lesser air in our stomach. So we call the patients empty stomach or in a fasting state. Second thing is while we are scanning a pelvic organ. So pelvic organs in females, males, they are like just posterior inferior to the urinary bladder. And when urinary bladder is not full, there is surrounding bowel loops which are having air inside, so it's very difficult to scan the pelvic organ. When we ask the patient to hold the urine, we generally ask patient to hold urine while for an abdominal ultrasound. Why? Because when the bladder is full, so there is a water medium. Water is a friend of ultrasound. It tends to transmit the sound waves, any fluid, it tends to transmit the ultrasound waves through it very easily. So the sound wave which we are releasing on the surface goes beyond the urinary bladder, and we are able to image the organs which are posterior to the urinary bladder. So only two requirements for an abdominal ultrasound, which every center asks you before doing an ultrasound. Please come in a fasting state. You know the reason why. Please hold your urine. So if now you only want to get your liver ultrasound done or already ultrasound done, you don't want an hysterectomy, you don't have to hold that much of urine. So this is just a thing when you should know what are the enemies of ultrasound. But there is a third enemy of ultrasound also, which I am not revealing right now. I will be revealing it later. Coming to the preparation of ultrasound, which I have already told you, what are the prerequisites for an abdominal ultrasound, why we call patients fasting and ask them to hold the urine, which transducers we tend to use. I have told you ultrasound work is more, we need a deeper penetration, we need a low frequency probe. Low frequency probe, a curvilinear probe is a low frequency probe. When we need to scan some superficial organs with better resolution, we need a linear probe or a high frequency probe. As simple as that. So coming to the basic images, basic techniques of scanning our abdominal organs, and I will be discussing a very few of the organs, otherwise it's a very vast thing. So all of us know where the liver is placed in the body. Whenever we will place the probe above the liver, it will give us the image of the liver, but in a two-dimensional plane. We have to understand the physics, that there is a two-dimensional wave which is going inside the body. It will move in a linear direction, it will reflect back and come back in a linear direction. So जिस भी प्लेन में हमारा प्रोब है, उस प्लेन में आपको एक two-dimensional image मिलेगी. As we will change our plane, as we will move our probe, तो हमारा इमेज का डायरेक्शन बदल जाएगा. So we should be knowing a basic anatomy of the organ in our mind. That liver is, what is the shape of liver? If we want to measure the size of the liver, we have to place our probe in the mid-axillary line. When we will place the probe in mid-axillary line, what will happen? The probe will give an image of the complete length of the liver, and the image will come like this, and we will be able to measure the size of the liver. The other important thing is, what is the normal size of the liver? What is the normal size of a liver which we take as a standard is 15 to 16 centimeters in Indian population. So another thing, important thing which we comment on an ultrasound is its echogenicity or echo texture. You would have heard it or seen it in the reports with normal echo texture. What is this echo texture? Basically, what is this image? This is a reflection or an echo which is coming from the organ. Every organ has different reflectivity as per its density for the sound waves. So whatever the echo which is reflected back, its quality on a 2D image is its echogenicity or an echo texture. There is no fixed parameter to measure any echogenicity. It's a relative parameter. If we are seeing two organs over here, one is liver and one is kidney adjacent to it, we can see that liver is brighter and kidney is slightly lower in echogenicity. So this is its echogenicity. Then liver is brighter than kidney. Normally it is like this only. So what happens to this echogenicity? It changes in various pathologies. And when it changes, when we are doing the ultrasound regularly, our eyes are used to what is the normal echogenicity of any organ. Whenever we see any derangement from that echogenicity, it tricks us for the diagnosis. So whenever there is an acute hepatitis, what will happen? Acute hepatitis, there is an inflammation of liver. Wherever there is an inflammation, there is some edema, increase in extracellular fluid, everything. And fluid, I tell you, is a friend of ultrasound. It generally permits the ultrasound waves to pass through it. So it will reflect it less. It will be less brighter. So whenever there is fluid more, it will be a blackish image on the ultrasound. The echogenicity will be low. So the brightness of the liver will reduce in acute hepatitis whenever there is a inflammation of liver. And what about the walls of portal vein? Generally, it will look brighter. It does not become bright because the surrounding liver echogenicity has become low. The walls of portal veins which are running inside the liver, its echogenicity will look bright. So it will give us a very, I'll just show you, sky appearance. Then what happens in the chronic hepatitis or cirrhosis? fibrosis. The liver tends to shrink. This is also to note that any fibrous tissue or a sclerotic tissue, it will also look a less ecogenic on ultrasound. So the liver ecogenicity drops and the brightness of portal venous walls also drops because now there is no fluid adjacent to it, there is a fibrous tissue adjacent to it, so there is no reflectivity which is increasing. Brightness of portal venous walls also drops. What happens in a fatty liver? Whenever most of you would have got your ultrasound done once or sometime in your lifetime, so most of us have a fatty liver. What is fatty liver or hepatic steatosis? In a hepatic steatosis, there is increased fat within the liver parenchyma, and fat has a higher reflectivity for the sound waves, lesser penetration through fat for the sound waves. So fatty tissue looks brighter. The liver's ecogenicity will increase. The fatty tissue looks brighter, and that brightness dampens the ecogenicity of portal venous walls. This is the image of a acute hepatitis patient. You can see the liver ecogenicity. Earlier what the liver we had seen, it was a bit brighter. Now in this image the liver ecogenicity is dropped. There is some acute inflammation, and the ecogenicity of portal venous walls has increased, which is it's looking like a starry sky. The walls of portal vein are looking like stars in a dark sky. So this starry sky appearance is very pathognomic for the acute hepatitis. These are some images of liver cirrhosis. Liver tends to fibrose, liver tends to shrink. You can see the margin of the liver here. The margins are a little bit nodular. Generally, whenever we have a cirrhosis, we have a portal hypertension triad of ascites, splenomegaly and all. So with the ascites, with the fluid around the liver, which is appearing as dark in this image, any fluid will appear dark because it is not reflecting anything. It is allowing everything to pass through it, every sound wave. So fluid जो है हमें अल्ट्रासाउंड पर काला दिख रहा है. Fluid के बीच में liver की margins हमें बहुत अच्छी दिख रही हैं, and we can see that the margins are nodular, and in this image also we can see the margins are nodular, and we can see the caudate lobe hypertrophy with also in this image, last one. So this is also pathognomic for the liver cirrhosis. This is a fatty liver. The normal ecogenicity of the liver is increased. If you are not able to appreciate it here, look at the other image. It is even fattier. It's a grade 2 fatty liver in which the liver ecogenicity has highly increased, and we cannot see the bright and ecogenic walls of portal vein in this image. Now, any cyst in the body is what? What is a cyst? It's a fluid-filled space. Fluid-filled. Fluid-filled मतलब not reflecting any echoes. यानी कि anechoic, यानी कि काली. Any cyst, pure cyst, without any intrinsic other contents than the fluid, will look dark. Any cyst. We can have cysts, a lot of cysts in kidneys, in liver, anywhere. They are generally benign, a purely simple cyst, anechoic, completely anechoic cyst. But whenever we have some echoes within the cyst, that means we have some septation, some echoes, something which is within the cyst and it is reflecting echoes. What it can be? It can be something mixed within the fluid. It can be a hemorrhagic fluid, it can be a pus, it can be anything, but it's not a simple cyst. Generally, abscess tend to look like, I'm showing the picture of an abscess, a hepatic abscess. It has some pus content. Pus has various debris, various cells inside the cyst, which is reflecting as a low-level internal echoes. So it's a liver abscess of pus-filled mass within the liver. Coming to the other organ, that is the gallbladder. We all know the location of the gallbladder. It's near the porta hepatis in subhepatic space. We can put our probe there. We can see a very gallbladder is filled with what? It is filled with bile. Bile is a fluid. If it is not dense, the bile is not dense. If the bile is very fluidic, it will not reflect echoes. It will be a very anechoic structure, elongated anechoic structure. Anechoic elongated structure. You can see the gallbladder in its fundus, body, neck, everything. Adjacent to the gallbladder is another anechoic structure, that is the blood vessel. Blood vessel पे जब तक हम we don't put a Doppler, we don't put a color Doppler. Until then on a 2D image, any blood vessel is filled with fluid and moving fluid, so it's generally anechoic or hypoechoic. Blood vessel also looks like dark on ultrasound. So there is a portal vein, we can see an IVC which is filled with blood, below the lumen. This is the general normal picture. Now, what is this? Inside the gallbladder, there is something echogenic. Echogenic means which is bright and it is reflecting the sound wave back such that it is forming a shadow behind it. It is not allowing even a single sound wave to pass through it and form the image of another organ. So this is a shadowing echogenic thing. It's a calculus. Every radiologist knows how to detect a calculus, but it's just a simple physics which we should know. So why is it reflecting the echoes? It's a dense thing inside the gallbladder which is reflecting back the echoes with a posterior acoustic shadow. So this is the picture of a calculus. How to image a gallbladder? For gallbladder, as I told you, the gallbladder should be imaged in a fasting stage. As soon as we eat food, the gallbladder contracts. And if you are making the patient, if you want to see a gallbladder better, you want to bring it near to the transducer, near to the surface of the body. In which position? Left lateral decubitus. It tends to come closer to the anterior surface of the body from where you are scanning. So it's better to scan in a left lateral decubitus. Otherwise, you can scan it in a supine position as well. And there should be it is a little bit right from right paramedium from the midline, epigastric midline, and you can move your probe in any direction. You can see the complete gallbladder. The important thing is to image for the CVD. This gallbladder is a big organ. It is imaged easily. People tend to miss CVD. For CVD, we have to trace the portal vein. Adjacent to the portal vein is the CVD. We have to slide our probe from the gallbladder down, and we will see near the gallbladder neck there is a triad that is called as the portal triad, which includes 3 hypoechoic or anechoic structures. One is a portal vein, one is a hepatic artery, and one is the CVD. How to differentiate? We simply put a color Doppler on it. The color Doppler detects the moving fluid, and moving fluid is within the blood vessels. So blood vessels will show some color, and those very slow moving or non-moving fluid do not show any color on the color Doppler, and we can easily detect the CVD. The normal diameter for a CVD is 5 to 7 mm. Nothing of much interest here. Coming back to if the gallbladder is filled, I have just shown you a very normal gallbladder and another gallbladder having one of the calculus inside. Now look at this picture of the gallbladder. How is its walls? Walls are not very smooth echogenic wall. There are some anechoic areas, linear running anechoic areas within the walls. So this is what? This is edema within the walls. What do you mean by edema? Edema means inflammation. So there is a polycystitis. What is inside the gallbladder lumen? There are low-level echoes. Low-level echoes means some sludge, some debris, and there are some brighter internal echoes which are having some posterior acoustic shadow. That means there are calculi also. So this is the calculus cholecystitis. While doing the performing the ultrasound, we tend to press the tissue also. As soon as we press the tissue, it gives a rebound tenderness in cholecystitis, which is generally clinically called as a Murphy's sign. So there is another image of choledochorial. You can see a linear anechoic, linear black structure, which is the CVD, which is having a brighter tissue inside with a posterior acoustic shadowing. So these are calculi within the CVD. We can see a calculus within the adjacent gallbladder also. So how to image a spleen? Spleen's location we all know. It is underneath the left lower ribs. We generally tend to keep our probe in the direction of 700 intercostal space, and the indicator of the probe, the spacing towards the patient head, and we see this kind of image which I have measured over here. This is the image of the spleen. So whenever the spleen is enlarged, it is more than 13 centimeter, which we take as a standard So more than 13 to 14 is splenomegaly. Coming back to some more, a little bit of organs, which I can show on ultrasound. It's all about anatomy. You should know the anatomy. You keep the probe there, you will be able to see everything. Except for that there are no enemies there. What are the enemies? How many enemies of ultrasound? 2 enemies, ear and bones, and one more hidden enemy I will be telling you. So this is the location of the appendix. We all know it. What is this point known as? Where the appendix tenderness is felt, it is called as a McBurney's point. So in this area we need to see a structure which is generally not very well visual because it is very thin structure. A normal appendix is less than 7 mm in its girth, but if we see a little bit dilated tubular non-peristaltic structure with edematous walls in this region, then it should be blind-ended. It should not continue with the other bowel on both sides. It should be blind-ended. So that is appendix. So there are 2 ways of finding appendix. One is we directly keep the probe on the point of maximum tenderness. The other approach is that we should start scanning from the right hypochondrium. We should scan the complete large bowel loop, the ascending colon, which is generally air-filled or fecal-loaded, and then when we reach the tip of the lower tip of the ascending colon and cecum, below that we can trace the appendix, generally near the psoas muscle and internal iliac artery. So this is a axial image. First one is the axial image of the appendix. You can see a round structure which is dilated and having some edematous walls. So this is any wall which is edematous reflex is inflammation, that is appendicitis is going, and because of appendicitis there is the increased diameter of the structure. We can see it is 9.2 mm, 0.92 centimeter written in the image. Normal diameter is up to 6 to 7 mm. The second image, we have just rotated our probe in the direction of appendix, in whichever direction it is being formed longitudinally, and there is a appendix in the longitudinal axis. What is the third image? In the third image we can see an appendix, and inside the appendix again there is a echogenic curvilinear thing having a posterior acoustic shadow. Yani this is also some kind of a calculus. A calculus within appendix may be an appendicolith. Any appendicolith will also is what? It is a calcified thing. It's a calculus. So coming back to again another important thing which we have to look in an abdominal ultrasound, we have to trace the fluid, free fluid within the peritoneal cavity. Free fluid, when there is a large, moderate or gross free fluid everywhere, and any blind can see that there is a fluid. What we tend to miss is the mild fluid. How will fluid look like on an ultrasound? Fluid कैसे दिख रहा है? अभी हमने कई बार बोला, it will look like काला, anechoic, black, है ना? So fluid looks like black. We are which are the sites for which we should look for the fluid? First site is the Morrison's pouch. Morrison's pouch is in the right upper quadrant between the liver and the kidney. We can see the liver upside and kidney below it, and we can see a very thin linear anechoic fluid within the Morrison's pouch. So this is where we have to look for mild amount of fluids. First is Morrison's pouch. Second site is perisplenic. When we are focusing the spleen, generally there is no fluid around the spleen. But in this image, you can see we are focusing the spleen and there is some fluid around the spleen. There is some hypoechoic, anechoic thing around the spleen. We have to look for the fluid. We have to look for the fluid, minimal or mild fluid in the pelvis. In males, below the urinary bladder, between the rectum and the urinary bladder, that is the rectovesical pouch. We have to look for some fluid in the rectovesical pouch. Better if our bladder, urinary bladder is filled. Because if our urinary bladder is filled, it will let the echoes pass through them and then we can see anything behind it very easily. And in females, is the site for mild fluid is the pouch of Douglas, that is behind the uterus. It is a peritoneal fold behind the uterus. We can see this is a TVS image. This is a TVS image which I have shown. The probe is inside the vagina. We have reached to the vicinity of the uterus. There we can see the cervix and the uterus with a very good resolution because it's a high frequency probe and we are near the organ. We need more resolution. And behind the uterus we can see free fluid in the pouch of Douglas. Then can we detect bowel pathology with the ultrasound? Bowel has air inside but not in its walls. At least we can see the walls. And sometimes, like in pathologies like intestinal obstruction, we have one of our friends sitting inside the bowel, and that is the we all please clap for Dr. Dharan Singh sir. Welcome sir. So let me continue. We are just I am showing an image in which you can see a bowel loop. The bowel loop has some like holes inside it, most probably a jejunal loop, and it is filled and dilated with fluid. So any dilated bowel loop which is filled with fluid will be very easily seen on ultrasound. So any small bowel loop more than 3 cm on ultrasound with a lesser peristalsis, because ultrasound is a dynamic scan. I told you that we can see the peristalsis. We can comment on the peristalsis. So with reduced peristalsis, dilated small bowel loops indicate as for the bowel obstruction. Can we see a pneumoperitoneum? What is pneumoperitoneum? Pneumoperitoneum is air. Air is our enemy. Okay, we cannot see our normal organs in a pneumoperitoneum. It is not allowing us to see the depth. But can we detect the pneumoperitoneum in a clinical settings? Yes, because whenever there is a pneumoperitoneum, the air tends to come up to the surface of the abdomen, inner surface. And whenever there is an air, there will be reverberation artifacts. There will be many such kind of echogenic lines which will be formed, which you can see in the second image. So we can see that there is a large amount of air which is not letting us see the deeper organ, and it is very proximal to the abdominal wall. With the clinical setting of the patient, which we know, we can indicate that there might be some pneumoperitoneum. Although ultrasound is not the modality of choice which can indicate that there is a definite pneumoperitoneum. We can just indicate for further evaluation. But because ultrasound is very readily available and very easily done in nearly every patient, we should have some idea for how we can indicate for a pneumoperitoneum. Next is lymph nodes. Lymph nodes generally are mesenteric or retroperitoneal. If the patient is not fatty, if abdomen is not filled with abdomen, we can easily see the lymph nodes, especially in children, which are very painful. Sometimes clinically mimics as lymph nodes can mimic appendicitis also. So there is an image of a target sign bowel loop. There is a bowel within bowel. We all have read it in our pre-PG, everywhere. Bowel within bowel, target sign appearance, pseudo-kidney appearance. What is this? This is intussusception. The good thing with ultrasound is that it's a dynamic modality. We can see the peristalsis. We have seen the loop insinuating light into the other loop. We have seen the loop coming out of the other loop also. So on ultrasound we can also try to do some therapeutic interventions also to see the intussusception. So this was just a very small insight into how ultrasound works. And now a very important slide which I have prepared with half an hour of thought. What are the take-home messages for this talk? First is ultrasound. Is it your best friend or most useful friend? What is good to have? Should we have a best friend or a useful friend? We should have a useful friend who should be with us in time of trouble. best friend who escapes in time of trouble, we don't need them. So ultrasound is our most useful friend. Why? Because it is very readily available. We cannot find a CT scan everywhere. We cannot find an MRI everywhere. Okay, X-ray we can find most of the places, but it does not know anything. It has very poor knowledge. So our good friend is ultrasound. It is very readily available. It is cost effective. It's not that costly. It is safe and radiation free. I have not told this point in our talk, but ultrasonic waves are sound waves. It is not using any kind of X-rays. It is radiation free and it is safe. Safe for what? Pregnancy. Every pregnancy has to get the ultrasounds done, and it is the one of the only modality which they have to access their baby. The other modality is MRI also, but it is not used every time. It's very costly, it's time taking, and although it is radiation free, but MRI is not readily used. Ultrasound is a good. So take home message is ultrasound is good in pregnancy. Other thing is it is real time and dynamic, which I have told you. One thing I have not told you, beware of its enemies. What are the two enemies? I have told you bone and air, but one enemy I had not told you. The other enemy is that it is very much user dependent. How experienced is your ultrasonologist? If the ultrasonologist is experienced enough, it can tell you a lot of things. If ultrasonologist is not that experienced, he can be your enemy. He can miss findings, he can give you a false report, your diagnosis can go down. So this is the third enemy of ultrasound, it is user dependent. So now, after this lesson, what do you take home? Can we do ultrasound now? Can all of you do an ultrasound now? No. Why? There is an act. There is a PCP&DD Act in India which limits the practice of ultrasound. Only the qualified persons with the proper formalities and the permission from the appropriate authorities can perform ultrasound. So it's good to know ultrasound, we should all know, but we should all know what it is. And ultrasound is a sound, it can listen. And look what this baby has listened in the recent attack. And what it is showing. It needs peace. Thank you.
Thank you very much, Dr. Nitish Sharma sir, for your valuable and enlightening session. Now I request our respected chairpersons, Dr. Ashok Sahai sir and Dr. Ashok Gupta sir, to kindly come forward and felicitate Dr. Nitish Sharma sir. Please welcome. Please welcome.
पीछे आ जा यार, फ्लैप आ रहा है भाई।
I now invite Dr. Vandana Arwaigar ma'am and Dr. Shrinjan ma'am to kindly come forward and facilitate our respected chairpersons sir, Dr. Ashok Sahai sir and Dr. Ashok Gupta sir, for their valuable presence, thoughtful insight and continuous support.
अरे मैम
Thank you.
भाई पीछे से पीछे
We are deepening our knowledge with each session at 2025 CME on Imaging Anatomy, and I am delighted to welcome you to the 6th session of the day. Following the insightful discussions on various imaging modalities, we now focus on advanced techniques that offer a detailed perspective on abdominal anatomy. It is my great pleasure to introduce our speaker for the session, Dr. Hari Singh Sir, Professor and Head, Department of Radiodiagnosis at Snmc, Agra, a distinguished expert in radiodiagnosis. Dr. Hari Singh Sir's leadership in the field, coupled with his extensive experience in CD imaging, has significantly advanced the application of sectional anatomy in clinical diagnostics. Today, he will share his expertise on CT scan, a sneak peek into sectional anatomy of abdomen, a topic that will enhance our understanding of how CT scans provide critical insights into the abdominal structures and their diagnostic implications. Before we begin, allow me to introduce the chairpersons for this session, Dr. Dharam Singh Sir and Dr. Shireen Jahan Ma'am, who will guide our discussions with their expertise and ensure a fruitful exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Hari Singh Sir to the podium.
Respected dignitaries, faculty members, delegates from various medical colleges, and dear students, good afternoon to all of you. It is my pride privilege to be here to deliver talk. I am thankful to the organizers for inviting me here. I will be talking on cross-sectional anatomy of abdomen and CT scan. So I want to say a few words about evolution of radiodiagnosis. X-rays were invented in 1895. At that time, X-rays की जो आविष्कार था बहुत ही चमत्कारी था और उसमें बहुत सारे मेडिकल साइंसेज मेडिकल प्रैक्टिस में चेंजेस आए. उसके बाद धीरे धीरे चीज़ें इम्प्रूव करती गई. उसके बाद 1970 से 80 के बीच में अल्ट्रासाउंड, सीटी स्कैन और एमआरआई का एवोल्यूशन हुआ और उसके बाद से तो सारी की सारी मेडिकल साइंस जो है अल्ट्रासाउंड और ये इमेजिंग मॉडलिटीज पे डिपेंडेंट हो गई ऑलमोस्ट. आज की डेट में कितना भी अच्छा क्लिनिशियन हो फिर भी इन मॉडलिटीज की आवश्यकता रहती है. सो आई विल बी टॉकिंग अबाउट सेक्शनल एनाटॉमी ऑफ एब्डोमेन. So few words about this CT scan. So CT scan is computed tomography and other name is commonly used is CAT scan, that is computerized axial tomography.
CT scan was invented by Godfrey Hounsfield in 1972. In the same time, Alan McCormack was also working for CT scan. So jointly in 1979, they both got Nobel Prize for their discovery, and it became a miracle in the field of medicine. CT scan is very essential part of modern evidence-based medical healthcare due to its precision and adaptability. CT scan enables healthcare professionals to detect, diagnose various medical conditions with unmatched accuracy. So this is view of CT scan. This is gantry, this is patient couch, and this is console room. So major two components are computer component and scanner components. So scanner component, this gantry, this is aperture, this is patient table, in which the patient goes inside the machine. In this gantry there is X-ray tube, which is rotatory X-ray tube. In this situation, X-ray tube होती है, उसके अपोजिट साइड में इसमें डिटेक्टर्स लगे होते हैं. तो उसमें जैसे पेशेंट अंदर जाता है, पेशेंट का एक्सपोजर एक्सरे का होता है, और पेशेंट से जो एक्सरे पास होते हैं, उसके बाद जो डिटेक्टर्स अपोजिट साइड में लगे होते हैं, तो उसके अकॉर्डिंग उसका इमेज फॉर्मेशन होता है, और कंप्यूटर पे डाटा एनालिसिस करके उसकी इमेज कंप्यूटर पे निकल के आती है. So this is view, clear view of this gantry, aperture, patient table. This is inside view. बहुत complex inside this gantry. X-ray tube होती है, डिटेक्टर्स लगे होते हैं, पेशेंट जब अंदर जाता है तो पूरा हाई स्पीड पे रोटेशन होता है, और फिर पेशेंट अंदर जाता है और रोटेशन होता है, उसकी एक्सरे इमेजेस कंप्यूटर के द्वारा हमारे स्क्रीन पे इमीडिएटली आती रहती है. So basic principles of CT scan. CT scanners works by taking a series of X-rays from different angles around the body of patient, which are then processed by computer to create detailed cross-sectional images or slices. These slices provide a three-dimensional view of area of interest to diagnose the diseases. The core components of CT scanner: X-ray tube, detectors, rotation of the tube, data processing, and image display. Now the CT scan abdomen. Computed tomography of abdomen is diagnostic imaging test which is used to delineate anatomy and various diseases of the abdomen, including liver, gallbladder, pancreas, spleen, kidney, and every organ can be imaged by CT scan. जैसे as in previous lecture, Dr. Nikhil told, there are many enemies to the ultrasound, like hair, like bone, like fatty patient, thick-built patient. In those conditions, CT is the best. उस कंडीशन में सारा कुछ क्रॉस सेक्शन एनाटॉमी पे we can diagnose inside the body. CT scan abdomen is fast, painless, non-invasive, accurate, but associated risk of radiation is always there. सारी अच्छाइयाँ हैं, लेकिन बुराई भी है साथ में. Now the common indications for CT scan. CT scan is used for diagnosis of various diseases, including every organs like liver, gallbladder, pancreas, spleen, kidney, retroperitoneum, abdominal wall. Every disease can be diagnosed by CT scan. CT scan preparation. General preparations, complete history is taken so that we can know at which part we have to focus. कौन से organ पर हमें focus करना है disease identify करने के लिए. Overnight fasting is required so that stomach should be empty, bowel loop should be empty for better delineation of lesions inside the bowel loops. And another cause of fasting is this: when we inject contrast, IV contrast, उस कंडीशन में कुछ पेशेंट्स को वोमिटिंग का सेंसेशन होता है. अगर हम एम्प्टी स्टमक नहीं रखेंगे पेशेंट को, पेशेंट कैन वोमिट ड्यूरिंग द एग्जामिनेशन, तो सारा का सारा स्टडी हमारा खराब हो जाएगा, प्लस पेशेंट एस्पिरेट भी कर सकता है. हाइड्रेशन, दिस शुड बी एडिक्वेट because we use hydrogenated contrast which can cause renal dysfunction. So hydration of patients should be adequate. Bowel preparation for certain indications, bowel preparation with oral contrast agent is required. Removal of all unnecessary metallic. पेशेंट को कोई मेटलिक इम्प्लांट है, कुछ भी है, ज्वेलरी है, या फिर उसके कपड़ों पे कुछ लगा है जो आर्टिफैक्ट दे सकता है, we have to remove all those. Some pre-medications may be required in cases of allergy and other conditions. Now the screening prior to hydrogenated contrast के लिए क्या-क्या आवश्यक है जब हम contrast दे रहे हैं? Is there any history of hydrogenated contrast? Previous history, serum creatinine level should be normal. इसका मतलब ये है when we use IV contrast, the kidney function of patient should be normal. Otherwise, the condition of kidney, function of kidney may deteriorate with this IV contrast. So kidney function normal होना आवश्यक है, बस borderline cases में हम कुछ renal shape contrast होते हैं, उन्हें हम use कर सकते हैं. Under this, for the moment of childbearing age group, currently or possibly, हमें ये ensure करना पड़ेगा कि pregnant patient जो है pregnant तो नहीं है female patient. तो उस कंडीशन में प्रॉपर स्पेस की लेनी पड़ेगी और उसमें 10 डे रूल हम इसमें फॉलो करते हैं कि प्रीवियस 10 डेज ऑफ मेंस्ट्रुएशन वी कैन डू सीटी स्कैन सो दैट अगर कोई एक्सीडेंटली प्रेगनेंसी है पेशेंट को तो उस पर अननेसेसरी एक्सपोजर उसका ना हो फीटस का. कॉन्ट्रास्ट यूज नॉन कॉन्ट्रास्ट एजेंट इज रिक्वायर्ड. लो कॉन्ट्रास्ट इज रिक्वायर्ड इन केस ऑफ डिटेक्शन ऑफ कैल्सिफिकेशन स्टोन्स एंड हेमरेज. लाइक पेशेंट रिनल कोलिक के साथ आया है, हमें सीटी करना है तो उसको कोई कॉन्ट्रास्ट देने की आवश्यकता नहीं है क्योंकि उस रिनल स्टोन्स को विदाउट कॉन्ट्रास्ट हम डायग्नोज कर सकते हैं. IV contrast is used to enhance vascular structures and help in characterization of lesions. अदर कंडीशन में लाइक कोई मास लीजन है या कोई और कंडीशंस है, उस कंडीशंस में हमें IV contrast यूज करने की आवश्यकता है जिससे जो पैरेंकाइमा है ऑर्गन का वो एनहांस कर सके और जो मास लीजन है वो एनहांस कर सके अपने तरीके से. तो वी कैन वेरी वेल डिफरेंशिएट बिटवीन द टू नॉर्मल लीजन, नॉर्मल स्ट्रक्चर्स एंड द लीजन्स. Non-contrast indications, stones in kidney, ureter, sometimes in CVD, calcification in liver, pancreas, fat in liver tumors, fat stranding as seen in inflammation. There are many conditions in which there is inflammation in the organs like appendicitis, pancreatitis, diverticulitis, foetal infarction. तो उस कंडीशन में हम जो CT है that is very well sufficient for diagnosing of surrounding inflammation. Fat in adrenal adenoma and myeloma can be detected by CT scan. Now, contrast scan CT helps in finding pathology by enhancing the contrast between the lesion and normal structures. Enhancement in different phases include various phases of contrast enhancement: early arterial phase, late arterial phase, hepatic phase, nephrogenic phase, and delayed scan. By these scanning in various phases, we can detect the various diseases depending on the condition. Now this slide is very important. There are CT appearance of various structures. मतलब how structures look on CT scan in these conditions. If there is air, it is black. If it is fat, it is black. It is fluid, it is black. But all are black, but their densities are different. These densities can be measured by Hounsfield units. For air, this is in minus near about -1000. Fat -100. Fluid near about 0 plus minus. Oral contrast and IV contrast जो हम यूज करते हैं पेशेंट में that looks white. Soft tissues shades of grey depending on the composition causing attenuation X-rays. Bones look white, calcification look white, and metals bulletin porosity these look intense white in cases of these metals. Now the basic anatomy of abdominal organs, cross sections of. Now I will show cross sectional images of abdomen for various organs. मैं एक बेसिक प्रिंसिपल बताऊं. जैसे हम पेशेंट को हाउस में लिटाते हैं, उसके बाद सेक्शन करते हैं तो अपर टू लोअर उसका पूरा स्कैनिंग किया जाता है. तो उस कंडीशन में जो ऊपर हमारी इमेज आ रही है, वी आर स्टार्टिंग फ्रॉम लोअर पार्ट ऑफ थोरैक्स. इन दिस इमेज द कार्डियक पार्ट इज विजिबल एंड दिस इज एओर्टा एंड दीज स्ट्रक्चर्स आर बोन्स. दिस इज स्पाइन, रिब्स. तो आप ग्रेजुअली ऊपर से नीचे में अभी स्क्रॉल अप डाउन करूंगा इसको, तो वेरियस ऑर्गन्स वी कैन सी इन दिस सिचुएशन. So I will scroll up down the images like we see in the console of our CT scan. So जैसे CT scan में देखिए ऊपर से नीचे scroll up down कर रहा हूँ मैं अभी. पहले मैं एक बार दिखा दूँ, फिर मैं ऑर्गन्स को आइडेंटिफाई करके बताऊँगा. इस तरह की इमेजेस हम अपने कंसोल पर देखते हैं. वहीं से डायरेक्ट हमने इमेज लिए है. I will show various organs in this CT scan. So this is from upper to lower abdomen पूरा. So now identification of organs. This is liver. Right lobe, left lobe. ऊपर से लेके नीचे तक हम पूरा स्क्रॉल अप डाउन करके देख सकते हैं लिवर का एक्सटेंट पूरा. नॉर्मल स्ट्रक्चर. अगर कोई पैथोलॉजी होती है तो उसका अल्ट्रा डेंसिटी में हमें विजिबल होगा. So this is liver. This structure is gallbladder. Is it fluid filled? It is looking dark. This is gallbladder. This structure is pancreas. This is spleen. Early phase में इसमें heterogeneous appearance है इसका. These are the kidneys. Right kidney, left kidney. This is abdominal aorta. Contrast दिया है हमने. Contrast looking white. From upper to lower, these are various branches. These are renal artery arising from aorta, right and left. Aorta going down, down, down. Various branches are arising, and this is dividing into right and left cardiac arteries. Further division into external and internal cardiac arteries. These white structures are bowel. हमने इसमें को ओरल कॉन्ट्रास्ट दिया, ओरल बाउल को ओपेसिफाई किया कॉन्ट्रास्ट से, so we can differentiate whether these are nodes or not. तो उस कंडीशन में ओरल कॉन्ट्रास्ट देना आवश्यक है. प्लस इसकी वॉल थिकनिंग कोई है, बाउल का कोई लीजन है, मास लीजन, तो we can very well identify the lesions in such cases. So these are various structures. This is spine, this is spinal canal, various parts of vertebral bodies. This is in axial way. Now I will show coronal and sess. On one click it becomes this one. We have the coronal. This is coronal. So this is coronal image of whole abdomen. From anterior to posterior we are going. We can see one organ in a single image. ऊपर से नीचे तक बिल्कुल देख सकते हैं हम लोग. Various. This is ascending colon filled with contrast. These are two kidneys in coronal position. This is spleen and various structures. These are bones. So this is, and CT is very good for delineation of anatomy of abdominal organs. Hair is not enemy for CT. Bone is not enemy for CT. Those were in ultrasound scan. And fatty patient is also not enemy for the CT scan. So after this normal anatomy, I will show some abnormal pathological conditions. So these are some common pathological conditions in abdomen. This is the case of gallbladder stones. This is gallbladder, and multiple hyperdense regions are filled within the lumen of gallbladder. So this is polylithiasis. This is gallbladder, but the wall is thickened in edematous. One stone is seen here. So this is polylithiasis with polycystitis. This is case of liver abscess. This is liver. This large hypodense lesion is seen within the right lobe of liver with well-defined wall and surrounding edema. So this is case of liver abscess. So this is large lesion, hypodense lesion with multiple membranes-like structures are seen within the lesions. So this is case of hydrated cyst at the liver. So this is a large heterogeneous mass lesion in right lobe of liver. Margins relatively defined, attenuation in heterogeneous, some are hyperdense enhancing, some are non-enhancing, these are necrotic areas. So this is case of hepatocellular carcinoma. This is case of acute pancreatitis. So this is position of pancreas. Normal pancreatic parenchyma is seen here, but in this area, this is hypodense and normal enhancement contrast now pancreatic parenchyma not seen. So this is case of acute pancreatitis with pancreatic necrosis. Also there is surrounding inflammation peristatic. This is peripancreatic peristatic cellular inflammation. This is case of pseudocyst. In the head region of pancreas, there is large cyst within the head region, which is suggestive of pseudopancreatic cyst. This is case of chronic pancreatitis, in which the pancreatic parenchyma is atrophic and multiple calcified foci are seen within the visual part of pancreatic parenchyma. This is case of splenic abscess. This is spleen. The hypodense non-enhancing lesion is in part of the spleen, suggestive of splenic abscess. This is case of splenic infarct, wedge-shaped hypodense lesion in the peripheral part of the spleen, suggestive of splenic infarct. These are small calculi in the both kidneys. This is right kidney, this is left kidney, and these hyperdense structures seen within the kidney are renal calculi. This is in sagittal plane. We have taken the whole kidney in this plane. The kidney appears slightly bulky. Small indefined hyperdense area is seen. And the most important is surrounding and fat inflammation, fat staining. Fat staining means inflammation. So this is case of acute pyelonephritis. This is case of rectal carcinoma. This is urinary bladder. Posterior to urinary bladder, this is location of rectum. In this rectum, this is heterogeneous mass lesion with surrounding fat staining and some nodular lesions in case of rectal carcinoma. This is case of large mass lesion with septations with cystic component in a female patient. This is ovarian mucinous cystadenoma. These are dilated small valves with air fluid levels, air fluid levels suggestive of small valve obstruction. This is case of bowel perforation in which free air is seen within the peritoneal cavity outside the bowel loop suggestive of intestinal perforation. This is case of acute appendicitis in which tubular structure is seen at right lower abdomen with surrounding fat staining, blind ending structure suggestive of appendicitis. This is case of abdominal tuberculosis. Bowel loops are dilated. Small amount of ascites is seen. Some nodes are also visible which are necrotic, suggestive of abdominal tuberculosis. So CTs get very good for identifying various diseases. Now the take-home message: CT scan is essential and inevitable part of modern evidence-based medicine healthcare system. CT scan provides accurate diagnosis, help in planning, management, and response assessment of various diseases in abdomen and other organs, especially for cancer. Disadvantage: radiation exposure is a risk for patients, common public, and healthcare providers, which may cause cancers and other serious problems. So, CT scan must be advised judiciously in view of radiation hazard. There is no safe limit of radiation, either in X-ray, either in CT or other modalities. So, LRA principle means as low as reasonably achievable principle must be applied. जब तक बहुत आवश्यक नहीं हो, तब तक हमें X-ray producing जो modalities हैं, वो नहीं use करनी चाहिए. Either maybe X-ray, either maybe CT scan or DSA. But in case of X-ray, the amount of radiation is very less, 0.7 millisievert in case of X-ray abdomen. But in case of CT abdomen, this is 8 to 10 millisievert. That is 80 to 100 times of the X-ray of abdomen. तो अगर हमारा काम X-ray से चल जाता है, तो we should not go unnecessary for CT scan. Thank you. Any questions? Students? Thank you.
Thank you very much, Dr. Hari Singh sir, for your exceptional session. Now I request our honorable chairpersons, Dr. Dharam Singh sir and Dr. Shri Jhan ma'am to kindly come forward and felicitate Dr. Hari Singh sir. Please ma'am.
पीछे से घिसे जाकर
I now invite Dr. Pradeep sir and Dr. Manjula ma'am to kindly come forward and facilitate our respected chairpersons, Dr. Dharam Singh sir and Dr. Shri Jhan ma'am.
After exploring various imaging modalities in our previous sessions, we now turn our attention to a powerful tool that has revolutionized diagnostic precision. It is my great pleasure to introduce our speaker for the session, Dr. Shamrendra Vikram sir, Professor at RMM Lucknow and a distinguished expert in radiodiagnostics. Dr. Shamrendra sir has completed his MBBS from Kolkata Medical College and MD from Patna Medical College. He has 41 published research papers in his name and is working on various research projects as principal investigator. Dr. Vikram's profound expertise in MRI and his contributions to its clinical applications have made him a leading figure in this field. Today he'll share his knowledge on MRI, an efficient and focused imaging tool, a topic that will enhance our understanding of how MRI can be leveraged for accurate and detailed diagnosis. Before we begin, allow me to introduce the chairpersons for this session, Dr. Ramkumar Singhal sir and Dr. Tejendra Singh sir, who will guide our discussions with their expertise and ensure a meaningful exchange of ideas. Please join me in extending a warm round of applause as I invite Dr. Shamrendra Vikram sir to the podium to deliver his lecture.
Thank you for the nice introduction. First of all, it's a privilege to stand here after 7 or 8 years because our faculty out there at this medical college. It's a prestigious medical college with lots of legacy and very old traditions. And this lecture theatre is really nostalgic to stand again out here. And I must congratulate Dr. Anshu for organizing such a beautiful conference. So today, the topic that has been assigned to me is an introduce to the student and resident and the delegates in this CME the modality, the imaging tool that is called MRI. So I don't think this modality is new to any one of us. How many of us know the word MRI? किसी ने MRI की फिल्म देखी है आज तक? नहीं देखी है. देखी है तो हाथ उठाओ. बच्चों आप लोग हाथ उठा के बता सकते हो. It is going to be something. This is a CME. This is not something that I am going to showcase any of my presentations or any of my things that I have done this and that. Nothing like that. This is a CME and primarily targeted, as your head of the department, Dr. Anshu has said, it has to be targeted to you people that you take some message when you go back from here. So कितने लोगों ने MRI का फिल्म देखा है? सबने देखा हो, सबने देखा है, सुना है ना? तो हम लोग
लोग इसी पे चर्चा करेंगे फॉर नेक्स्ट 30-35 मिनट्स एंड आई एम श्योर यू विल टेक सम मैसेज एंड यू विल एंजॉय लुकिंग एट योर इमेजेस इन द बुक्स. आई थिंक ऑल द एनाटॉमी बुक्स नाउ हैव MRI images. Okay, so learning objectives for the next 30 minutes. What is MRI? MRI होता क्या है? Images कैसे बनते हैं? थोड़ा सा समझना होगा. And then उस इमेज को कैसे देखते हैं? क्योंकि आपने देखा होगा कि MRI की कितनी फिल्म मिलती है, जब भी मिलती है 5-6 तरह की फिल्म मिलती है ना? तो उस इमेज को कैसे देखते हैं, कैसे समझने की कोशिश करते हैं, कैसे हम लोग उसको इंटरप्रेट करते हैं एंड उसकी डायग्नोस्टिक वैल्यू के लिए कुछ एग्जाम्पल्स, 2-3 एग्जाम्पल्स लास्ट में देखेंगे so that you can understand that okay how this is being used as an imaging tool. Okay, so what is MRI? नाम क्या है? Magnetic Resonance and Imaging. Okay, so there should be a magnet. Magnet, आप लोगों को मैग्नेट के बारे में पता है? सबसे बड़ा मैग्नेट क्या है? अर्थ itself, है ना? अर्थ की अपनी एक मैग्नेटिक फील्ड होती है. उसी तरह से उसको उस मैग्नेट के अलावा जो हम लोग इमेजिंग करते हैं वो मैग्नेटिक प्रॉपर्टी ऑफ द सब्सटेंस. अल्ट्रासाउंड में हमने क्या देखा था, जो अभी इसके पीछे का लेक्चर था, इकोज साउंड जाती थी, साउंड रिटर्न होकर रिफ्लेक्ट होकर टिश्यू से आते थे, उसको इंटरसेप्ट करते थे, उसकी इंटेंसिटी को मापते थे और एक इमेज बनाते थे. सीटी स्कैन में हरी सर ने क्या बताया? हम लोग रेडिएशन को यूज करते हैं, एक्सरे, इलेक्ट्रोमैग्नेटिक रेडिएशन हमारे बॉडी से पास करती है, वो इंटरैक्ट करती है बॉडी से. इंटरैक्ट करने के बाद उसमें चेंजेस आते हैं, उसको इंटरसेप्ट करते हैं एंड देन वी ट्राई टू गेट सम इंफॉर्मेशन कि वो इंटरैक्शन कितना उस वैल्यू को, उसकी एनर्जी को एटेन्यूएट किया है और उससे इमेज बनाते हैं. उसी तरह से MRI की जो इमेज बनती है वो हमारे शरीर के अंदर जो मिलियंस ऑफ मैग्नेट्स, छोटे छोटे मैग्नेट्स पड़े हैं, बहुत छोटे छोटे, अभी हम उस पर बात करेंगे क्या है वो मैग्नेट्स. एंड देन देयर इज सम रिजोनेंस. रिजोनेंस हम लोगों ने फिजिक्स में पढ़ा है. रिजोनेंस पढ़ा है. क्या पढ़ा है कि जब दो फ्रीक्वेंसी एक साथ आती है तो इफेक्ट समेटिव से बहुत ज्यादा होता है. उस रिजोनेंस को, उसको, तो वो जो मैग्नेट्स है उसकी जो स्पिन है, उसकी जो रोटेशन है, उसकी जो मूवमेंट है, उसके साथ रिजोनेट करते हैं हम लोग एक्सटर्नल मैग्नेट को, और उसके बाद कुछ ज्यादा इफेक्टिव चेंजेस आती है जो कि हम इंटरसेप्ट करते हैं और इमेज बनाते हैं. और तीसरा है कैप्चरिंग दैट चेंजेस, दैट रिजोनेंस टू मेक द इमेज. सो मैग्नेटिक रिजोनेंस इमेजिंग, देयर इज अ मैग्नेट, देयर शुड बी अ रिजोनेंस एंड देन देयर शुड बी टूल्स, हार्डवेयर, मशीन्स to capture the resonance phenomena and create the image. Okay, so where is the magnet in our body? Electromagnetic word properties हम लोग 10th 11th 12th में पढ़े हैं. क्या है? Any moving electrons will create a magnetic field around it. Isn't it? So हमारे शरीर में मैग्नेट है. क्यों? क्योंकि all the elements जो हमारे शरीर में है सब में इलेक्ट्रॉन्स हैं, प्रोटॉन्स हैं, है कि नहीं? इलेक्ट्रॉन्स एंड प्रोटॉन्स के बिना तो हमारा शरीर नहीं है. तो हमारे शरीर में सारे मैग्नेट्स भरे पड़े, सिर्फ मैग्नेट्स ही मैग्नेट्स. एक ही प्रॉब्लम है कि कितना है वो, कितना जुड़ के बनता है, कौन सा इफेक्टिव होगा हमारे लिए. तो जो इफेक्टिव होता है, एक हमारे पास इलेक्ट्रॉन्स हैं, उसका वेट बहुत जब कम है, मास हम लोग सब जानते हैं उसका सब बहुत कम है, तो उसकी मैग्नेटिक फील्ड कम बनती है. प्रोटॉन्स की बनती है, लेकिन प्रोटॉन्स जितने सारे एलिमेंट्स हैं हमारे शरीर में उसमें सबसे ज्यादा क्या है? वाटर. एंड वाटर में सबसे ज्यादा क्या होगा? हाइड्रोजन, H2. ठीक है. सो हाइड्रोजन इटसेल्फ इज ए प्रोटॉन. उसमें कोई न्यूट्रॉन नहीं है, उसके न्यूक्लियस में एक प्रोटॉन है जो स्पिन कर रहा है. हम लोग सब इस चीज को सब लोग जानते हैं, किसी ने देखा नहीं है, हम लोग सब जानते हैं. तो हमारे शरीर में वी ऑल हैव टाइनी मैग्नेट्स इन आवर बॉडी, दैट इज प्लेंटी, एंड ईच एंड एवरी एलिमेंट ऑफ आवर बॉडी इज ए मैग्नेट. बट बिकॉज वी कैन image only one thing, so we look for that particular magnet which is maximum, and that maximum is hydrogen. हाइड्रोजन हमारे शरीर में चाहे वो प्रोटीन हो, चाहे वो लिपिड हो, चाहे वो कार्बोहाइड्रेट्स हो, चाहे वो वाटर हो, ये तीन कंपोनेंट से तो हमारा शरीर बना हुआ है. सो ये हाइड्रोजन सब जगह है. सो इफ वी कुड डेवलप दिस टूल, use this magnet of tiny proton, that is hydrogen, we can image each and every tissue of our body. So ये हमारा मैग्नेट हमारे शरीर में है, and this magnet is spinning. Spinning in the sense प्रोटॉन क्या है? स्टैटिक नहीं है, ये घूम रहा है. ये घूम रहा है हमारे शरीर में. और ये स्पिनिंग, इसके साथ क्या है कि हमारे लोग ने एक चीज और पढ़ा है कि जितने हमारे शरीर में वो सब क्या होता है कि रैंडम स्पिन कर रहे होते हैं अलग अलग डायरेक्शन में। अलग अलग डायरेक्शन के कारण क्या होता है कि उसकी जो पर्सन, नहीं तो हम मैग्नेट की तरफ क्यों नहीं कहीं चिपक जाते हैं, इसलिए नहीं चिपकते हैं कि हमारे पास जितने टाइनी मैग्नेट्स हैं सब अलग अलग डायरेक्शन में होने के कारण दे आर नॉट एबल टू क्रिएट ए नेट मैग्नेटाइजेशन इन आवर बॉडी। हमारे बॉडी में नेट मैग्नेटाइजेशन नहीं क्रिएट होती है, सब एक दूसरे को कैंसिल करते हैं। मैग्नेट वेक्टर इधर इधर गया, सब कैंसिल कर दिया, तो कैंसिल करके नेट जीरो हो गया। सबकी डायरेक्शन अलग है, किसी का ऊपर है, किसी का नीचे है, किसी का दाएं है, बाएं है। तो इसी कारण से हम उससे कोई इंफॉर्मेशन ड्रॉ नहीं कर पाते। ठीक है, सो पर्पस क्या है, कैसे हम कर सकते हैं, उसको रिजोनेट करके, उसको अलाइन करके, उसको एक डायरेक्शन में लाते। तो यदि हम सारे को एक डायरेक्शन में ले आएंगे तो वी कैन हैव सम मैग्नेटिक वेक्टर इन आवर बॉडी, ठीक है, इन आवर टिश्यू। सो दिस इज हाउ द कॉन्सेप्ट ऑफ मैग्नेटिक रेजोनेंस का जो पूरा हार्डवेयर है उसका काम बस ये है कि हमारे शरीर के मैग्नेट्स को अलाइन करना और उसके बाद उसको रिजोनेट करवाना, उसको फ्लिप करना, उसके एंगल को चेंज करना, एंड देन चेंज के बाद उस कितनी जल्दी वो वापस अपने इनिशियल स्टेट में पहुंचता है, रेस्ट स्टेट में, हैजार्ड स्टेट में पहुंचता है, उस चेंज को कैप्चर करना और उसके बेसिस पे इमेज को फॉर्म करना। सो दिस इज द बेसिस ऑफ मैग्नेटिक रिजोनेंस। तो रिजोनेंस में जब आता है तो रिजोनेंस में एक और छोटी सी चीज है जो हम आप लोगों को चाहते हैं, यू शुड ड्रॉ इट, जो दिस इज प्योर फिजिक्स, लेकिन मैं बहुत जल्दी से इसको क्रॉस करना चाहूंगा कि एनी आपने लट्टू देखा है, लट्टू देखा है, जब लट्टू आप नचाते हो तो कैसे घूमता है, एक तो स्पिन कर रहा होता है, उसके अलावा वो प्रेसिस कर रहा होता है, आपने देखा होगा थोड़ा 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 टर्न कर रहा होता है और वो टर्न बढ़ता 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 वो गिर जाता है लट्टू। ठीक है, दिस इज द बेसिस। यही चीज हमारे इसमें होता है कि ये प्रेसिस भी कर रहा होता है। जब ये मैग्नेटिक फील्ड अलाइन होती है तो एक साथ स्पिन कर रहे हैं लेकिन साथ में वो प्रेसिशन भी उसमें हो रहा है। लेकिन ये प्रेसिशन बहुत इंटरेस्टिंग चीज है। ये प्रेसिशन का है, बस एक मिनट अटेंशन चाहिए आप लोगों का, बहुत इंपॉर्टेंट पॉइंट। ये प्रेसिशन इसलिए इंपॉर्टेंट है कि ये प्रेसिशन डिपेंड करता है मैग्नेटिक सराउंडिंग मैग्नेटिक फील्ड से। तो जब ये सराउंडिंग मैग्नेटिक फील्ड चेंज होता है तो अब जो हाइड्रोजन एक वाटर में कनेक्टेड है तो उसके सराउंडिंग जो मैग्नेटिक फील्ड होगा, जो हाइड्रोजन प्रोटीन में है और जो हाइड्रोजन कार्बोहाइड्रेट्स में है, जो हाइड्रोजन लिपिड में है, सबके सराउंडिंग जो इन्वायरमेंट है वो थोड़ा थोड़ा चेंज होता है। ठीक है, एंड उस चेंज के कारण क्या होता है कि सबकी जो मैग्नेटिक फील्ड है, मैग्नेटिक प्रेसिशनल फ्रीक्वेंसी जो है थोड़ी सी अलग होती है। अब जब थोड़ी सी अलग होती है और इस चीज को हमने कैप्चर कर लिया तो क्या होगा, इस चीज को कैप्चर कर लिया तो वी नाउ हैव डेवलप्ड द आर्ट ऑफ डिफरेंशिएटिंग बिटवीन प्रोटीन, फैट एंड दिस टाइप ऑफ टिश्यू। सो डिफरेंट टिश्यू कैरेक्टराइजेशन हम कर पाएंगे एंड दिस इज हाउ वी आर गोइंग टू यूज दिस पर्टिकुलर प्रॉपर्टी टू क्रिएट द एमआरआई। ठीक है, सो व्हाई एमआरआई इमेजिंग इज एन एफिशिएंट टूल, बिकॉज इसमें हम एक एनाटॉमी क्रिएट कर पाते हैं। व्हाई इट इज एफिशिएंट टूल, बिकॉज इसमें हम एक हिस्टोलॉजी क्रिएट कर पाते हैं। व्हाई इट इज एफिशिएंट, क्योंकि इसमें हम कुछ फंक्शनल चीजें भी डिफरेंस जनरेट कर पाते हैं और वो इमेज कर पाते हैं जो हम एक दो एग्जाम्पल्स में देखेंगे। ठीक है, एक और जो चीज है कि जब सारे शरीर का मैग्नेट एक जैसा बिहेव करेगा तो उससे इमेज नहीं बन पाएगा। क्यों? क्योंकि सब जगह यदि एक ही है, सब जगह से एक ही तरह की सिग्नल आएगी तो हम उसको सेलेक्ट नहीं कर पाते हैं। तो एक और तो मैग्नेट में जब हम व्हाइट बोर्ड मैग्नेट में जब अंदर घुसते हैं तो हमारा सारा शरीर का मैग्नेट एक डायरेक्शन में हो गया पहले। उसके बाद क्या किए, उसमें एक ग्रेडियंट डाले कि मैग्नेट को होमोजेनियस ना करके कहीं पर एक ऐसा ग्रेडियंट डाले कि यहाँ पर पॉजिटिव है, यहाँ पर नेगेटिव है, और अल्टीमेटली क्या हुआ कि थ्रू आउट ऑफ डिफरेंट पार्ट द मैग्नेटिक फील्ड इज डिफरेंट एंड दैट मैग्नेटिक फील्ड क्रिएट डिफरेंट प्रेसिशनल फ्रीक्वेंसी एट अदर प्लेसेस। तो जिस प्रेसिशनल फ्रीक्वेंसी को हम एक्साइट करेंगे, जिस प्रेसिशनल फ्रीक्वेंसी को हमने रिजोनेट करवाया, वहां से जो सिग्नल आएगा तो हमें पता है कि ये कहां से आ रहा है। एंड दिस वे हाउ वी सिलेक्ट द स्लाइस। तो जब हम एमआरआई की इमेज बनाते हैं तो क्यों कि ये पर्टिकुलर इसी क्रॉस सेक्शन से आएगा। अल्ट्रासाउंड इज ए क्रॉस सेक्शनल इमेजिंग, सीटी स्कैन इज ए क्रॉस सेक्शनल इमेजिंग, क्योंकि क्रॉस सेक्शनल डेटा हम क्रिएट करते हैं, इमेज क्रिएट करते हैं। सिमिलरली एमआरआई इज आल्सो ए क्रॉस सेक्शनल इमेजिंग, अनलाइक द रेडियोग्राफ्स जो कि फ्रंटल टू डायमेंशनल इमेजिंग है, वो क्रॉस सेक्शनल नहीं है। ठीक है, तो अब इसके बाद क्या होता है कि कैसे इस इमेज को बनता है, और जो जल्दी से मैं रश करूंगा, तो जो ये प्रिसिशन है जब हमने प्रिसिशनल फ्रीक्वेंसी, जब मैंने कहा कि लट्टू अलग अलग तरीके से प्रेसिस कर रहा था, तो हमने उसको रिजोनेट करवाया, एक बाहर से रेडियो फ्रीक्वेंसी पल्स दिया उसके साथ, जैसे लट्टू को आप जैसे घूम रहा होता है उसको टच करते हो फिर सीधा हो जाता है। उसी तरह से आप देखोगे कि हम लोग जो रेडियो फ्रीक्वेंसी पल्स उसमें देते हैं, एनर्जी इंपार्ट करते हैं, तो जो प्रिसिशन है, एक तो था अलाइनमेंट जो एक डायरेक्शन में हो गया, दूसरा था प्रिसिशन जो वो सराउंडिंग में घूम रहा है। अब सराउंडिंग में घूम रहा है तो अलग अलग डिफरेंट फेज में रहेगा और उसको हमने रिजोनेट कर दिया तो सब एक ही डायरेक्शन में एक साथ मूव करना शुरू किया। लेकिन जब हम एनर्जी खत्म करते हैं, एनर्जी स्टॉप करते हैं, उसकी एनर्जी जितनी दी है उसको खत्म कर देंगे, तो वापस वो क्या होगा, डिफेज होना शुरू होगा। डिफेज होने का मतलब है कि सब एक तरफ से जा रहा था, एक साथ प्रेसिस कर रहा था, तो हमारी वर्टिकल एक मैग्नेटिक फील्ड थी और एक हॉरिजॉन्टल कंपोनेंट, जब टेढ़ा होकर प्रेसिस कर रहा है, एक हॉरिजॉन्टल कंपोनेंट वेक्टर्स है ना, तो मैग्नेट जब टेढ़ा हो गया तो एक हॉरिजॉन्टल कंपोनेंट है, एक वर्टिकल कंपोनेंट। वर्टिकल सबकी सही तरह से जुड़ रही थी, हॉरिजॉन्टल कंपोनेंट अलग अलग डायरेक्शन में था, सबको रेजोनेट करवा दिया, एक डायरेक्शन में ले आया, तो हमारे पास एक हॉरिजॉन्टल कंपोनेंट स्ट्रॉन्ग मैग्नेट का मिल गया और वो सिग्नल को हम कैप्चर करना चाहते हैं। तो अब जब एनर्जी हाई एनर्जी स्टेट में वो स्पिन आया, वो मैग्नेट आए, बस 1 मिनट का अटेंशन चाहिए। हाई एनर्जी स्टेट में जब उसको आया, हमने जो वर्टिकल मैग्नेटिक फील्ड था उसको फ्लिप किया, हॉरिजॉन्टल किया, वापस वो अपनी जगह पर जाता है। सारे टिश्यू में हाइड्रोजन का स्पिन जो है वापस अपनी जगह पे जाता है और जब जाने लगता है तो एक लॉन्जिट्यूडिनल मैग्नेटाइजेशन जो 0 हो गई थी वो वापस अपने नॉर्मल वी वैल्यू, अपने वैल्यू पे पहुंचता है। साथ ही साथ जो हॉरिजॉन्टल जो सब अलग अलग फेज में जो हम अलाइन किए थे वो भी सब डिफेज होना शुरू होते हैं। एक साथ सब चल रहे थे, कदम ताल करके पूरे यूनिट में चल रहे थे, फिर सब इधर उधर भागना शुरू किए और कुछ देर में वो फैक्टर भी उसका 0 हो गया क्योंकि हॉरिजॉन्टल सब तरफ से मिल गए। तो अल्टीमेटली जो हॉरिजॉन्टल मैग्नेटाइजेशन है वो भी 0 हो गई। तो 0 कहाँ से हुई, मैक्सिमम वैल्यू से 0 हुई, एंड लॉन्जिट्यूडिनल मैग्नेटाइजेशन कहाँ से हुई, 0 से मैक्सिमम वैल्यू पर पहुंची। तो दो तरह की डिफेजिंग होती है, इसको रिलैक्सेशन करते हैं, इसको रिलैक्सेशन करते हैं। और ये जो रेट ऑफ चेंज है इसको कहते हैं, दैट इज हाउ द रेट। हमेशा हम लोग को स्टैटिक चीज को मेजर करना मुश्किल होता है। वी ऑलवेज ट्राई टू मेजर द रेट, हाउ इट इज चेंजिंग, हाउ फास्ट इट इज चेंजिंग, एंड उसको जब हम मेजर करते हैं उस स्ट्रेंथ को ये भी मेजर करते हैं एंड उसको हम बेसिकली फिक्सलेट करते हैं, उसको एक इंटेंसिटी देते हैं कि कौन कितना फास्ट चेंज कर रहा है, कौन कितना स्लो चेंज कर रहा है, एंड उससे हम एमआरआई की इमेज बनाते हैं। सो दिस इज व्हाट आई कॉल लॉन्जिट्यूडिनल मैग्नेटाइजेशन। अब आप समझो, अब अलग अलग टिश्यू में अलग अलग माइक्रो इन्वायरमेंट है, अलग अलग माइक्रो इन्वायरमेंट होने के कारण उसके सबके अलग अलग रिलैक्सेशन होंगे। 2 तरह की रिलैक्सेशन होती है। क्या होती है, एक T1 होती है और एक T2, जो अभी मैंने बताया, एक लॉन्जिट्यूडिनल मैग्नेटाइजेशन और एक होती है ट्रांसवर्स मैग्नेटाइजेशन की जो बात होती है। तो जो T2 मैग्नेटाइजेशन और T1 मैग्नेटाइजेशन, आप जस्ट इस ग्राफ को देखो जो राइट साइड में है, जो इस राइट साइड में जो ग्राफ है, यहाँ पर 2 सब्सटेंस है, ठीक है, एक जल्दी डिक्रीज हो गया और एक जल्दी लॉन्जिट्यूडिनली रिकवर कर गया और एक थोड़ा स्लो कर रहा, यानी कि दोनों की T1 वैल्यू अलग है। अब इससे क्या हो रहा है, सपोज करो हमने यहाँ मेजर किया, दोनों के सिग्नल बराबर मिलेंगे। सपोज करो हमने यहाँ मेजर किया, दोनों के सिग्नल बराबर मिलेंगे। लेकिन यदि हमने यहाँ मेजर किया तो क्या होगा, दोनों टिश्यू का सिग्नल अलग अलग मिलेगा, एक का ज्यादा मिलेगा, एक का कम मिलेगा, एंड दिस इज हाउ द इमेज इज क्रिएटेड। अब डिपेंड कर रहा है कि आप इसमें फिजिक्स है कि कौन सी वेटिंग यूज कर रहे हैं, T1 पे कर रहे हैं, T2 पे, लेकिन दोनों ही ग्राफ में आप देखोगे कि वी कैन सेलेक्ट ए टाइम to differentiate 2 different tissue as 2 different tissue। हम कुछ सीक्वेंस ऐसा कर सकते हैं जो यहाँ पर हमने वो डेटा लिया और यहाँ पे इमेज बनाया, तो यहाँ पर वो दोनों टिश्यू एक जैसा लगेगा, लेकिन यहाँ पर हमने लिया तो यहाँ पर वो दोनों टिश्यू अलग अलग कलर में दिखना चाहिए, अलग अलग इंटेंसिटी का दिखना चाहिए, क्योंकि यहाँ पर दोनों में अभी गैप है, अभी पूरा रिकवर नहीं हुआ, एक ज्यादा रिकवर हुआ, एक कम रिकवर। इसी चीज को यूज करके हम सारी इमेज को बनाते हैं, ठीक है। So the concept of MRI, this was the concept of MRI, and concept of MRI, concept 1 क्या हुआ, ये हाइड्रोजन इमेजिंग है बेसिकली। कोई पूछे MRI क्या है, तो you can very straightforward till now the clinical imaging, हम ये नहीं कर रहे स्पेक्ट्रोस्कोपी एंड अदर थिंग, देयर आर सम थिंग्स जहाँ पर हम दूसरी चीजों को भी इमेज करते हैं, लेकिन फॉर द ऑल प्रैक्टिकल पर्पसेस जो इमेज आप लोग देखते हो, जो इमेज फील्ड में देखते हैं, इट इज बेसिकली ए हाइड्रोजन इमेजिंग। हाइड्रोजन को इमेज करते हैं बॉडी के, and because all molecules have hydrogen, अब जैसा कि अल्ट्रासाउंड में बताया गया था, क्या था, हमारे कुछ दुश्मन होते हैं। दुश्मन क्या होते हैं कि भाई अल्ट्रासाउंड में बोलते हैं एयर है, बोन है, जहाँ से साउंड नहीं पास करती है, रिफ्लेक्ट हो जाती है, जिसके कारण हम नहीं देख पाते। तो उसी तरह से जहाँ जहाँ हाइड्रोजन नहीं होगा वहाँ हम कोई सिग्नल नहीं क्रिएट करेंगे, वहाँ से कोई सिग्नल नहीं बनेगा। जैसे जहाँ कैल्सिफिकेशन है, जहाँ एयर है वहाँ बहुत मिनिमल हाइड्रोजन आता है। हमारे शरीर का हाइड्रोजन और एयर का हाइड्रोजन सोचोगे तो आपको समझ में आएगा कि इतना मिनिमल हाइड्रोजन है एयर में, तो वहाँ से भी कोई सिग्नल नहीं आएगी। और जहाँ पे फ्लो है, जहाँ पे भी फ्लो है, जहाँ पे मूवमेंट हो रही है, तो जिसको हमने रेजोनेट करवाया जिस हाइड्रोजन को, वो तो मूव करके जब तक हमने सिग्नल लेना शुरू किया क्या हुआ, वो तो आगे बढ़ गया। आगे बढ़ने से क्या होगा, हम वहाँ से इमेज ही नहीं बना पा रहे। तो जहाँ ये 3 कंडीशंस हैं जहाँ पर भी आपको एमआरआई की कोई सिग्नल नहीं है, तो इसका मतलब ये नहीं हुआ कि हम उसको इमेज नहीं कर रहे हैं, इमेज कर रहे हैं लेकिन वहाँ सिग्नल नहीं है। तो हम इंटरप्रेट इस तरह से करेंगे कि आइदर देयर इज कैल्सिफिकेशन और देयर इज एयर और देयर इज सम फ्लो वर्ड, सम मूविंग पार्टिकल, इस तरह से इंटरप्रेट करेंगे। एंड अनलाइक अल्ट्रासाउंड जहाँ हम इकोजेनिसिटी की बात करते हैं, हाइपो इकोइक, हाइपर इकोइक, सीटी स्कैन में सर ने बताया हाइपरडेंस, हाइपोडेंस, हम एमआरआई में इंटेंसिटी की बात करते हैं। इंटेंसिटी का मतलब सिग्नल इंटेंसिटी, कितनी सिग्नल इंटेंसिटी, कितनी रैपिड चेंज ऑफ काइनेटिक रेट उस इलाके में हो रहा है, अनलाइक सीटी एंड अल्ट्रासाउंड। तो उसके लिए करना क्या होता है, एमआरआई में पेशेंट को मैग्नेटिक फील्ड में डाला जाता है ताकि सारी एक लॉन्जिट्यूडनल अलाइनमेंट हो। फिर हम लोग आरएफ पल्स देते हैं ताकि उसकी जो प्रिसिशन है वो सब अलाइन हो जाए। देन उसको छोड़ देते हैं ताकि वापस वो डिफेज होना शुरू हो और उस चेंज को हम रिसीविंग कॉइल से एक्सेप्ट करें एंड देन दैट सिग्नल इज कन्वर्टेड इनटू इमेज। दिस इज द बेसिस ऑफ इमेजिंग इन एमआरआई। ठीक है, अब इसके बाद जो मैंने कहा कि जो कॉमन सीक्वेंसेस हैं, 2 प्रॉपर्टी है T1 एंड T2, उसके बेसिस पे हम इमेज बनाते हैं एंड देयर आर सम स्पेशल सीक्वेंसेस, नॉट गो इनटू दैट डिटेल्स। लेकिन हम लोग जो बात कर रहे हैं कि जब भी आप एमआरआई की इमेज देखो तो इस चीज को याद रखो, यहाँ से शुरू करते हैं हम एमआरआई। ठीक है, आप लोग को बहुत डिटेल एमआरआई पढ़ने की जरूरत नहीं है, लेकिन जो समझने की जरूरत है जो बहुत इंपॉर्टेंट है कि टिश्यू जैसे वाटर एंड फ्लूइड, सर ने अभी पढ़ाया था सीटी स्कैन में, फैट कैसा होता है, ब्लैक। ठीक, वेरी गुड, सब सुना है सर आपके लिए, सर सबने सुना है, फैट ब्लैक होता है, एयर ब्लैक होता है। तो उसी तरह से जो एमआरआई में है, जब हम T1 पे देखते हैं, T1 वेटेड इमेज होती है, अरे T2 प्राइमरी यही होती है, बाकी सब सिंथेसिस है, एक दूसरे को मिला के एक डिफरेंट टाइम में कर दिया, किसी को सप्रेस कर दिया, किसी को ये कर दिया, बट ऑल द इमेजेस आर बेसिकली T1 एंड T2। T2 इज जिसको कहा जाता है फ्लूइड सेंसिटिव सीक्वेंस, जिसमें कि पानी, वाटर, इडिमा ज्यादा उभर के ब्राइट दिखेगी, एंड T1 इज द एनाटॉमिकल इमेज। और T1 में वाटर एंड फ्लूइड जो है वो डार्क दिखती है, T2 पे वाटर एंड फ्लूइड ब्राइट दिखती है। फैट दोनों में ब्राइट दिखेगी और बोन कॉर्टेक्स कैल्सिफिकेशन जहां प्रोटोन की कमी है वो दोनों में डार्क दिखेगी। ये कॉन्सेप्ट आपको याद करना है, बस इसको आप याद कर लो, तो इसके बाद जो इमेज दिखाएंगे आप लोग फटाफट बोल पाओगे और देखना शुरू कर। याद है, फैट दोनों में ब्राइट होगा, ठीक है, वाटर T2 पे ब्राइट, अरे फोटोजेनिक फ्लो नहीं बेटा, बहुत छोटी सी लाइन है, बहुत छोटी सी लाइन है, याद हो जाएगा ऐसे भी। पानी T1 में आइसो लो फ्लो डार्क दिखेगा, T2 वाली सीक्वेंस में पानी ब्राइट दिखेगा। तो जब भी जहां फ्लूइड होना चाहिए वो ब्राइट दिख रहा है तो आप समझ लेना कि ये T2 में, ठीक है। कोई भी चीज T1 और T2 दोनों इमेजेस में फ्लूइड ब्राइट है और फ्लूइड एक दूसरे इमेज में फ्लूइड डार्क है, लेकिन कोई एक चीज दोनों में ब्राइट है, तो आप प्राइमरली समझ लेना कि ये फैट, ठीक है। कभी ब्लड ऐसा हो सकता है, कुछ मैं उसकी डिटेल में नहीं जाके कंफ्यूज करना चाहता हूँ, बट कीप योरसेल्फ टू द बेसिक। एंड जहां पर प्रोटॉन्स नहीं हो सकते हैं, कहाँ कैल्सिफिकेशन है, बोन कॉर्टेक्स में, बोन कॉर्टेक्स में बहुत कम प्रोटॉन्स होते हैं क्योंकि सारी मिनरल्स होती हैं वहाँ पे, ठीक है। प्रोटॉन्स नहीं होते हैं, बहुत कम होते हैं, थोड़े से हेलोजन सिस्टम में थोड़े बड़े प्रोटॉन्स रहते हैं और क्रिस्टल्स में थोड़े प्रोटॉन्स रहते हैं, तो कम रहते हैं, तो वहाँ डार्क सिग्नल आएगा। तो वहाँ पे T1 हो चाहे T2 हो, कोई भी सीक्वेंस कर लीजिए वो डार्क ही रहे, डोंट वरी अबाउट, ठीक है। तो इस 3 कॉन्सेप्ट के साथ हम लोग चलते हैं कि इमेज की व्यू में। तो जब भी हम इमेज देखते हैं, जब भी किसी इमेज का फिल्म हमारे सामने रहता है, चाहे वो कंसोल पे सर ने अभी दिखाया था, सॉफ्टवेयर पे ही देखते हैं, तो हम इस चीज को यूज करते हैं। एनाटॉमिकल पोजीशन एनाटॉमी में सब दिन पढ़ाया जाता है, भाई कैसे खड़ा है, उसके बाद पास फेल आप हो जाते हैं एग्जामिनेशन में कि भाई कैसे पकड़ लिया लीवर को, कैसे तो बस इसी तरह से है, उसको याद रखना है इस इमेजिंग पे कि हम कन्वेंशन जो है इमेज को देखते हैं वो है एनाटॉमिकल पोजीशन, कि भाई हमारे सामने पेशेंट खड़ा है, पेशेंट हमें देख रहा है और उसकी इमेज हमने सामने लगाई है, और उसके बाद और क्रॉस सेक्शनल इमेजिंग के लिए क्या है कि हम खुद की तरफ बैठे खड़े होकर देख रहे हैं। जब क्रॉस सेक्शनल इमेजिंग है तो नीचे की तरफ से, बाकी एनाटॉमिकल है कि सामने खड़ा है और हम देख रहे हैं। इस तरह से हम उसको करते हैं। तो इस तरह से करने से क्या होगा, पेशेंट का राइट किधर होगा, आपके लेफ्ट साइड। तो इमेज आप कैसे लगाओगे, कभी भी क्रॉस सेक्शनल स्क्वायर में उसका राइट आपके लेफ्ट साइड में होना चाहिए, आप जब फिल्म लगाते हैं, ठीक है। सो अब डिफरेंट इमेजिंग प्लेन्स होते हैं, इससे मल्टी प्लानर इमेजिंग है, ठीक है। तो डिफरेंट प्लेन्स में आप ले सकते हो, एक्सियल प्लेन आप सब जानते हो, कॉर्नर प्लेन, सैजिटल प्लेन, these are the classical planes that we talk about, but actually MRI की जितनी स्कैन्स होती हैं उसमें आप देखोगे वर्ड लिखा होता है ऑब्लिक कॉर्नर, ऑब्लिक सैजिटल। क्यों? क्योंकि मोस्ट ऑफ द टाइम जब हम इमेज करते हैं तो ट्रू कॉर्नर और सैजिटल नहीं यूज करते हैं, वी ऑलवेज ट्राई टू कीप टू एन एंगल जिससे कि हम जो स्ट्रक्चर्स देखना चाहते हैं वो बहुत अच्छे से देख सकें। जब कोई भी स्ट्रक्चर हमें देखना है, अभी आप देखोगे जैसे कि एकदम ट्रू प्लेन में नहीं होता है, हर जैसे आप देखो पीसीएल यहाँ दिख रहा है, नी जॉइंट में आप देखोगे पोस्टीरियर क्रूशिएट लिगामेंट दिख रहा है, ठीक है। अब इतनी पूरी तो दिखेगी, ये कैसे ट्रू सैजिटल में नहीं दिखेगी, क्यों? क्योंकि एक जगह से दूसरी तरफ एक फेस में जा रहा है ना, फिनोडल कॉन्डाइल्स में जाके अटैच हो रहा है, तो डिफरेंट प्लेन में क्रॉस कर रहा है। तो यदि हमने एकदम ट्रू किया तो वो नहीं होगा, तो हमेशा हम लोग हर चीज को ऑब्लिक करते हैं थोड़ा सा। यही कारण है कि जब इमेजिंग को बैलेंस में जब हम लोग यूज करते हैं तो मोस्ट ऑफ द टाइम व्हाट यू विल सी इज इट इज एन ऑब्लिक कॉर्नर ऑफ सैजिटल इमेज, सम टाइम वी यूज ऑब्लिक एक्सियल इमेज एज वेल। सो जब एनाटॉमिकल कंसीडरेशन अभी हमने सिखाया है, ये ब्रेन का इमेज है, 3 इमेज है। पहला इमेज वेंट्रिकल समझ में आ रही है सबको, एनाटॉमी में कैसा लग रहा है, काला या सफेद? वेंट्रिकल्स में क्या होता है, पानी काला या सफेद है? काला है, काला है ना। क्या इमेज हो सकता है? T1 में, वेरी गुड, ठीक है। उसके बगल में देखो क्या है, वेंट्रिकल्स कैसा लग रहा है, ठीक है। तो ये हो गया हमारा T2 वेटेड। तीसरा में CSF कैसा है, ब्लैक है, आप कहोगे T1 है। यही इसकी खूबसूरती है MRI की। MRI में हमने T1 T2 तरफ पढ़ाया था, उसमें था कि हम जिसको चाहें कभी कभी हम सिलेक्टिवली उसके सिग्नल को सप्रेस कर सकते हैं। एंड यहाँ पर हमने यूज किया, क्यों मैं बता रहा हूँ। यहाँ पर आप देखो पेरीवेंट्रिकुलर रीजन में, फ्रंटल में देखो, आप ऑक्सीपिटल रीजन में देखो, तो थोड़े से इडिमा जो आते हैं वो थोड़ा ब्राइट यहाँ दिख रहा है, जो कि T1 में आपको नहीं दिखेगा। T1 में यहाँ नहीं दिख रहा है ना, ब्राइट दिख रहा है, यहाँ भी ब्राइट दिख रहा है। तो यानी ये बेसिकली ये T2 इमेज था, लेकिन हमने फ्री वाटर को सप्रेस कर दिया, यहाँ फ्री वाटर सिग्नल को सप्रेस कर दिया। तो ये सप्रेस हो गया, यानी ये फ्री वाटर था। जो एरिया सप्रेस नहीं हुआ उसका मतलब वो बाउंड वाटर है, यानी वो इडिमा। तो ये एक ब्यूटी है जो कि हम MRI में क्रिएट करते हैं। सिमिलरली आप स्पाइन में देखो, बहुत सिंपल सा है, उसी तरह से जैसे वहां हमने प्लेयर यूज किया था, यहाँ पर ये CSF कैसा है, ये कॉर्ड है, कॉर्ड है सैजिटल इमेज, ये स्पाइनल कॉर्ड है, ये क्या है, क्या है CSF ही तो होगा, लेकिन एनाटॉमी में तो कोई दिक्कत नहीं हो रही है, आप आइडेंटिफाई कर पा रहे हो ना कहाँ में। तो स्पाइनल कैनाल में ये CSF है, ब्राइट है, ये कौन सा इमेज हुआ, T2 वेटेड इमेज। CSF कैसा है, डार्क है, ये बेसिकली T1 वेटेड इमेज है। यहाँ पर CSF कैसा है, ब्राइट है, तो ये भी T2 वेटेड इमेज है। लेकिन अब आप देखोगे स्किन के नीचे आ जाओ, ये हमारा स्किन है, स्किन के नीचे ये क्या है, सरफेस फैट, कैसा रहेगा T1 पे, ब्राइट, T2 पे कैसा रहेगा, ब्राइट, इस पे कैसा है, काला, ब्लैक। दैट मींस हियर वी हैव यूज्ड ए सीक्वेंस जहां पर हमने फैट के सिग्नल को सप्रेस कर दिया। यही इसकी ब्यूटी है, माने यू कैन क्रिएट मल्टीपल कंट्रास्ट, you can create multiple contrast to be sure ki what I am looking at, and that's why we call not only an anatomical imaging, we also call it a histological imaging। थोड़ी सी ये एडवांटेज इसमें मिलती है जहां पर हम देखते हैं यहाँ पर हमने फैट सप्रेस कर दिया। अब आपको ये है कि ये हमारा T1 T2 था यंग है, तो इसीलिए इसमें मैरो फैट सप्रेस नहीं हुआ है। इसका मतलब क्या है, ये यंग पेशेंट का है। क्यों? क्योंकि मैरो में फैट होता है, जैसे जैसे एज करते हैं फैट कम सप्रेस हुआ है, यानी फैट कम है, रेड मैरो ज्यादा है। जैसे जैसे एज होगा ये फैट होते जाएगा, आप देखोगे कि फैट वाली जिसमें फैट सप्रेस की ज्यादा सप्रेस होगा। अब ओल्ड एज में यदि फैट नहीं सप्रेस हो रहा है फोकली, तो क्या होगा, वो ट्यूमर है, वो फैट वहाँ नहीं था, फैट हैज बीन रिप्लेस्ड बाय सम ट्यूमर और सम कलेक्शन, उस तरह से है। तो नेक्स्ट केस में देखते हैं, ये कौन सा इमेज है, CSF कैसा है, ब्लैक है, फैट कैसा है, व्हाइट, ठीक है, CSF ब्राइट है, फैट व्हाइट है। चलो तो ये T2 इमेज हो गया। यहाँ पर क्या था, फैट सप्रेस कर दिया गया, फैट सप्रेस हुआ इसमें। यहाँ का T1 देखिए, T1 फैट ब्राइट है, यहाँ पर फैट सप्रेस हुआ है। यहाँ पे सप्रेस हुआ क्या, फैट नहीं हुआ ना, इस पर्टिकुलर जिसपे हमारा एरो है, तो ये फैट सप्रेस नहीं हुआ। इसका मतलब क्या है कि यहाँ पे फैट कम है, फैट की जगह पे थोड़ा पानी आया है। अब वो पानी क्या चीज है वो सोचेंगे बाद में, वो अलग चीज है, बट दिस इज नॉट नॉर्मल। और जब हमने कॉन्ट्रास्ट यूज किया तो देयर वाज एनहांसमेंट, स्ट्रेंथ की देयर वाज नो करेक्शन, यानी कोई टेरिटोरियल एनहांसमेंट नहीं था, बट एक डिफ्यूज एनहांसमेंट है। तो ये एक एब्नॉर्मल एरिया है। एब्नॉर्मल एरिया पहचान सकते हैं आप थोड़ा एब्नॉर्मल की फिल्म लगा के, वेरी उसी तरह से एब्डोमेन में मैंने बुक में देखा, इस तरह के एब्डोमेन में रखी हुई थी फोटो, हमें लगा यार ये तो बहुत अच्छा है, आप लोग सब पढ़ के आ रहे हो, हम आपको क्या पढ़ाएंगे। फिर मुझे लगा कि चलो थोड़ा सा और इमेज दिखा देते हैं, बताते हैं कि आप जब एनाटॉमी की किताब खोलो तो सिर्फ इस पर फोकस नहीं करो, इस पर भी आ जाओ और देखने की शुरू करो। यार फैट नहीं है, फैट सरफेस इमेज होगा, इसमें है, इसमें ब्लड फ्लो वाइट की जगह ब्राइट है। यहाँ ऑर्डा है ना, ये ऑर्डा है, तो ये फ्लो वाइट होना चाहिए था, यहाँ तो फ्लो कर रहा था, नहीं आना चाहिए था, बट यहाँ ब्राइट है। तो यानी हमने कुछ ऐसा सीक्वेंस अलग यूज किया होगा जो एमआरआई की खूबसूरती है, जहाँ पर कि हम एंजियोग्राफी भी कर सकते हैं इसके लिए। सो दीज आर द नॉर्मल एनाटॉमिकल इमेजेस जो हम लोग इस पे देखते हैं और पहचानने की कोशिश करते हैं। इफ यू गो थ्रू सारी मल्टीपल प्लेन्स में हमारे पास इमेज मिलेगी। कोई बात नहीं, तो उसी तरह से कोई बात नहीं, बट ये देखो अब एक थिक स्लैब हमने लिया है MRCP का, anyway, but we can understand। तो यहाँ पर आप देखोगे बिलियरी ट्री है, बिलियरी चैनल्स है, CVD दिख रही है, गॉल ब्लैडर आ रहा था, T2 वेटेड इमेज है, हेवी T2 वेटेड इमेज है। क्यों? क्योंकि बाकी सिग्नल काफी सप्रेस हो गया है। आप देखोगे कि इसमें T2 का इतना ज्यादा वेटिंग कर दिया है कि बाकी सबसे सिग्नल सप्रेस हो गया, सिर्फ पानी दिखेगा, और पानी दिख रहा है। बिलियरी चैनल की एनाटॉमी बहुत अच्छे से डिलीनिएट हो रही है, लेकिन साथ में क्या है कि एक फिलिंग डिफेक्ट है जो सर ने अभी दिखाया, अल्ट्रासाउंड में आपने देखा, CT स्कैन में गॉलस्टोन देखा, अभी MRI में देखिए गॉलस्टोन कैसा, ठीक है। सिमिलरली डिफरेंट एनाटॉमी इज देयर, एंड एनाटॉमी कितनी डिटेल्ड एनाटॉमी है, तो वीडियो चल नहीं रहा है तो हम लोग इस पर नहीं जा पाएंगे, बट डिटेल्ड एनाटॉमी आप इस तरह से देखो कि एक एक्सियल इमेज है नी जॉइंट का, और ये देखो ये पैटेला है, आप यू ऑल नो दिस इज द पैटेला, बट व्हाट इज इंपॉर्टेंट, आप इसके अंदर कार्टिलेज देखो, पैटेलर कार्टिलेज कितने अच्छे से आप डिफरेंशिएट कर पाते हो, सब कॉन्ट्रोल बोन प्लेट, द मैरो, then the cartilage and different anatomical ये different ligaments, muscles, आप पीछे की तरफ muscles देखो, सारे muscles आपको बहुत अच्छे से दिख जाएंगे, quadriceps tendon दिख रहा है। तो इस तरह से इतनी फाइन एनाटॉमी है, एंड एट द सेम टाइम मल्टीपल कॉन्ट्रास्ट क्रिएट कर सकते हैं MRI में। आप T1 देखते हो, T2 देखते हो, फैट सप्रेस देखते हो, कॉन्ट्रास्ट एनहांसमेंट देखते हो, आप फ्लूइड सप्रेस कर सकते हो, इवन इसी तरह से शोल्डर की इमेजिंग देखोगे, आप शोल्डर की इमेजिंग देखोगे तो सारी एनाटॉमी बहुत अच्छे से दिख रही है। सुप्रस पेनिटस मसल है, नीचे से उधर से एक्रोमिक्लर जॉइंट है, क्लेविकल को आप देखोगे, ह्यूमरस का हेड देखो, उसके अंदर की कार्टिलेज एनाटॉमी, द लैब्रम, ये जो है ना ब्यूटीफुल लैब्रम की आप देखो इस तरह से, तो इतनी ब्यूटीफुली एनाटॉमी सारी डिपिक्ट होती है। ये इमेज क्या है, ये इमेज फैट कैसा दिख रहा है, सबक्यूटेनियस फैट सप्रेस्ड है, इसमें फैट ब्राइट आनी चाहिए, चाहे वो T1 और T2 हो, ब्राइट आनी चाहिए, यदि वो सब, और हम लोग सब जानते हैं कि सबक्यूटेनियस प्लेन में फैट होता है, तो फैट नहीं दिख रहा है तो आप हमेशा बोल सकते हो, अपने आप को ज्यादा होशियार बता सकते हो, अरे ये तो फैट सप्रेस्ड इमेज है ना, तो फैट सप्रेस्ड इमेज में फैट नहीं है, बट आप देखोगे इंटरेस्टिंगली इस एनाटॉमी को देखो, ब्यूटीफुल ये फ्यूमरल हेड है और ये शाफ्ट है। यहाँ पर क्या है, ये ब्लैक है और ये क्या है, मैरो थोड़ी सी ब्राइट है, इसमें सिग्नल है। क्यों ऐसा है? बिकॉज एपिफिसिस में फैट होते हैं। एपिफिसिस में रेड मैरो होता है क्या? नहीं होता है, फैट रहता है, वो सप्रेस करेगा ही करेगा। बट ये रेड मैरो है जो नहीं सप्रेस कर रहा। सो आप इंटरप्रिटेशन देखो उसी इमेजेस से कितने तरह की फिजियोलॉजिकल पैथोलॉजिकल आप उसमें से निकाल सकते हो। अब ये तो सिर्फ वीडियो है, ये मैं ब्रेकिंग टेक्स्ट दिखाना चाह रहा था। कोई बात नहीं, इतना कॉन्सेप्ट तो समझ में आ रहा है ना, हम लोग कॉन्सेप्ट की बातें करते हैं। जो हमने बताया था एक लाइकोमा का केस है, सिंपल सी बात है। एक इमेज दी T2, एक इमेज दी T2, राइट, T1, राइट, फैट सप्रेस हो गया, एक ट्यूमर था। आप कॉन्फिडेंटली कह सकते हो ना कि लाइकोमा है, क्योंकि फैट सप्रेस सीक्वेंस में सप्रेस हो गया है तो ये लाइकोमा है। ये सप्रेस नहीं होता तो आपको तो लाइकोमा नहीं कुछ और होगा, सॉफ्ट टिश्यू सबक्यूटेनियस ट्यूमर होगा, नियोफाइब्रोमा है या डर्मेटोफाइब्रोसार्कोमा है, इस तरह से बहुत सारी है। लेकिन इसमें है कि सारे के सारे फैट थे जो सप्रेस हो गया, लाइकोमा है, आपने बोल दिया, डायग्नोसिस बना दिया। अब हर इंसान उसमें सोचेंगे कि अरे नहीं हमें बायोप्सी करना है, इसकी गिलोमिन करना है, वो अलग चीज है। लेकिन फिलहाल आप संतुष्ट रहोगे, पेशेंट संतुष्ट रहोगे, ठीक है। उसी तरह से इमेजेस यहाँ पर आप देखोगे, अगेन ये टिश्यू सॉफ्ट टिश्यू ट्यूमर था, ये स्क्रीनशॉट इमेज है जिसमें 4 तरह की इमेजेस है, सेम टिश्यू, सेम एनाटॉमी, सेम चीज, बट ऑल टुगेदर इन डिफरेंट पर्सपेक्टिव इन एमआरआई इमेज। एक्सियल T1 इमेज आप ये देख रहे हो, एक्सियल T1 प्री कॉन्ट्रास्ट, ये फैट सैचुरेटेड इमेज है, सबक्यूटेनियस फैट इसमें डार्क है। ये T2 इमेज है, ये ठीक है, और ये फैट सैचुरेटेड T2 इमेज है। सो आप सेम एनाटॉमी से, सेम मशीन से डिफरेंट तरह के कॉन्ट्रास्ट जनरेट कर रहे हो, तो देख क्या रहे हो, यहाँ पर ये ब्राइट था, यहाँ डार्क हो गया, मतलब ये फैट होना होगा। यहाँ ब्राइट था, यहाँ डार्क हो गया, यानी ये फैट होगा। लेकिन ये डार्क था, ये जब हम फैट सप्रेस करते हैं तो यहाँ पे ये ब्राइट होना शुरू हो गया, यानी ये इडिमा है, फ्लूइड भी है, फैट भी है। तब आपको लगता है ये सिंपल लाइकोमा नहीं है भैया, ये कुछ और है, ये है ना लाइकोसार्कोमा होगा, मिक्सॉइड लाइकोसार्कोमा होगा, और भी चीजें। तो आप उस तरह से सोचना शुरू करते हैं, ठीक है। ये एक देखो, एक बच्चे का ट्यूमर था, सॉफ्ट टिश्यू ट्यूमर है, एक सिग्नल है, यहाँ पे डार्क है, यहाँ पे भी डार्क है और यहाँ पे भी डार्क है। क्या क्या था? 2D इमेज ये है, ये T2 वेटेड इमेज है, ये हमारा T1 वेटेड इमेज है, ये एक है फैट सप्रेस्ड इमेज है, T2 वेटेड इमेज है। अल्टीमेटली क्या है, ये डार्क एरिया है। तो क्या क्या हो सकता है? हेयर हो सकता है, बोन हो सकता है, कॉर्टिकल बोन कैल्सिफिकेशन हो सकती है। ये आपका एक्सरे है, रेडियोग्राफ, देखो लॉट्स ऑफ कैल्सिफिकेशन। तो आप इसको बता पाते हो कि ओके ऑस्टियोसार्कोमा है, ऑस्टियोइड मैट्रिक्स है, पूरी तरह से इसमें भरी हुई है, और इस तरह के बॉडी डिस्ट्रक्शन है। इस तरह से हिस्टोलॉजिकल आप क्लासिफिकेशन कर पाते हो। लेकिन उस हिस्टोलॉजी के अलावा भी कुछ चीजें हैं जो हम कर पाते हैं। क्या कर पाते हैं? अब नई टेक्निक आई है जिसमें कि हम लोग डिफ्यूजन टेंसर इमेजिंग होता है। एक होता है जिसमें कि हम ट्रैक को आइडेंटिफाई कर पाते हैं, डिफरेंट ट्रैक्स को। एक ट्रैक यहाँ से यहाँ जा रही है तो उसको किस तरह से वाटर मूवमेंट हो रहा है मोलिकुलर। एक ट्रैक के अंदर सब डायरेक्शन में वाटर नहीं मूव करेगा, एक ही डायरेक्शन में करेगा। उसको फिट करके हम लोग पूरी ब्रेन की मैपिंग कर लेते हैं डिफरेंट ट्रैक्स की, जो आप थ्योरी किताब में पढ़ते हो, ब्रेन की किताब में पढ़ते हो और याद नहीं होता है। लेकिन वो सब चीजें अब दिखने लगी हैं, इमेजिंग दिखने लगी है, मार्क दिखने लगी है, एंड ईच एंड एवरी फाइबर्स कैन बी ट्रेस्ड with newer techniques of diffusion tensor imaging। और ये काफी हेल्पफुल होता है, जैसे एक्सटर्नल इंजरी, डिफ्यूज एक्सटर्नल इंजरी हो, एपिलेप्सी में कौन से ट्रैक इन्वॉल्व है, ट्यूमर है तो कौन कौन सा हम उसको ऑपरेट करेंगे तो कौन कौन से ट्रैक उसमें इन्वॉल्व हो रहे हैं, ताकि हम प्रोग्नोस्टिकेट कर सकें, पेशेंट को बता सकें पेशेंट को कि भैया ये चीजें होगी, ये डैमेज होगी जब हम इसको ऑपरेट करेंगे। तो ये एक नई टेक्निक है जो आई है और अब यूज धड़ल्ले से हो रही है, काफी अच्छे से हो रही है, वैलिड टेक्निक है। उसके अलावा एक टेक्निक है जिसमें कि फंक्शनल इमेजिंग करते हैं। फंक्शनल इमेजिंग क्या हुआ? आप कुछ सोच रहे हो, आप देख रहे हो, कौन सा एरिया स्टिमुलेट हो रहा है? ऑक्सीपिटल कॉर्टेक्स प्लस इंटायर विजुअल पाथवे। हमने बोला, आपने सुना, पूरी ऑडिटरी पाथवे आपकी स्टिमुलेट हो रही है। आपने हाथ हिलाया, पूरी आपकी मोटर कॉर्टेक्स तक एक पाथवे जा रही है स्टिमुलेट। लेकिन ये स्टिमुलेशन हो रहा है तो इसका मतलब क्या है? वहां पर ऑक्सीजन ज्यादा कम हो रहा है, दैट सेल्स आर वर्किंग, दैट सेल्स आर कंज्यूमिंग मोर ऑक्सीजन। तो जब उस ऑक्सीजन को जब वहां कंज्यूम कर रहा है तो वहां पर क्या होगा? हमारा हेमोग्लोबिन ऑक्सी हेमोग्लोबिन है, डी ऑक्सी हेमोग्लोबिन है, जस्ट एक कॉन्सेप्ट ऑक्सी। तो दोनों में डिफरेंट इन्वायरमेंट है और दोनों के सिग्नल अलग होते हैं, और उस सिग्नल को हमारी अब मशीनें जो आई हैं, जो हार्डवेयर आई हैं, उसको पिक करने की क्षमता है. They can pick up those differences and now they have the ability to map those areas जो एक्टिव हो जाता है. तो हम मरीज को अंदर गैलरी में डालते हैं, सुला देते हैं, समझा देते हैं, सिग्नल देते हैं, भैया उंगली हिलाओ, कुछ एरिया होगा. हम बोलेंगे भैया मूवी चला दिए, मूवी देखना शुरू किया. रडर इसमें था रिस्पॉन्स टू फेस, ये बुक से लिया हूँ, लेकिन ऐसा नहीं है कि न्यू है, बुक से लेने की बात है. मैंने इस इमेज को लिटरेचर से लिया, इसके पहले वाले को, लेकिन कल रात को बना रहा था तो हम लोग का वो कंसोल जो स्टेशन वर्क स्टेशन होता है वही नहीं खुल रहा था कि हमें ओरिजिनल इमेज ना. बट दीज आर नॉट समथिंग जो कि बहुत बड़ी चीज़ है. ये हो रहे हैं और हर जगह हर सेंटर पे होते हैं जहाँ पर कि हम लोग कुछ स्पेशल स्टिमुलेशन देते हैं एंड वी कैन मैप दोज एरिया. तो यदि अब्नॉर्मैलिटी है एंड यू कैन सी दैट दोज एरिया आर फंक्शनिंग और नॉट, तो आप उससे प्रोग्नोस्टिकेट कर सकते हो, थेरेपी प्लान कर सकते हो और ये कर सकते हो, एंड दैट इज कॉल्ड फंक्शनल इमेजिंग. सो एनाटॉमी वाज वन थिंग. हिस्टोलॉजिकल इमेजिंग क्रिएटिंग डिफरेंट एनाटॉमिकल कंट्रास्ट अनलाइक ए सिंगल कंट्रास्ट जो कि रेडियोग्राफ्स में होते हैं, उस दैट इज अनदर थिंग. एंड देन दिस इज गोइंग अप टू द लेवल ऑफ फंक्शनल पार्ट. फंक्शनल के अलावा और डीप पीएम मॉलिक्यूलर पार्ट में जाते हैं, दैट इज कॉल्ड स्पेक्ट्रोस्कोपी, जिसमें कि हम लोग ये देख पाते हैं कि क्रिएटिन किस में बढ़ गया, कोलिन किस में बढ़ गया, एनए किस में बढ़ गया, लिपिड किस में जाता है, लैक्टेट किस में जाता है. तो ये सब भी हम लोग अब एमआरआई के थ्रू करने लगे. सो दिस इज ऑल अबाउट द कंसेप्ट कि एमआरआई को हम कैसे यूज कर सकते हैं. एंड दैट आई थिंक कि आप लोग को इतना समझ में आया होगा कि इससे नॉन इन्वेसिव इमेजिंग मोडालिटी दैट ऑफर्स क्या एक्सलेंट सॉफ्ट टिश्यू कॉन्ट्रास्ट. इसके सॉफ्ट टिश्यू कॉन्ट्रास्ट का साइन यही है एंड वी कैन डिफरेंशिएट क्रिएट डिफरेंट कॉन्ट्रास्ट बिटवीन टू डिफरेंट टिश्यूज. It is non-ionizing, unlike the radiograph and the CT scan, जिसमें कि ionization का कोई drawback नहीं है, कोई side effect नहीं है. इसके अपने side effects हैं, but that is not the scope of this discussion. And multi-planar capabilities है, histological insight है, some functional capabilities भी इसमें है, and इसके साथ ही मैं ये बात कर रहा हूँ. Thank you very much.
Thank you very much, Dr. Shabir Narayan sir, for your illuminating session on MRI. We are deeply grateful for your time, expertise, and contribution to this CME. Now I request our honorable chairpersons, Dr. Ramkumar Sindha sir and Dr. Tejendra sir, to kindly come forward and felicitate Dr. Shabir Narayan sir. Please welcome. I know I now have the honor of inviting Dr. Vasudha ma'am and Dr. Nisha Yadav ma'am to kindly come forward and felicitate our respected chairperson sir, Dr. Ramkumar Sindha and Dr. Tejendra Singh sir for this gracious involvement and valuable support in today's session.
I request Dr. Shamrendra sir to kindly join us on the stage. I request Dr. Hari Singh sir to kindly join us on stage. Thank you. We are nearing the summit of an enriching day at 2025 CME on Imaging Anatomy, and I am delighted to welcome you to the 8th and the final session of the day. After exploring a range of imaging modalities in our previous sessions, we now focus on their comparative role in advancing medical education, a fitting conclusion to our academic journey. It is my pleasure to introduce our speaker for this session, Dr. Abhishek Dwivedi sir, Associate Professor at Snmc Agra, a distinguished expert in radiodiagnosis. Dr. Dwivedi's expertise in imaging modalities, coupled with his dedication to medical education, has made him a respectable figure in the field. Sir has completed his MBBS from BLPS Medical College, Karnataka, served as medical officer in Armed Medical Corps, and completed MD radiodiagnosis from Army Hospital, Delhi. Today he'll share his insights and compare the use of different imaging modalities to enhance the understanding of medical education, a topic that will highlight how these technologies can transform the diagnosis. Before we begin, allow me to introduce the chairpersons for this session, Dr. Anupriya Kumar and Dr. Manish Khurna sir, who will guide our discussion with their expertise and ensure a thought-provoking conclusion to today's program. Please join me in extending a warm round of applause as I invite Dr. Abhishek Dwivedi sir to podium to deliver his lecture. Dr. Abhishek sir will be joining us shortly. Thank you. how these technologies can transform our diagnostic skill. Sir has completed his MBBS from BLDS Medical College, Karnataka, served as medical officer in Armed Medical Corps and completed MD Radio Diagnosis from Army Hospital, Delhi. Before we begin, allow me to introduce the chairpersons for this session, Dr. Anupriya Kumar and Dr. Manish Khanna sir, who will guide our discussions with their expertise and ensure a thought-provoking conclusion for today's program. Please join me in extending a warm round of applause as I invite Dr. Abhishek Dwivedi sir to the podium to deliver his lecture.
Good afternoon, everybody. From the radiology department. So my topic is comparison of different modalities with the basic sciences, which the lecture is today. So now we can see these two structures, especially UGs. What you are looking here? Are they same or there is some difference between them? So if you don't have any basic idea that what a donkey and what a zebra is, then you can say that, like if you have only seen a donkey in your life or not seen zebra, you say that the donkey has been painted by some black strip on it. Similarly, vice versa. So if you don't know the basics, if you don't know the backbone, then the imaging sciences are of no use for you. It's like same thing, like a donkey with a stripe on it. So, diagnostic imaging needs what? Actually, anatomy is the backbone for the entire diagnostic imaging. Because if you don't know that what should be there at this place, you will never expect that what is wrong here. Then pathology, of course, because pathology means what is wrong here is the pathology. What you expect there normally is the anatomy. And then different kind of radiation, their physics, their interactions with matter. Because of that you get the images in the form of imaging. And the fourth is nuclear physics, even the most advanced version of the imaging, where you go for the molecular level. So like in the imaging sciences, we used to have our vision about two-dimensional and three-dimensional anatomy. So this can be done by different type of modulations or modifications in between the pixels. So there is one image which is known as MINI or minimal intensity projection imaging. Here we take the pixels of an image with minimum intensity, and similarly vice versa, there is another projection which is known as maximum intensity projection. So it's similar, like suppose a black and white picture is there with you, and you see something which is dark. So you have taken the darkest pixel is the minimum and the brightest pixel is the minimum. So the minimum is generally used for in CT imaging and even in different kind of imaging for looking for low density structures like ground glass opacities, mosaic attenuations, traction bronchiectasis, cystic lung disease. And similarly, maximum intensity projections are looked for bones. If you are pushing some contrast in the patient, the contrast will be brightest because of its iodine content, and that will be separated from rest of the background images by this projection. So these are the examples. Here you can see this is a minute image where the bronchi and their markings can be best seen, and this is the MIP or maximum intensity projection, where you can see that the place where contrast was given is only taken from this pixel, and thus everything is suppressed. And the third is this is a volume rendering. Right now it is something looking like the most natural form of the patient's body. Here you can see the blood vessels, their branches. This is actually arch of aorta. And similarly for the bone, we can see that there is a bony structure. This is a skull with a fracture in the left frontal lobe. So this is how you can use this imaging sciences. But if you don't know about the skull, if you don't know about which bone should be there, what are the real sutures, what are the fractures, then you cannot differentiate it is a fracture or not. Because you know that there is nothing, so you know that there is something wrong on this side. So this is the basic anatomy of brain. This is the most common anatomy to be, read or marked. The schematic image of the cut section of axial section of the brain at the level of basal ganglia and lateral ventricles and third ventricles. So similarly, this is the CT image. This is the real CT image of the same thing. Structures are same. Look somewhere black, like the CSF is black, the bone is white. So CT is somehow a replica of this anatomical image. It's a normal anatomical image. And this is an MRI image of the same. You see that CSF has become white because it's a T2 sequence. It's a different kind of modification. So, but this is an MRI image. And you can see even gray-white differentiation is better. But the structures are same. So if you don't know this thing, then you cannot understand what is there. So this is why that's the importance of anatomy. And today also, even with our interactions with our residents also, we say your report will be not concise and not peculiar if we will not explain which muscle is involved, which bone is involved, which particular thing is involved. And that is only by their basic sciences. That is by their first year knowledge. After that you can just read them, but you cannot mug everything at the last time. So here you see, like that was the last image, you see there is something wrong on this right side. So if you don't know that there should be everything dark, there is something white on this right side. This is an intrapericabral bleed in right temporal lobe. And this is a CT image where the bone is white and breast is dark. And this is an MRI image. Here we can see that there is something extra white on this side. And now it is suppressed. So this is a T2 image and this is a clear image, a modification of MRI images. And we can differentiate that there is something wrong, some kind of edema or some granuloma is there at this place, at left parietal lobe. So if you know the basic things, then only you can think of that what can be wrong at this place. Now, this is a very brief idea about CT brain. So CT brain is divided into two forms, like CT brain plane and contrast. So plane is the basic imaging, fastest and cheapest also, and there is no requirement of patient's creatinine or other things because contrast is an iodinated medium. So you need normal renal function test as well as there should not be any hypersensitivity with iodine or any kind of chemicals related to iodine. So that's why contrast is little bit complicated. So the plain brain imaging is generally done for all kind of emergencies, and contrast is reserved for particular conditions. So what we'll see here in the plain brain imaging, we'll see that the grey matter appears denser and thus brighter as compared to the white matter, and the bone will appear white, water and CSF, edema, everything will appear dark, air will appear super dark. Because they are not interacting with the X-rays, they are not radio back, because they are not interacting with the X-rays. They are not radio dense. So one rule is that, like, if the atomic number increases, this substance will become more radio opaque because they interact with the X-rays. So then there are some special studies done by the iodinated contrasts in the CT, similar like CT contrast. So they are another. Sorry, the slide has been skipped. So now, in the same way, tumor and infarction, they'll have edema, so they'll be darker on CT. Blood will appear, fresh blood will appear white, and then it will fade with its age. Similarly, contrast. We have put in iodinated contrast medium in the body via the intravenous route. So those all places will have increased density, and they'll appear radio opaque. And subsequently, the pathology is like, suppose we got a mass, and now there is vascularity in the mass, then that mass will pick up the contrast, and that's why it will become more radio opaque. So this is how we use contrasts. And similar like contrast, barium studies and special investigations. So generally, barium is reserved for all kind of upper and lower GI studies, where the gastric mucosa or the bowel mucosa is intact, where there is nothing wrong. So because of its higher atomic number and interaction with X-rays, it produces a radio opacity. So barium can be done for various kind of barium studies, like barium swallow for esophagus, then barium meal follow through for small bowel, and edema, that's for large bowel. Similarly, some other investigations like the contrast what we use in CT like iodixol, iodixenol or whatever. So here we use them in the plain radiograph, and these investigations are known as special investigations. So in these special investigations we have IVU, that is intravenous urethrogram, RGU, retrograde urethrogram, and MCU, micturition cystourethrogram, histosalpingogram, that is HSG, gastrographic study for operated patients like leucograms. So these are the examples. So this is a barium study. You can see contrast-specified material in the large bowel. So this is basically barium enema. With the double contrast, there is double contrast, that means some kind of air is also put here. And then this is a barium swallow, where you can see opacified barium in the esophagus. This is a hysterosalpingogram, where you can see that. So here we inject the contrast, or you say instill the contrast from the vaginal root, from the cervical os. And from here, this contrast goes inside the uterine cavity and goes in each tube. So these are the tubes. And then subsequently they spill off in the peritoneal cavity. So here you can see any kind of filling defect, that may be a fibroid, that may be a polyp, or any mass, or any kind of hydropyosulfates can be seen in the form of dilatation of the respective tubes. So this is the IVU. Actually, the urinary bladder is not covered in this diagram. So these are the calyces, then this is the renal pelvis, and this is the ureter on both sides. Here we inject the contrast in the patient's vein, and we will wait for the contrast to get concentrated in the kidneys and then get excreted by the renal system. And this is a retrograde urethrogram, where you inject the contrast, or we instill the contrast from the penile root, and it goes ascends up to the urinary bladder, and we can place this especially for the anterior urethra. And then we come into MRI. MRI is a magnetic investigation which is having excellent contrast result, especially tissue contrast. And here we use, what is the basic concept here in MRI is that there is a longitudinal magnetic field. When we just keep the patient in normal lying position in the magnetic field in the MRI machine, and subsequently we put another 90-degree magnetic field that is known as transverse magnetization. So this transverse magnetization is 90 degree from the body of the long axis of the body, and after that we switch off this transverse magnetization, and then the protons, because they are the maximum in the body, so they come back to their normal resting position, and two different sequences came in this, two different properties come in this picture, like your 63% of recovery of longitudinal magnetization is known as T1, and similarly 37% of the retention of the transverse magnetization is known as T2. These T1 and T2 are peculiar property of each tissue, so they will be different for each tissue, and they give the basic contrast in the MRI. So any substance which will have different T1 will have a different kind of contrast in the MRI, and these are then acquired and taken in the study. So there are then some more steps like gradients. Gradients are actually, like we have changed the angulation of the magnetic field and we have taken the signal. Similarly, we put some different degrees of magnets. Here, of course, in the today's scenario, the latest magnets are electromagnets, which are produced by the electricity. So we give various electricity in a different gradients to produce different magnetic fields, which gives even more contrast variation, and then they are mathematically calculated and reformed in the form of images. So here generally the general sequences which are used, or common sequences which are used in MRI are T1, T2, flare, stir, GRE, diffusion, and how they look like. So T1 is, of course, the water is dark. We have seen one image here. Here the CSF is white. So this is T2. Similarly, when this CSF is dark and you have been given an MRI image, that is T1. And similarly, the fluid is dark, CSF is dark, fluid is dark, protein, blood, fat, they all are high or they all are white. And on T2 images, say what I have shown you, that image, where you get white water or white CSF, and the grey matter will generally appear intermediate, white matter will appear dark. So in another way you can just mug it that because T1 is having a property of high signal on fat, and your white matter is generally comprises of myelin. So myelin is having fat. So your grey matter will be on the T1, your white matter will be even more whiter as compared to the grey matter because of this fat. So you can, this is how you can just remember it. Then flare is something like T2 minus water or CSF. So you suppress the background water signal or CSF signal to get better contrast is flare. Similarly, if you suppress the fat signal in NT2 image, it's a kind of modification. They are basically inversion recovery channels. So sequences where a different kind of angulation is done just to remove the background images. And then there is an image known as GR image. GR image is a gradient echo image. Here we give various gradient of magnetic field, and this is very sensitive for blood and calcium. So if there is any bleed, any calcification in the brain will be appearing darker on GR. And there is another modification of this thing known as SWI or susceptibility weighted imaging. Similarly, diffusion weighted and ADC image, they are actually couple images. So this TW and ADC, they are the best images. They are acquired in the minimum time, and right now they are very useful because they are the first to look infarcts. Any kind of tumors, especially a tumor with cytotoxic activity. There are two types of edema in brain. One is cytotoxic, another is vasogenic. So vasogenic is finger-like edema, and cytotoxic is a blunt edema, wedge-shaped edema, which is generally seen with tumors, aggressive tumors. And similarly, abscess. Abscess is having a property of very viscosity. They will not allow the water or the protons to move. So there is restriction of diffusion, and they also appear brighter on these diffusion weighted images. And cytotoxic edema is seen in generally malignant tumors, aggressive tumors. So these all entities can be seen on diffusion weighted imaging. They are not only used for brain, they can be used for the entire body. Right now, like there is a different system. When you use diffusion weighted imaging for whole body, you have background suppression, and this is right now used as a substitute of PET imaging for diagnosis of disseminated cancers. So this is the future version of this, and right now it is also used very well in India also. And then bone is generally dark on all sequences. Air is dark on all sequences in MRI. So that's why generally CT is better than MRI for looking for bones, fractures. But when you look for edema, that means again there will be water, increased permeability, leads edema, and in that condition, MRI is better. So osteomyelitis and all those conditions can be better looked on MRI. But fractures and any bony irregularity or any kind of architectural distortion will be better seen on CT. So now, the difference between T2 and flare. You see that this is image, this is a Photoshop image where we have removed the mustache or you say hairs or kind of hair. So this background hair is removed, and now you can see the mole here very well. Otherwise it was missed. So this is the use of flare image. Flare, you see that this is a T2 image and this is a flare image. Here we have suppressed the entire water here. So after suppressing entire free water, we get that this edematous areas are being more white and the rest of the things, everything is darker. So this gives you better contrast. It saves you a lot of time. Now we are coming to ultrasound. Ultrasound is a very, you say operator-based imaging, very cheap, very good, easily accessible, and like it's the first image for any kind of pathology when we start looking. Structures are generally same, but if you are better aware with the sectional anatomy, you can better think of that what structure will be there at this place and what I am looking for. So base of ultrasound is again anatomy, and without knowing anatomy you cannot go for better pathology detection. So the principle of ultrasound, everybody have just read that some electric waves becomes ultrasonic waves, and they goes inside your body, interact with your organs and come back, and that is again read into the electricity signal, and that is reformed in the form of images. So that is the basic concept. So how your ultrasound waves go and interacts with your body gives different type of attenuations, and these are the form of images what you are looking on ultrasound. There are different modes of ultrasound. A mode is amplitude mode, then B mode is the most common mode. A mode is generally 1D imaging used for eyes, where you just look for eye structures, and then B mode is generally what we use on regular day-to-day ultrasounds. M mode is for motion mode, that is for cardiac imaging, and similarly fetal cardiac activity can be best detected by this image. And then Doppler mode. Doppler mode, we even see the running structures by their color. So something which is going away. So this is a physics concept of Doppler, which says that if something is coming towards you, the frequency will increase, and going away, the frequency will decrease. So this change in frequency will give different kind of imaging in the reformed images. So now the next is nuclear scans. Nuclear scans are the today, like, it is a very old technique, but with the type of discovery of different kind of detecting equipments, now nuclear imaging is the most superior, most techniques. Without vision, you can diagnose a lot of things at the level of cellular level. So here, instead of putting the contrast what we were using for our radiological procedures, we use some radiopharmaceuticals, or you say radioactive tracers, and these tracers goes, and every tracer is having some particular property, like iodine for thyroid, tactinium for blood, sulfur is for blood. So similarly, there are so many substitute of, that means radiological substitute of some tissues which goes and hit on that place. Or if suppose if there is more activity at that place, it will be more shining or more colorful on that particular image. So this is a general concept of radioactivity in the nuclear imaging, and how these things are detected by different kind of cameras or different kind of equipment, such as gamma camera. This gamma camera becomes the gamma radiation which is injected in the form of radio pulses. Then single photons, that is SPECT. Then PET is the positron emission tomography. And now even more advanced version like PET-MR has also come. So they all are hybrid images with modification and greater resolutions. So this is the gamma camera. Patient has been injected contrast inside the radio contrast, say, or radio tracer inside the patient's body, and then gamma camera picks up the activity. When the activity will be most, that means there is something wrong. But suppose I am giving the example, like in Meckel's diverticulum. Meckel's diverticulum, somebody is having pain in the abdomen. On an ultrasound patient went to the doctor says something, some loop kind of thing, or some inflammatory thing has been found in pelvis. Right now he is confused with appendix and Meckel's. And then they went for CT also. Then they again found something. They are not very clear because of that inflammation that it is appendix or it is a diverticulum or not. So now, because Meckel's diverticulum is having a property that 60% of it is comprises of the gastric mucosa. So gastric mucosa has a tendency to take tactinium perstactinate. So with the gamma camera, we inject this chemical inside the body, and we see that this is picked up by the stomach, and then something is wrong in the pelvis also. Like it is picked up on two different spots, one in the stomach and another is in the pelvis. So it shows that there is another activity in the pelvis. So without invading, without doing any FN or any colonoscopy or whatever, or any exploratory laparotomy, you have reached to some kind of diagnosis that this is something wrong with the gastric mucosa kind of structure in the pelvis. So this is how Meckel's diverticulum can be picked up. And right now with evidence-based medicine and with medical insurances, now the policies and people are more prone for going for non-invasive procedures, and that's how the basic knowledge of nuclear imaging is required. Similarly, SPECT, the brain death, you've seen hot nose side and all that declaration of dead brain, and similarly traumatic brain injuries. So they are done by various tactinium compounds injected inside the body. And then PET scan. PET is right now like for any kind of disseminated cancers. a kind of FDG PET, that is deoxyglucose PET. Here a substitute of fluoride or a radiotracer fluoride is used for detecting of the dissemination of the cancer. So here you see that this is a PET image, whole body PET. The best is you see the entire body. So this is best for the imaging and staging of the patient. You got a mass in kidney or you got a mass in liver, and you think that this is the primary. Now you have to stage that cancer. So you have to go for the PET. The PET shows that the brain is not having any special activity. There is some kind of high activity in this liver, then in the right kidney. So you think of, and the entire pleura is also like green structures. These are the lymph nodes, then the left axillary lymph nodes. So these all things are picked up and even color coded. So you can see that there is some high avid or FDG avid lesions. So this is kind of dissemination. Similarly, bone scan, what gamma camera used. So here we put bisphosphonate derivatives of the bones. They are radioactive bisphosphonates, which this is a CA prostate image. But you can see that this is picked up by the parotids, and thyroid, and even the bones, multiple vertebrae, and bladder. So you know that every kind of contrast will go through the bladder. So this is a normal excretory thing. So this is not abnormal, but remaining are abnormal. This even on this left humerus. So this is your spectacle where we are looking for a healthy patient with minimal or little pickup in the cerebellar areas and some areas in the brain stem. But in post-traumatic disorder, we see that more due to contusions. And similarly, traumatic brain injury, we see that the pickup is reduced. Classical traumatic brain injury or brain death, it will be reduced. So this is how we differentiate different elements without going inside. Now this is a secondary image. This is an anatomical image of the brain, where you see all things: your frontal lobe, cerebellum, occipital lobe, cerebellum, and your brain stem. So all things are here with your sutures. And now you just fissures. And now you just see the CT image of the same patient. So you see this parrot-like structure or the bird-like structure is the brain stem. This is the corpus callosum which you see here and here. So if you don't know this thing, going and having this thing is not very fruitful. So basic idea of the anatomy will always help you. And then you go for MRI, you see even better contrast resolution, even better images. But the basic anatomy is same throughout. Then what are the investigations and how they can be used? So ultrasound is the first and of course basic investigation, cheap, fast, operating based, no radiation. But there is a point like right now, even there is a theoretical thing in medical literature. It says that there is increase in the temperature of the fluid. So especially in fetal imaging, this is important to keep the contact time minimum, and there is a concept known as LRR, as low as reasonable. So right now this concept is followed, and we cannot just keep imaging for hours in ultrasound also. But still it is very safe, or you say there is no evidence of any kind of teratogenic effect by the ultrasound so far. Then radiograph, of course, 2D imaging, primary imaging for bone and skeletal system, cheapest everywhere available. So again, and then CT. CT is the fastest 3D imaging on the earth. You cannot miss any kind of medical or surgical emergency by CT. A single investigation which can be kept from Kashmir to Kanyakumari, I think is CT. CT should not be. Look, there is a radiation hazard, but you see the benefits, pros and cons. Then CT will never miss any kind of bleed. Any kind of bleed. Generally, all the parts are also picked up. Any kind of abdominal trauma, any kind of pneumothorax, pneumoperitoneum, pyoperitoneum, ruptured appendicitis, whatever you think of, bone fractures, pulmonary edema. So you just think of any kind of thing. Even right now, cardiac things are also picked up on CT. So most of the things are now picked up on CT. With the discovery of the latest techniques or models, above 16 slides, 64 and above. They are so fast, and now we are even in our medical college we have 128 slice CT, which can scan entire body in 6 seconds. So this time of and even at higher centers right now, the protocol is there that if some patient is coming for trauma, so they just say whole body CT, and within 6-7 seconds they are done, because every time you cannot mobilize the patient with so many fractures and so many things because of stability and all those things. And even bedside CT has also been available in AIMS, Gangaram and all the big hospitals. So this is how CT is the fastest. The only thing is, of course, that this is having radiation hazard, even 100 times, generally 100 times more than X-rays. And the other is, of course, contrast, which is used here for the patients with kidney disease and allergy to iodinated mediums. They are avoided. Then MRI. MRI is the best modality for contrast, for tissue contrast. You can differentiate each and everything, nerves, muscles. Just like in anatomy, you are dissecting everything and you see this is a nerve, this is a blood vessel. Same in MRI, you can see everything. If somebody is saying that we cannot see that, if the patient is like there is a problem with MRI, then it takes a lot of time. So patient is having a tendency to move. If there is a kind of motion artifact, then that is a problem. Otherwise, you see most of the things without invading is the MRI is the best thing. But the only problem is that it takes a lot of time. Then the machine is so bulky that I say 30% of the people are having claustrophobic problems, including doctors also. So that is a common thing, and people avoid it. But this is the best thing for reaching up to a substantive amount of diagnosis for surgeries. This is a very important modality, especially for brain, then for hepatobiliary system also. This is one of the best. And of course, MSK, MRI is I think is the final thing. After that, arthroscopy or direct visualization by the surgeon is the only option. Otherwise, if you want a non-invasive procedure, MRI is the ultimate thing for all kind of musculoskeletal things. Then nuclear imaging. Nuclear imaging I have already explained. That there is so much of utility, and pioneers like Dr. Hajra, who has been here. So his work has been seen in the world from so long. So this is right now the only problem is in places like Agra, it is an emerging branch because of these all bigger modalities or bigger equipments. So this is a costly thing. Otherwise, this is widely used by all kind of doctors, especially all super specialists. They are using it for the malignancies and for final diagnosis. And pathology is you say that never dying science. It cannot finish, and final diagnosis is given by pathologists only. Last landing is on pathologists. So if you don't have knowledge of the basics, you say these all are same. Are you sure? Which one is what? All are cats? Or this person is with this kind of black lining in his eyes, has been imported from some foreign country to India. So this is Mr. Cheetah, which was lost. Now African cheetah is in India. We lost our Asian cheetah, that is only remaining in Iran. But this is the only last remnants of that. So this is jaguar, this is leopard. So everything looks like same, but if you don't know about the anatomy, you cannot think of that. And finally, what generally you have to do after getting your PGs and all that, especially in imaging sciences, you have to see or spot the difference. So for this spotting the difference, you know the basic, that from which thing I have to differentiate it. So you have a basic image and then you differentiate what is missing from here. If you don't know this, so this is your anatomy. If you don't know this, you cannot think what is wrong here. So that is why anatomy is the basics. And basics means the building block of most of the sciences which you use in your later version. You want to become surgeon also, without anatomy you cannot be a good surgeon, neither gynecologist. And finally, we were very fond of general things, but we were like running from the brain anatomy in our UG days. We were just running off, this is very tough and all that, and head and neck. But unfortunately, with kind of training, we have gone through and imbibed everything. So the better you can imbibe your UG days is the best, because after that your understanding for higher subjects will be very easier. It will make you differentiated from, especially this happens with the place where I have been trained. So people from FMC were also there, and I have seen the way their anatomy was. They were too good, and that was because they have given so much of influence in their basic sciences. So this is how you can become better. So similarly, your physiology, you will be having good physiology ideas, everything, then your medicine will become very easy for you. So your basic sciences, you cannot skip them and become a good doctor. So finally, you have to be serious at this stage. So everybody is having different idea. Any questions, anybody?
Thank you very much, Dr. Abhishek Reddy sir, for your thought-provoking and enriching session. We are grateful for your valuable time. Now I request our respected chairperson, Sir Dr. Munish Khanna sir, to kindly come a step forward and felicitate Dr. Abhishek Reddy sir. I now take the opportunity to invite Dr. Pradeep sir and Dr. Kamal Rajah sir kindly come forward and felicitate our respected chairperson, Dr. Munish Khanna sir, for their valuable contribution in this field.
I request Dr. Anita to join the podium. She was also a chairperson.
Okay. Thank you, sir and ma'am. Thank you, Dr. Prem Singh, Dr. Reena, and Dr. Vasudha for chairing the session. Okay. Now I'll invite upon Dr. Viren Kumar Nim. He has been so patiently listening the sessions from the very morning. I'm so thankful, sir. To please present the prizes for the poster presentation winners. The first prize was won by Dr. Shalini Singh. The second prize was won by Dr. Varun Upadhyay. And the third prize for the poster presentation goes to Dr. Yatharth Mishra. Thank you, sir. Thank you so much. And now I'll invite upon Dr. Tejinder to please felicitate our organizing committee. First of all, I'll ask Dr. Anshu ma'am to please come up. She was the organizing chairperson. Her efforts are all what we can see from the morning. She is working day in and day out for this event. Now, sir, please stay back. Sir, please stay back. I'll invite upon Dr. Shikhi ma'am to please come up. Ma'am, abhi bahut I want everyone. Don't worry. We like to felicitate Dr. Pradeep Singh, the organizing chairperson. His unceasing support for this event has made it successful. He has been arranging all the logistics and everything, working very hard. Dr. Munish sir to please come and felicitate Dr. Anjali ma'am. She has been the backbone behind the scenes, working very hard, giving her precious suggestions and advices to make the event even better. And again, Vivian sir, please. I'll invite Dr. Vibhu ma'am to come up. She is the organizing secretary and helps out on various occasions. Dr. Kamal sir is, I guess he has left, but I would like to thank him. He was the man behind all the treasury, looking after all the management of the monetary funds. We can clap for him. Very now, information. Meanwhile, while we are looking forward for Dr. Kamal sir to come back, I would like to also thank all the PG residents. They have been working very hard. In fact, they have been working very, very hard. They were untiring sessions of everything, so many revisions, rehearsals, and they are the support behind the scenes. And I would also like to thank the collectors for their certificates will be distributed. You can collect your certificates. Okay, okay, I'll invite now Dr. Viren sir to give me a moment. I was the registration. Clients, I would like to invite upon Dr. Vibhu ma'am to give the vote of thanks. A very good evening to everyone. It is with great honor and joy that I should before you today deliver the vote of thanks on the behalf of Anatomy Department for the successful conduct of CAB which is conducted today. First and foremost, I would like to express my deepest gratitude to our distinguished speakers. Your sessions were informative, thought-provoking and incredibly relevant to our practices. The depth of knowledge and shared the clarity with which you present it has surely enhanced our understanding. I would also like to thank our chairperson who helped guide the flow of event with great professionalism and ensure your session stayed meaningful and engaging.
To our delegates and participants, thank you for showing such a keen interest and actively participating. Your insights and enthusiasm help on create a dynamic and interactive learning environment. I extend my sincere gratitude to our organizing committee for their tireless effort in making this event a resounding success. Your dedication and hard work are deeply appreciated. I also want to thank to all PG students, UG students of batch 2024-23 and 30. You worked hard behind the scenes to make sure everything went smoothly for planning the session and arranging the logistics. Your dedication and teamwork made today's success possible. We are also thankful to our technical staff team and our supporting staff and anatomy department whose tireless effort ensured the smooth execution of this program. At last, let us carry forward the knowledge and inspiration gained today to further our collective mission of excellence in healthcare. On the behalf of Department of Anatomy, I once again express my deepest gratitude to all who have contributed to this enriching experience. Thank you all of you who support your have wonderful evening. Thank you. Thank you so much, ma'am. Dr. Kamal sir. Dr. Kamal sir would like to please proceed to the stage. I would like to request Dr. Shekhi ma'am to kindly felicitate Dr. Kamal sir.
Sir.
Thank you so much sir for your constant support and efforts. Thank you.
चेयर खड़ा होना पड़ेगा और पीछे मैम फर्स्ट Yes, close. On मेरे पास है. Thank you. चलो फोन को फोड़ देनी है.
कैमरे की
Right.